And we'll start on page 35, lab values. You have to know your lab values. But the good news is you don't have to know them all. Just certain ones that everybody else knows. Well, there's kind of more bad news, and that is not only do you have to know lab values, but you have to know which lab values are more dangerous than what other lab values. So if you knew 10 lab values, you need to know which ones are high priority, which ones are middle priority, and which ones are low priority. Because they will ask you to prioritize people according to their lab values. Like they'll give you 4 different patients, a patient with a potassium of 7.4, potassium with a pH of 6.8, a person with a hemoglobin of 10, and a person with a BUN of 54, and they want to know who's your highest priority patient. That kind of thing. So it's not good enough just to know the values themselves. Because they will give you 4 people, all of them have abnormal lab values. All of them do. So what you have to do is then rank them, on who's highest, who's lowest priority. So what I want to do is teach you that, because I don't believe any school I know of teaches students how to prioritize lab values. They teach you the lab values. They teach you the numbers, the ranges, what's normal, what's abnormal. They teach you what high means, what low means. They teach you the significance of the test, but they don't teach you that a hemoglobin of 7 is a higher priority than a person with an INR of 3.4. Do you see what I'm saying? They don't get to that. Now, am I mistaken? Are some schools doing that? Are any schools doing that?
They pretty much use that potassium, but that's about it.
They just say potassium's bad.
Yeah.
And that's probably on boards, that'd probably be the least you should know, at least that. But, I'm going to give you a scheme here. Do you see the legend at the top of the page where it says A, B, C, D? A means that it's not a priority. It's a low priority. It's not a big deal. Yes, it's abnormal. The lab is abnormal. But really, there's nothing you need to do about it. In fact, in real life, what I'm going to do is, let me back up. What I'm going to do is, for every lab value I give you, I'll tell you whether the abnormal is an A, a B, a C, or a D. I'll assign a priority letter to it. Are you understanding where we're headed with this? And when I tell you that a lab abnormality is a level A, what I'm trying to communicate to you is that yes, it is abnormal. And yes, it could mean there is the presence of disease. But in the scheme of things, this is really no big deal. In fact, you don't have to do anything about it. In other words, if a lab report came back and it's an A level, you could ignore it all night long and have the doctor discover it in the morning, and you wouldn't be in any trouble for having that happen. Do you understand what I'm saying? However, if I tell you it's a C level C, letter C, and you do nothing about it all night long, and the doctor finds out about it in the morning, you are in major trouble. So I'm trying to give you a feel for how important it is that you must report these or do something immediately. So an A is abnormal, yes, but you do nothing about it, it's no big deal. A letter B, it is abnormal and you need to be concerned, but there's nothing you need to do. You just kind of watch them closer. Have you had the experience where you had a lab value that was abnormal, but it really wasn't all that bad? So you didn't have to do anything, but that lab abnormality said to you, watch them closer, watch them closer. That's what I'm trying to tell you a B is. When I tell you that a lab value is a C, we've now crossed a line from low priority to high priority. When a lab reaches a C value, it is critical. You must do something about it. You can't just sit on that lab value and do nothing. If I tell you that a lab abnormality is a D, I'm trying to communicate to you that it is the highest priority that you can possibly have with a lab value. So what's the lowest priority?
A.
Followed by And then what are two high priorities? And the highest of all is D. Okay, just so everybody know where we're headed here. Okay, now, let's start into this lecture. In the first column, there's the name and anything I want to tell you about it. In the middle column, you'll write the range, the normal range. And in the last column, we'll assign the A, the B, the C, or the D. Alrighty? Let's talk about creatinine. I told you 2 days ago that it is the best indicator of kidney or renal function. Now, in this case, I am talking about the serum creatinine because they will not give you the values for a creatinine clearance, 24-hour creatinine clearance. They aren't going to test you on that, but they will test you on the serum creatinine. Now, the serum creatinine is 0.6 to 1.2, which is actually the same numbers as the lithium range. If you recall that from yesterday, the lithium and the creatinine are the same range. Okay, in the middle column, you have that. In the last column, an abnormal creatinine is just a level A. You would never prioritize a person with a high creatinine as your highest priority. Now, do they have kidney disease? If they have a high creatinine, yes. But are they going to die in the next 4 hours? No. The next morning, the doctor could come in and go, oh, his creatinine is high. He must have kidney disease, and that's fine. You're not going to be in any trouble for it. Probably the only time that I would ever make a high creatinine something that I would actually make a phone call to a doctor about is if they were going for a test that had a dye in it that next morning. Like, for example, if they're having a cardiac catheterization where they put the dye in, if the question tells you that they're to have a dye procedure in the morning, I might make a high creatinine something that I would report, but it wouldn't be in the next hour. It would just be sometime, like for example, if you got the high creatinine back at midnight, I wouldn't call the doctor till 5 or 6 in the morning at the earliest. I might wait till 7. I certainly wouldn't call him at 1 in the morning. But there are certain lab values you're going to see where you call them right away. So this would, even then, it wouldn't be a super high priority, but it would be higher than just a plain high creatinine. Does everybody understand that? Okay. The INR, the International Normalized Ratio, it monitors Coumadin therapy. It's like the PT. It's a variation of the prothrombin time. Its normal range should be 2 and 3, in the 2s and 3s. In other words, you want your INRs to be in the 2s and the 3s. Like 2.1, 3.8, that's what you want. In the last column, anything that's above 4, or 4 and above, is a C, which means it's high priority. You have to do something. This is not one you can ignore. You can ignore the creatinine, but you cannot ignore this one. An INR of 4.2 would be a higher priority than a creatinine of 30. Now, when I assign something a letter C, what do I say are the implications of that? It's critical and you have to what? Do something. Now, the question you should be asking is, well, what's the do that I should do? Well, whenever you get a situation where they want to know what are you going to do about something, there's a protocol you need to follow, an order, because this would be a click and drag. You always hold. That's the first thing you do. What do I mean by hold? If there's something that's causing a problem, stop it first. After you hold, then you assess. What would you assess? a whole, complete, head-to-toe physical exam? Yes or no? No, a focused assessment. Focused on what? The area that the lab value is telling you there's some problem with. But do a focused assessment. Then you prepare, which means you prepare to give. Now, you don't always give, but you prepare to. And after you prepare, then you call, meaning call physician, or call respiratory, or call whomever is appropriate. But before you call the physician, you always hold, assess, and prepare. Now, if we apply this to the INR of 4.7, let's say you get an INR of 4.7, and they want to know what are you going to do, in what order, and you have to click and drag. What would you click first? Hold what? Hold Coumadin. Hold all Coumadin. Then what would you do? Assess for what? Bleeding. Then you would vitamin K, prepare to give vitamin K, and then you would call your doctor. In that order. Now, sometimes there may be nothing to hold. Do you understand what I'm saying? There's nothing to hold. There's nothing causing a problem, so you jump immediately to what? Assess. And sometimes there may not be anything to prepare, so you jump to call. But you should intellectually go through that process with everything you do something about, so that you're thorough, so that you don't miss a step. All right, potassium. Potassium, there's nothing I want to say about it in the first column, except that it's not really a good indicator of anything, but it is an indicator that something's wrong, but you don't know what. Its range is 3.5, and then flip it around 5.3. 3.5 to 5.3. Now for Hesse, it's 3.5 to 5.0. For Hesse, it's 3.5 to 5.0. But for boards, it's 3.5 to 5.3. Why? Why the difference? Boards is a nationalized. Hesse uses whatever Elsevier lab book says. Okay? So, to Hesse, a 5.1 potassium is an elevation. On boards, a 5.1 is not an elevation. Now, let's talk about the last column. A low potassium, meaning lower than 3.5, is a C. You have to do something. Okay, now let's go through our protocol. If your potassium is low, is there anything you have to hold? No. So what do? But what are you assessing? What's your focus? Heart. Assess heart. Prepare to administer vitamin K. Potassium. I always do that. I always used to do that. Anybody ever do that? Vitamin K and potassium K? I screwed that up for like 10 years. Okay, and then I what? Call the doc. All right. What if it's between 5.4 and 5.9? That gets a C. So now you have to do something. Well, is it high or low? High. So what do you think we would first do? Hold all potassium. And that may mean ripping down the D5W with 20 of KCl. You know what I mean? Getting that torn down. Then you assess the heart. Then you... What? Now, Lasix does make you lose potassium, but we don't give Lasix for the purpose of losing potassium. Kxalate and D5W and regular insulin. Remember yesterday? Kxalate and D5W and regular insulin. And then you call your doc. However, in the last column, if the potassium is greater than or equal to 6, it's a D. It is deadly dangerous. This person could die soon, like in the next 2 minutes. So what do? You do everything we just said. You rip down the IV, you assess the heart, you prepare the D5W, regular insulin, and the K-oxalate, and you call your doctor. You do all that what? Stat. So how many people have to be involved? You probably got one nurse ripping out the what? Potassium. You got somebody calling for an EKG coming. One nurse is preparing the D5W and regular insulin while the secretary's calling the doctor's stat. You see what I'm saying? And you stay with your patient. Got it? Because you can't leave the bedside of a D. You understand what I'm saying? Can you leave the bedside of a C? Do you even know what I'm talking about? D's and C's. Okay, got it. Okay. Can you leave the bedside of a C? Yeah. Can you leave the bedside of a D?
Nope.
No. So one of the things you're going to have to remember when you're answering these D questions is you stay at the bedside and you do what you can do at the bedside, but everybody else helps you do everything else. You don't run out and get the EKG and leave your patient by themselves with a potassium of 7, okay? Now, I'm not saying you do this in real life. You should do it in real life, but I'm saying this is what the book wants you to do. And really, if you really did this, you wouldn't get in trouble. Your patient would be in good shape. Okay, the pH, 7.35, 7.45 is the range, which you told me the other day. In the last column, the only thing that matters is a pH in the 6s is a D. Now, I don't mean 7.6. I'm talking about 6 point something in the 6s. Now, you notice that do you notice with the creatinine, I didn't talk about a low creatinine. Did you notice that? And in an INR, I didn't talk about a low INR. And here I'm not talking about a high pH because those aren't that clinically significant and they're not usually tested at all. You see what I'm saying? These are the things that are tested over and over and over again. So rather than have you learn everything, let's focus on what's essential. Alrighty, pH in the 6s. So what do? Is there anything to hold? I can't think of anything. What would you assess? Now this is interesting. What do you think you'd assess? Somebody said respiration, somebody said pulse. There you go. Lump them together, check your vital signs. Because the pH is going in what direction? Down. And as the pH goes, so goes your patient. So the patient is going to be going what? Down and out. And you're checking, with a pH in the 6s, to be totally transparent and honest with you, you're doing the vitals to make sure they're still alive. I know that sounds ridiculous, but you really are. Because, usually when you have a 6, you're dead. So you're just making sure they're alive. And then is there anything to prepare? Not really. Used to be, years ago, because they were severely acidotic, we would prepare bicarbonate to give bicarb, but you don't do that anymore. You don't indiscriminately give bicarbonate. Like, if you've ever been taught that, no, you don't do that. You don't give bicarb anymore to acidotic patients because it confuses the whole issue. The key is to correct this acidosis. The only way you can correct it is to treat the underlying cause. And there is nothing a nurse can do to treat the underlying cause. The physician has to get here, determine the cause, and treat the cause. So, with a low pH, you have to get the physician in on the case faster than anything else we'll talk about today. So, that's why you just assess their vital signs and you call your doc. And you skip hold and you skip prepare. Now, why are you getting the vitals? Because when you call the doc, what are they going to say? Is he alive? Is he breathing? What's his heart doing? So get a set of vitals. That's all you need. Set of vitals. Call the doc. And you stay. So who gets the vitals? You do. Who calls the doc, maybe some, put on the light or whatever, and however you communicate to your unit secretary, and have them call stat. Okay, BUN, blood urea nitrogen, BUN. It has a lot to do with nitrogen waste products in the blood. Its range is 8 to 25. 8 to 25. The way I remember that is BUN spells what English word? Bun. Buns, like hamburger buns, hot dog buns. When you buy hamburger buns or hot dog buns, how many are in the pack? 8. There's your 8. Buns, 8. 8 to 25. And if the BUN is elevated, it's no big deal. All you do is assess them for dehydration. Assess them for dehydration. By the way, a little hint. Good guessing strategy here. If they give you an elevated blood value and you have no clue what's going on, and they ask you, for what would you assess them? Dehydration is a great answer. Because when you dehydrate, what happens to all blood values? They go up because of concentration. So it's just a really good guess to say, when the BUN's up, I don't know what it is. Well, pick dehydration. Good answer. You may be wrong, but it was a good answer. Might not have made the top 10 surveyed, but it's not bad. I don't know why I had an extra L on the end of elevated, but Hemoglobin is the next one. It's 12 to 18. Now, I know it's 12 to 16 for women and 14 to 18 for men, but for humans, it's 12 to 18. And boards doesn't get into lab values versus men versus women, children versus adults, newborns versus. They could be on your test, but those are really hard questions, and you do not have to get those right. But if you don't know a normal adult hemoglobin, you're in trouble. Okay. If it's 8 to 11, if the hemoglobin is 8 to 11, it's a B. And you would assess them for what? Low hemoglobin. Anemia, a bleeding or malnutrition. If the hemoglobin, however, falls below an 8, it's a C, and you must do something. Okay, well, what are you going to do? You going to hold anything? Not that I know of. You're going to assess for bleeding. You're going to prepare to administer blood, and you're going to call the doctor. Now, LPNs, you would prepare, but you would call, not on this, but on everything where we've said call doctor, you could substitute notify RN. Do you see what I'm saying? You could, wherever this could say hold, assess, prepare, notify RN. Alrighty? Bicarb. The bicarb is what? 2 plus 2 plus 2 equals 6, right? 22 to 26. And an abnormal bicarb is an A. We don't care. So what? I've never, in 37 years of being a nurse, I have never been yelled at by anybody because I didn't tell them what somebody's bicarb was. It's just not a major issue. Okay, CO2, carbon dioxide. This you are getting from an arterial blood gas, by the way. The normal range is 35 to 45. It's the same as the pH, just dropping off the 7 point, correct? In the last column, a CO2 that's high, but in the 50s, like 51, 57, 56, 59, those are C levels. That's a C, which means it's critical. You can't just sit on it. You got to do something about that. That's not good. Now, I want to say a disclaimer. I'm not talking about COPD clients here at all. that changes everything. This is for people without COPD. So what do you do? Well, is there anything to hold? A high CO2, anything to hold? I don't think so. What would you assess?
Respiration.
Respiratory status. Now, when it comes to prepare on this one, there is actually something you can do. There is actually something you can independently, as an LPN or an RN, do. What would that be? Okay, breathing in a bag actually recirculates the CO2, so we don't want that. That would be raising the CO2. What's that? Oxygen is used for low oxygen, not for high CO2.
Navel down,
What's that?
look down like on your thumb, where you're, I've read that if you actually put your thumb in your mouth and blow.
Oh yeah. Okay, like your Or they'll say the candle. This is a candle. Blow out the candle. That is called pursed lip breathing. Have you heard of that? This is what you're going to pick. Pursed lip breathing. Because with pursed lip breathing, you're prolonging the exhalation. And if you prolong exhaling, you're getting rid of CO2. Now, most of the time, that will correct the problem, so you never have to move to what? Call. How do you know it's going to correct the problem? They will breathe easier. Because when they're in the 50s, it's going to be dyspneic. They'll be dyspneic when their CO2 is in the 50s. So that will solve that problem. However, what if the CO2 is in the 60s? That's a D. That's one of the criteria for making the diagnosis respiratory failure. Have you heard of respiratory failure? Well, how do you know someone's in respiratory failure? Well, one of the ways you know is the CO2 is 60 and above. Now, here again, we're not talking about COPDers. So this is a medical emergency. This is a super high priority patient. So you do not what? Leave the room. You stay with them. So is there anything to hold in this case? Nope. Assess their respiratory status. Now, pursed lip breathing isn't going to cut it. Now, I will probably do it with them just to decrease their anxiety and maybe take the edge off of it. But I'm going to have to prepare for what? Two things, because they're in respiratory failure. Intubate and ventilate. So you prepare to intubate and ventilate. And then who do you call? There's two people to call. Who do you call first? Respiratory therapy first. Call respiratory therapy first. Then call the physician. But you stay with your patient. Yes?
At that point, would you also call the emergency response team? Or does that come later?
Like a code?
Well, like a pre-code.
A pre-code? Yeah. On boards, they really don't have anything that's called an emergency response pre-code team. They don't. Certain hospitals have that, some don't. And because it's not a universal phenomenon across the nation in every hospital, they won't even go there. But I would say if I were you and I had one of those teams at my disposal in a hospital, yes, at this point I would, because this person's going to end up on a vent. And that's the best that's going to happen. You know, the worst could happen before. So, yeah. All right. Hematocrit. Hematocrit is 36 to 54. 36 to 54. Now, I don't remember that. That's why I had to think for a few seconds before I said it. I never remember that. Because that's a clumsy number, 3654, it's just sloppy. Well, it's 3 times the hemoglobin. So whatever the hemoglobin is, multiply that by 3, and that's why I had to do the math in my head there for a second before I told you. So 12 times 3 is 36, and 18 times 3 is 54. So it's 36 to 54. Okay, an elevated hematocrit. An elevated hematocrit. It's abnormal, it's a B. An elevated hematocrit, what would you assess for? Dehydration, good job, dehydration. But it's no big deal. Okay, let's talk about the oxygen level, the PO2, the oxygen level. Here again, you're getting this from the arterial blood gas. This is not what you're getting when you put on the pulse ox on their finger or their earlobe. That is not the PO2. The PO2 is from the blood gas. Now the PO2 normally should be 78 to 100. 78 to 100 is the normal range. If it is low, but still in the 70s, like 70 to 77, that is a C, which means you have to do something. It's critical. So, is there anything to hold? No. You assess what? Respiratory. Now, there is something you can do, both LPNs and RNs, without a physician's order. And what is that? Give them oxygen, because their oxygen is low. So now you give them oxygen. And 9 times out of 10, what will happen? Will it correct it or not? It will correct it, and you will not have to call your physician. And how will you know it corrects it? Because you're not having a continuous arterial blood gas measurement. You'll know because the dyspnea goes away, and the restlessness and the anxiety and the tachycardia. By the way, just an interesting thing, so I know everybody knows this, because they love to test this. When someone is hypoxic, which rate increases first? The respiratory rate or the heart rate? Heart rate. So when you go hypoxic, your heart rate will speed up first. Then, when the heart can no longer compensate for it, your respiratory rate goes up. A lot of people think, oh, hypoxic, your respiratory rate will go up first. No, it won't. Your heart rate goes up first. If you ever work coronary care, what are the 2 most common causes of episodic tachycardia in heart patients? Hypoxia and dehydration. So a coronary care nurse knows that when you get these episodic tachycardias, all you have to do is increase the IV rate and give them some oxygen, and it goes away, and you never have to call your doctor. I would have to say 90% of the time that I have episodic tachycardia in the coronary care unit when I worked night shift there for 10 years, was at Mercy Medical Center in Springfield, now called Springfield Regional whatever Mall. I never had to call doctors because I would just up the IV rate or give them oxygen, and the tachycardia would go away. You always could tell a new nurse who came into coronary care because they were calling doctors in the middle of the night for episodic tachycardia. And the doc would say, well, did you increase the IV rate? No. Did you give them oxygen? No. Well, do that and call me back if it doesn't work, And that, I'm saying it politely. Okay. Okay, well, what if it's low in the 60s, meaning 68, 69, 64, 63? That's a D. That's the other criteria for respiratory failure. So what are the 2 defining characteristics for respiratory failure? CO2 in the 60s and an O2 in the 60s. When they're both in the 60s, that's when you need to intubate and ventilate them. So if it's in the 60s, there's nothing to hold, you assess the respiratory status, you prepare to intubate and ventilate, you call respiratory therapy, and you call the doctor. Now, you can put oxygen on them during that time. It's not going to solve the problem, but it's going to make them a little more calm. So if I had a click and drag on that one, where would I put the oxygen? I'd probably do this. I'd probably hold. I wouldn't hold anything. I'd assess. Well, no, there's nothing to hold. I'd probably throw on the O2 just to make them what? Comfortable. Then I'd assess them, and then I'd prepare to intubate and ventilate, call respiratory therapy, and call the doctor. Yeah.
That kind of confuses me because I was always taught, I guess, to always assess first and you're safe. In any question,
No, you're not. That's a gross oversimplification.
Okay.
She said that she was taught that in an order question, you always assess before you do. And that's true 80% of the time. 20% of the time it's wrong because there's something you need to hold before you assess. For example, you're giving a blood transfusion and somebody complains of itching and you see hives. What do? Stop the blood, then you do your assessment.
What about though in this situation? Because I would have put assess my patient first, then put the oxygen on that.
That would probably, I don't think, just in my impression, I think if you ask 50 nurses, you'd have half and half on that. And so I can't conceive that they would write that question on boards because it would be such an interpretive thing. Subjective kind of thing. But if the INR is 5, every nurse says, I'm going to stop the Coumadin and then I'm going to find out, assess. That they would all say that. Mm-hmm. And if the potassium's 6, they'd say, I'd turn off the IV and then assess their heart.
Okay, that makes sense.
So yeah, it's going to be, there are certain things where I always tell people this. Assess before you do. Unless delaying doing puts your patient at higher risk. And if you would assess for signs of blood transfusion reaction, if you delayed stopping the blood to do an assessment of are they having a reaction, you would be putting the person at increased risk. So therefore you do before you assess. So what's the rule, everybody? Assess before you do, unless delaying doing in order to assess puts the patient at risk. For example, a patient pulls out their arterial line. They are bleeding in bright red spurts from their radial artery. What's the first thing you do? Assess their vital signs. Apply pressure. Okay? Well, one's assess, one's do, right? Well, if you delay putting pressure in order to take a set of vitals, are you increasing the risk to the patient? Yes, therefore do will precede assess. And that's an obvious one, but I'm trying to illustrate the principle. Are you seeing that?
Yeah.
Okay, good. Good question, because that's one that everybody's taught. How many were taught? Assess before you do, assess before you do. But you have to understand, whenever you use a rule like that, you have to understand that there's always an exception, and what's the exception? Yes?
Not Carmel Group always had a question on ATI that would always catch us up, and it was something about with respiratory situation, which do you do first? And it had head of the bed,
Yes.
and oxygen, and
Yeah.
talking about assessing and calling the doctor.
Yeah.
et
The
cetera.
thing is if I was between, somebody's having dyspnea, acute dyspnea, one was elevate the head of the bed, the other was put on oxygen, the other was call the doctor, and the others do a respiratory assessment. What would I do? I would elevate the head of the bed first. Alrighty? Because if I do a respiratory assessment with him lying flat, I'm getting data that's not going to be helpful. He's not going to cooperate with me. I'm not going to get good data, not going to get full. So I'm going to elevate the head of the bed first. I always like to do, if I'm between two do's, I like to position first. You know, if I'm between two do's and one's a position and one's another action, I find that the position usually wins over the other action. How many have found that out, sort of seen that? So I would probably elevate the head of the bed. I would put the oxygen on. I would do an assessment, and then I would call the physician. Now, what did ATI say, I wonder? Is that what ATI said? Mhm. Because I almost always position first. When I'm between, what, two do's, I always position first. And see, my rule there would be, if somebody's in significant dyspnea and hypoxia, would delaying putting their head up and delaying giving them oxygen while I did a respiratory assessment put them in greater risk? And the answer is yes, you would be. You see, so then I would precede the assess with the do's. Do you see that? Yeah, question.
So if you raise the head of bed first, what you do best is give them O2.
Bingo. You're smart. Good job. Do you hear what she said? She said, but what if it's not a first question? What if it's a best? And you're between oxygen and raised head of bed. Well, in a best question, and I'm really glad, are you here for a refresher, or is this the first time you've taken this class? First time? Good job. Because if you had to do one, raise her head without giving her oxygen, or keep her flat with oxygen, she really will benefit better from the oxygen lying flat than she will up with no O2. So best would be O2. First would be raise head of bed. Is everybody seeing that? Good call. Okay. The O2 sat, the oxygen sat should be 93 to 100. Anything less than 93 is a C, critical. There's nothing to hold. You assess them, you throw on the O2. Now you could, I don't think with an SaO2, unless they're in real danger, a low SaO2 is not going to, like an 88, there's no reason to throw on the O2 right away. You know what I'm saying? I don't, there's no big deal there. In fact, I can't even believe I'm telling you that an SaO2 below 93 is that bad. Because I'm happy with SaO2s of 88 and above. If you think that you're going to run around calling doctors in the middle of the night for SaO2s of 91, you're not going to last long. But on HESI particular, and on boards, if it's a 92 SaO2, they're in bad shape. And I'm telling you, that's not real life. But that's the book. You got me? Because HESI has a question on there where it says, they give you 4 patients and want to know who's your highest priority. And I remember taking it, and letter A was a patient with a 91 SaO2. And I went, oh, that's fine. You know. And then I went to B, and they were okay. And I went to C, and they were fine. And I went to D, and they were good too. And I thought, oh my goodness, they're all fine. And I thought, wait a minute. 90, it's not 93, it's 91. So that's the one that's in bad shape. So I picked them, I got it right. So you're just going to have to go with that, all right? Now, anybody ever want to work peds? In pediatrics, you better freak out when it's below 95. Okay, because little kids don't desaturate without, older people, we desaturate all the time. You know, it's just what we do. But little kids don't desaturate. They usually won't go to COPD because then that anything could be, with COPDers, they're going to have abnormal blood gases. But there's no pattern to tell you what it's going to be and how much of one thing means what. Do you see what I'm saying? Like they can't say, well, you know, for respiratory failure for a COPDer, it's not 60 and 60, it's 70 and 50. There are no parameters. Every COPD their blood gases are individually judged on their level of functioning at that blood gas. So if you have a COPDer with a CO2 of 59, which it should never be, and a O2 of 64, which is horrible, but they're functioning okay, then that's their baseline. Do you see what I'm saying? And the hypercarbia is no issue because they don't have a hypercarbic drive to breathe. They have a hypoxic drive to breathe, so it doesn't even matter. So that's the issue. With a little hypoxia is good for a COPDer because it keeps them breathing. That's why you don't want to give a lot of O2 to a COPD or they'll stop breathing on you. So yeah, I don't think that they could even ask a question that would be fair, other than the fact to know that COPDers normally run high on the CO2, low on the O2. So I guess my answer to you would be, if they gave me 4 patients and they told me one was a COPDer with a CO2 of 55 and an O2 of 71, even those are letter C's for you and I would not make them a high priority. Okay. BNP. Oh, by the way, when is your SaO2 invalid? What invalidates your finger probe SaO2 reading? What's that?
Anemia.
Anemia falsely elevates it. So if somebody's anemic, they're going to look a lot better than they actually are. So if you have an anemic patient, your SaO2 is not helpful. You need to look at other indicators of oxygenation. The other thing that invalidates it is if they've had a dye procedure in the last 48 hours. Why? What does the dye do to blood? Color it. And what does that read? Color. So you're going to have falsely elevated SaO2s with anemia and after dye procedures. So in both cases, when you get your SaO2, you're going to think the patient is what? Better off than they actually are, which is actually pretty dangerous. Okay, BNP, which is the brain natriuretic peptide. Don't worry about that. It's the best indicator of congestive heart failure. It should be under 100. An elevated BNP is a B, which just means you've got congestive heart failure, but you're not going to die. You don't need to call the doctor in the middle of the night. There's nothing you have to do. Just watch them for CHF. See, it sounds kind of funny that a heart value is not a high priority, but this is a heart value because it's indicating a chronic condition. Do you understand why it's not high priority? Because it indicates a chronic condition, not an acute one. Sodium. Sodium is 135 to 145. If it's abnormal, it's a B, which means you assess. If the sodium is high, you assess for dehydration. If the sodium is low, you assess for overload. Remember hypernatremia, hyponatremia. The one with the E is dehydration. The one with the O is overload. However, if the question tells you the sodium is abnormal and there is a change in LOC, the priority of the patient shoots up to a level C. And basically, it's a safety issue at that point. It's safety. Which brings us to the last 3 lab values. Yay. You see why I didn't want to do this yesterday at 3:30? White blood cells. There are 3 white counts you must know. 3 white counts you must know. The first one is the total white blood cell count, which is 5,000 to 11,000. The other 2 are the ANC, the absolute neutrophil count, which needs to be above 500. There's no range here, it's just a threshold limit. You must have more than 500 ANCs per cubic millimeter. And the last one is the CD4 count, and it needs to be above 200. Because remember, when your CD4 falls below 200, what do you have? Not HIV, you got AIDS now. So the defining line between HIV disease and AIDS is the 200 CD4. If you've got 201, you have HIV disease. If you've got 199, you have AIDS. So all of those are low white counts. And all of those are a letter C. All of those below those levels. An ANC below 500. A white blood count below 5,000. And a CD4 count below 200. All of those are level Cs. They all are. And because of that, there's nothing to hold. You assess for signs of infection. And instead of preparing, what you do is you place them on these neutropenic precautions that are in your last column. And it would be good for you to know those, because they do test what's on the neutropenic precautions. The one that it's amazing how you could be a nurse for decades and certain facts you just never learned. It was like 10 years ago, after I've been a nurse for 20 some years, that I learned the ninth one, I think it's the ninth one down. Don't drink water that has been standing longer than 15 minutes. I didn't realize on these neutropenic precautions they are not allowed to have a water pitcher. If they want water, you bring them fresh water. The water isn't allowed to stand. In fact, the water bottles, if they're unopened, I think they're good for 4 hours. If they're open, they're good for an hour. Yes?
I have my leadership on oncology, hematology, and insurance.
Mhm.
And I had patients with, who were getting the NT transplants.
Yes,
And I
bone
had,
marrow transplants.
I had ANC patients with literally two. But not
With a
200,
two.
With a two.
With a two.
And the neutropenic precautions we had to do, like this patient, the nurse, when she had this patient, you could only have one patient because
Mhm, exactly.
the precautions were so
Rigorous.
timely and rigorous. And
What did they use for the water bottles? What did they use?
you weren't allowed to have a water bottle open unless you drank it right away, and they had a special refrigerator that we were able to go. Like, you couldn't just get them regular water. We had to go to the BMT refrigerator, which was always locked. We'd unlock it, get it out, bring it to them, watch them drink it, throw it out. Right?
Throw it out. So it wasn't even an hour. Okay.
I mean, I think you'd have to 20, 30 minutes to let the patient
Okay.
drink it, you know.
Mhm.
But there were certain, and then we had to clean the room every, like, I think it was either every 4 or 6, we had to clean it down with this really special, the whole
Yeah.
room. I mean, it was just
And so the point is they can really get more obsessive than this. A lot more. So this is sort of like the least you would do. And this is see, with bone marrow transplants, you got to be really, really careful because they're really dangerous. Because what did we do? What did we do to them? We irradiated total body irradiation. We irradiated all of their protection. They have none. Zero. I'm surprised she had 2. I've seen some with practically none. Okay, so neutropenics are really important. Okay, platelets. Platelets, I'm not going to give you a normal range because I've looked in 5 different books and they don't even overlap. Nobody knows what a normal platelet count is, I don't think. But the key is, what are the trigger values for thrombocytopenic precautions or bleeding precautions? And that is in your last column. A platelet count below 90,000 is a C. You need to put them on these bleeding precautions. And if the platelet falls below 40,000, now you'll hear people say he has 40 platelets or 35 platelets. They don't mean 35. They mean 35,000. So if they say his platelet count is 3, what do they mean? 3,000. They don't mean 3. Okay, now the ANC means what it says. But this is usually in thousands. And then red blood cells are 4 to 6 million. Red blood cells are 4 to 6 million. And an abnormal red count is just a B. It's no big deal. Okay, now that's a lot of info. Here's what I want you to do with it. Memorize the 5 Ds. Why should you memorize the 5 Ds? Because those are the really high ones that if you don't know, you're unsafe, and you don't want to show that on this test. So what are the 5 Ds? pH in the 6s. Not bicarb. Okay, but there's one before that. Potassium in the... So a potassium in the 6s, a pH in the 6s. Got that? Now what is the next one? CO2 in the 6Ds and an O2 in the 6Ds. So a pH or a potassium in the 6s, or a CO2 or an O2 in the 6Ds. So what pattern are you seeing already? 6s and 6Ds you don't like. And then what's the 5th one? Platelet count of less than 40,000. Those are your highest priority people. Nobody will beat them. And boards will not put those people against each other because it's not fair. Okay, now, what I would then do is learn all the C's. There's probably about a good 8 to 10 of them. Then I would not remember the priority on any of the others. Why? Because that way, if you don't remember them, they are what? Priority. Low. Do you see what I'm saying? So just remember the high ones and everything else is low. So remember your D's, which I think are easy, your 6s and 60s in the 40,000. And then your C's and probably what to do for them, and then you're good to go. And you really will be so much better prepared for the questions than anybody else sitting there. You know? So, because everybody else is just going to what? Guess. And say, well, potassium. And then if it's not potassium, they're dead in the water. Okay, let's turn to something near the back of the book. I want to get it done earlier because it's just a horrible lecture to do late in the day. And that is page 64, psych drugs. We'll do this one, then take a break. Psychotropic drugs, page 64. This is a big laundry list of psych drugs that you have to know. But don't panic, because you're going to find that psych drugs, even though the classes of drugs are different, there's a lot in common between them. And so you're not, even though you may memorize 10 different classes, there isn't going to be 10 totally different, discrete pieces of information. A lot of it's going to overlap, which is nice. And to start off with showing you this, the note in the box is very important. All, how many does that mean? All. Thank you. All means all. All psych drugs cause low blood pressure and weight changes. There isn't a psych drug made today that does not lower your blood pressure and make your weight change. Now, the vast majority of psych drugs will do what to your weight? Increase. But Prozac and a couple others make you lose weight. But even Prozac makes you gain weight. In Prozac, you can go either weight gain or weight loss. Weight loss is more common, but you wouldn't rule out weight gain for Prozac either. So if you really wanted to make it specific, you could say all psych drugs cause low blood pressure and weight gain. But you have to understand that Prozac and a couple others will also cause weight loss. Could cause weight loss. If we just stopped right there, you'd probably do better on your psych drugs, because they like to test those universal kinds of principles. But let's not do that. Let's go into the major classes more specifically. The first one are the phenothiazines. This is an old class of drug, speaking pharmacologically. They're called the first generation antipsychotics, or they're called the typical antipsychotics. Have you heard those words? Typical antipsychotics, first generation antipsychotics. Those are your phenothiazines. They all end in zine, Z-I-N-E, which I love. I think every drug should be that way. I think every drug in a class should end with the same ending, and it should be the ending of the name of the class of the drug. Okay? So all steroids should end in oid. Okay? All calcium channel blockers should have CAL at the beginning of the name. Calcium. You know what I'm saying? All beta blockers should have beta beginning in the name. All benzodiazepines should end in zapine. You see what I'm saying? I just think that's the way it should be, and it isn't, so we have to get over it. But anyhow, this class, it's great. They all end in zine, like thorazine, stelazine, fluphenazine, piperazine, chlorpromazine, hydroxyzine. All those zines are phenothiazines. Actions, they do not cure psych diseases. They just reduce your symptoms. In large doses, they are antipsychotics. I remember this by saying we use zines for the zany. Zines for the zany. So you see a drug ending in zine, what should you immediately think? Zany. It's for an antipsychotic for a crazy person. In small doses, they are antiemetics. Have you ever given compazine? Have you ever given Phenergan promethazine for nausea? Have you ever given Vistaril hydroxyzine for nausea? But if you double the dose, it will treat psychosis. Have you ever given Thorazine for psychosis? If you cut the dose in half, it will treat nausea. Letter C, they are considered major tranquilizers. Major tranquilizers. These are the big guns. I'm going to make an analogy here. Aminoglycosides are to infection like phenothiazines are to tranquilizers. Okay? I should make it different. Aminoglycosides are to antibiotics like phenothiazines are to tranquilizers. What's that mean? They're both the big guns. You pull these out when nothing else is going to work. Okay, these major tranquilizers have a major side effect list. In fact, this has been the marketing dilemma manufacturers of these drugs have had for decades. They manufacture these drugs that really work well, but they have this long list of side effects that really hinders their marketability. I'm going to use the alphabet here to help you remember the side effects of the major tranquilizers. A will stand for anticholinergic, primarily dry mouth. Anticholinergic, dry mouth. B stands for blurred vision. C stands for constipation. D stands for drowsiness. Anybody know what E stands for? EPS, extrapyramidal syndrome, the thing that looks like Parkinson's. Extrapyramidal syndrome, EPS, like Parkinson's. Remember where they get the pill rolling and the cogwheel rigidity and the shuffling gait and all that? F, I cheated. I needed the F. Photosensitivity. I know it's spelled with a PH, but I needed the F to work for me. So photosensitivity. And then with the G, I want you to put a little A in front of the G and write a granulocytosis, which means low white count. So they have a dry mouth, they have blurred vision, they have constipation, they have drowsiness, they have the Parkinson extrapyramidals, their skin burns to light, photosensitivity, and they're immunosuppressed. So that's the side effects of. Now those are all side effects, not toxic effects. What do you do when a patient displays a side effect? What's the nursing action when a patient displays a side effect? Do you hold the drug? No. You teach the patient, inform the doctor, and keep giving the pill. When someone experiences a toxic effect, what's the nursing action? Hold the drug, call the doctor immediately. So for EPS, would you call the doctor immediately and hold the drug? No, we have Parkinson's drugs like Cogentin and Artane we'll give to them to treat the EPS. The only problem is when you give Parkinson's drugs to treat the EPS, do you know what 2 of their major side effects are? Dry mouth and constipation, so that gets worse. But it's kind of a pain. All right, number 5. The nursing care is treating the side effects. So what's the number one nursing diagnosis? Well, they have blurred vision. What's the number one nursing diagnosis related to blurred vision? Injury, risk for injury, safety, right? Drowsiness, what's the number one nursing diagnosis with that? Same thing. Extrapyramidal, what's the number one diagnosis there? Same thing. So what is the number one nursing diagnosis when a client is on a major tranquilizer? Risk for injury, safety issues. Number 6 is a vocabulary word. I want you to know what the word decanate means. Decanate can come after the name of a lot of different drugs. Sometimes they'll abbreviate it. They'll say Thorazine D or something D. The D means decanate. And what decanate means is after the name of a drug, it means it is a long-acting. Sometimes it works for 2 weeks, sometimes it works for a month. 1 shot for a month. It's a long-acting IM form given to non-compliant clients. In fact, this is usually court-ordered or could be court-ordered. What do I mean by that? Yeah, they've probated the client and the judge ordered monthly Prolixin injections. Okay, it's court-ordered. So if the client does not come in to the psychiatrist's office or the community mental health center for their Prolixin shot, because it is court-ordered, what can the staff at the clinic do? Contact the police, who will put out a warrant because they're in violation of a court order, and they will arrest them, bring them in, you stab their butt, and they go home. Okay, so that's the way it goes. And the police just love that. Okay, tricyclic antidepressants. Tricyclic antidepressants are an old class of antidepressant, and most of them have now been grandfathered into a new class of antidepressants called the NSSRIs. Which means what? Non-selective serotonin reuptake inhibitors. But you understand, they were not invented as NSSRIs. They were invented as tricyclic antidepressants. But chemically, they're so much like the NSSRIs that they've sort of been grandfathered into that group. They are mood elevators used to treat depression. They are mood elevators, happy pills. Examples of these are Elavil, Tofranil, Aventil, and Deseril. Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. It rhymes. They all rhyme. Do you hear the rhyme? I'm serious about this. I want you to put these on a 3x5 card. I want you to tape them to your steering wheel. And for the next 4 days, every time you come to a red light or a stop sign, I want you to stop texting, and I want you to just say Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. Elavil, Tofranil, Aventil, Deseril. And after 3 or 4 days, guess what will be forever linked in your brain? Elavil, Tofranil, Aventil, and Deseril. Now, why do I want you to link those 4? Because if you link the other 3, Tofranil, Aventil, and Deseril, with Elavil, Elavil's real easy to remember that Elavil elevates. Elavil elevates. Well, what's it elevate? Your mood. So if you know Elavil elevates your mood, and you link Tofranil, Aventil, and Deseril with Elavil, then you'll know Tofranil, Aventil, and Deseril are also mood elevators. You see why I want you to link them? So that you know what they do. And Tofranil is a very famous one that they love to test. For what reason, I don't know. It's been decades since I've given Tofranil. Okay, in fact, I don't even know why they still test these drugs. They're not given that much. Okay, what are the side effects? Well, Elavil starts with the letter E, so this group's side effects use the alphabet, but it only goes through the letter E. A for anticholinergic, primarily dry mouth. B for blurred vision. C for constipation. D for drowsiness. And E is euphoria. E-U-P-H-O-R-I-A, which means happy, joy, joy. You know. Way too happy. Have you ever met anybody that's so happy it irritates you? That's what this is. What do you notice about that list? It's very similar to the major tranquilizers, but you don't have the extrapyramidal, the photosensitivity, or the agranulocytosis. But the big thing they'll ask about these antidepressants is you must take them for about 2 to 4 weeks before you get beneficial effects. You take them for 2 to 4 weeks. So do they work right away? No. So what's the patient going to say typically after 1 week of antidepressant therapy? What will they say? It's not working. And you need to teach them it's going to take a little while. Letter C, the benzodiazepines, the benzos, real famous. Everybody should know about the benzos. The benzodiazepines. These are anti-anxiety meds. They are considered to be minor tranquilizers. As opposed to what? The Zines, which were the majors, the Zeps are the minors. Number 2, they always have Z-E-P in the name. Zep. Always. So how do you tell a phenothiazine? And zinzine. How do you tell a benzodiazepine? Zep. But both tranquilizers, majors and minors, the identifying syllable starts with what letter? Z. Zeps and zines are tranquilizers. Now the way I remember that is in cartoons, when somebody is tranquilized, meaning they go to sleep, what do they write on the page? Z, a bunch of Z's, right? So if you want to put somebody to sleep, give them Z's, use the Z's. What Z's? The Zeps and the zines. Zines for the zany, those are the what? The majors. And Zeps are the minors. The way I used to remember that when we were in school, it doesn't work as well for you guys because you're younger. But back when I was in school, the greatest rock band of all time was Led Zeppelin. Anybody ever hear of Led Zeppelin? Who's never heard of Led Zeppelin? Oh, wow, I'm still impressed. You still have heard of it? Wow. They must be in their wheelchairs still making music. What's that?
Rock bands put all those older.
Oh, okay. You mean the
game?
The game is bringing it all back. Okay.
Yeah.
Well, I just remember Zeppelin. Zeppelin starts with what?
Z.
3. Zep. Doesn't it? Zeppelin. And we used to say, what do you find at a Zeppelin concert? A bunch of minors on tranquilizers. So that linked what? Zep with minor tranquilizers, so that we kind of remembered that. Okay. The prototype is Valium, diazepam, lorazepam, fluazepam, clorazepam, chlorzapoxide. They always have ZEP in them. Indications, they are more than just minor tranquilizers. These drugs are more than that. Yes, that's their major use. But letter A, they can also be used as a pre-op to induce anesthesia. Letter B, they can be used as a muscle relaxant. Letter C, they're good for alcohol withdrawal. D, they're good for seizures. And E, they help people when they're fighting the ventilator. They help them relax and calm down. Okay, number 5. Yes?
Do they put the generic and the brand name on?
On boards, they're going more and more for the generic. used to be that they always put both. About 2 years ago, they started flooding the exam with experimental questions where they only gave generic name for drug. Because they were trying to find out which drugs is it reasonable to expect new graduates to know by just the generic, and which ones would it be totally unfair to ask them by just the generic. That happened 1.5 to 2 years ago. It'll be 2 years this June. So usually questions stay in the experimental phase for about 2 years, maybe less. So pretty soon, all of those are going to start counting. Okay? Up until now, I would have said, no, they don't count. They're still in the experimental phase. But it's been long enough that they've been doing that yes, there probably will be questions on your board where you are given a drug just by its generic name. And you have to know what it is. That's why I'm trying to do phenothiazines, benzodiazepines, calcium channel block, dipines, sones, those kinds of things, so that you learn the generic names, the mycins, rather than the actual trade. Now, don't panic, because if the only questions that have generic name only, the only questions that have made it into the test pool are ones that are reasonable to expect a new graduate to know. So it's not going to be one that you probably wouldn't know. It's probably going to be one you would know anyhow, like acetaminophen, okay, or warfarin, or meperidine, or acetylsalicylic acid, or those are, you should have known what all those were. What was warfarin? Coumadin. What's acetaminophen? What's acetylsalicylic acid? What is meperidine? Demerol. So those are things that you need. Those ones would be like there. They probably won't say something like, I doubt that they would say pantoprazole. They'll probably say Protonix, or Protonix pantoprazole. You see what I'm saying? So yes, there's a big trend to make it generic only, and I don't like that. I think that's stupid. I don't understand the point of it, because you always look a drug up. So I don't understand why that's, what's unsafe for nursing practice is not looking up a drug, not having the PDR memorized. Do you see? So I don't know where they're headed with it, but I'd like you to really, from now on, if you work, learn your generic names. Learn your generic names. Call them by their generic names until you take your boards. Then you can call it whatever you want. Yes. Oh, I thought, okay. Just praising the Lord? I didn't know if that was it. Okay. Number 5, they work quickly, but you must not take them for more than 2 to 4 weeks. How many of you know people that have been on Valium for years? That's not what the FDA ever approved. So what's the relationship? Think about this. What's the relationship between an antidepressant and a minor tranquilizer?
One you take 2 to 4 weeks and one you don't.
Right. So one takes how long to work? 2 to 4 weeks. And that one you can be on for how long? Rest of your life. However, the other one works right away, but you can't be on it for longer than 2 to 4 weeks. So if somebody comes in anxiously depressed, they'll throw them on both an antidepressant and a minor tranquilizer at the same time on admission. Why? What's going to make them feel better right now? The minor tranquilizer. But somewhere in the next 2 to 4 weeks, what's going to kick in? Their antidepressant, and then you pull them off the minor tranquilizer and they go home on the antidepressant. So stay on your tranquilizer until your antidepressant kicks in. Another analogy, can I make another analogy for you? Heparin is to Coumadin as a tranquilizer is for an antidepressant. Heparin is to Coumadin as a tranquilizer is to an antidepressant. Did you get the analogy? Heparin works how fast? Right away, but you can't be on it for very long. Coumadin takes longer to work, but you can be on it for the rest of your life. And you're only on your heparin until your Coumadin kicks in. Well, that's the same relationship between a tranquilizer and an antidepressant. Okay. Turn the page. Let's talk about the side effects. A, B, C, D. Do I have to repeat them, or can you write them down? Anticholinergic, dry mouth and constipation, and drowsiness, blurred vision. A, B, C, D. And the number one nursing diagnosis is, because it's a tranquilizer, safety, injury. Are you seeing anything different from the major versus the minor? Just a few side effects. Okay, which brings up the monoamine oxidase inhibitors, the MAO inhibitors. These are antidepressants. I don't understand why they're still being tested on boards. It has been 17 years since I gave one of these. And it's not because I didn't work psych, because I did. And I taught psych clinicals too. So I mean, so I don't know why they give them. Now, they still give them in Veterans Administration hospitals. You'll see the most likely place you'll see an MAO inhibitor given is a Veterans Administration hospital. Why? And they're dirt cheap. Dirt cheap compared to the other antidepressants. You can buy a month's worth of MAO inhibitor for the price of 3 days of Prozac. You know, they're pennies. They cost pennies per pill. Now, number 2 tells you how they work. You can just read that yourself. It's not a big issue. But the drug names, you need to spot an MAO inhibitor when you see it. Now, you're going to spot it from the beginning of the name, not the end of the name. The beginnings of the names all rhyme. They are Mar, Nar, and Par. Mar, Nar, Par. Mar, Plan, Nar, Dill, Par, Nate. You see it there? Mar, Plan, Nar, Dill, Par, Nate. Now, the only problem with Mar, Nar, Par is that is their trade name, not their generic. Okay, but I've not seen a lot of generic names on these on standardized tests. Almost every standardized test I ever see has the Mar, the Nar, and the Par there. Side effects. Write it down. But the number one thing they test is on page 67. Patient teaching. Do you remember these drugs? Letter A, to prevent severe, acute, sometimes fatal hypertensive crisis. Hypertensive crisis. High blood pressure. Hypertensive crisis. The patient must avoid all foods containing tyramine. Remember this one? This is that diet that they're not allowed to have certain foods. I saw this once, and I was the one that took the blood pressure in the ER, and I got 300 plus over 220. And the only reason why I wrote 300 plus was back in 1978, our manometers only went up to 300, so who knows what it really was. But it was I wish I had a Dynamap back then, but they weren't invented yet. See, when I was a nurse, all we had was metal IV needles. We never had the plastic. We had metal needles stuck in people try to get somebody through a shift without a metal needle infiltrating. Well, you care. Okay. So you have to know what foods have tyramine, which foods they're not allowed to have. They test this all the time. Every time I try to pull this out of my lecture, somebody says it was on my test, and I say, okay, put it back in. Okay, here are the foods you're not allowed to have. In the fruit and veggie food group, generally speaking, fruits and veggies do not have tyramine. So these people can eat all the fruits, all the veggies they want till the cows come home. It's no problem, just have at it. However, there are 3 fruit veggies that they're not allowed to have. And I always say, remember the salad bar. B-A-R, the salad bar. B for bananas, A for avocados, and R for raisins, which actually stands for any dried fruit. They're not allowed to have any dried fruit. Now be careful, because on certain tests, including the boards, they're very likely to talk about guacamole, which is what? Avocado. See, they always do that kind of thing where you almost have to be a cook to know what's in foods. But guacamole. Now, number 2, grains are fine. They can eat cookies, pie, cakes, breads, no big deal. Meats, they're not allowed to have organ meats, so no liver, kidney, tripe, intestine, brains, heart, lung, tongue. No preserved meats, which means nothing smoked, dried, cured, pickled, or anything like that. Now, they're not allowed to have hot dogs and certain processed lunch meats. Why? What's the last thing in the label on a hot dog?
All the organs, like
And other assorted parts, which means heart, lung, tongue, kidneys, brains, intestines, the whole shoot match. Now, my entire family, back one generation, is Slovak. My grandparents and my dad were not born in America, so I'm first generation American. But in Slovak, we ate Slovak foods, and heart, tongue, lung soup, all that fantastic stuff. And heart and tongue are great. They're fantastic. Back when I was in high school, the big rage in the 60s was to steal other kids' lunches and eat them. No one would touch my lunch. I could leave my lunch out as long as I put Mark Clement on it. Nobody would touch that bag because they never knew what was in it. Okay. Dairy. They're not allowed to eat cheeses except for cottage and mozzarella. Now, there are a few other cheeses they are allowed to have, but boards just really wants to know, can they eat mozzarella? Can they eat cottage cheese? Yeah. So those aged cheeses are no good for them. And also, they're not allowed to have yogurt. This is probably the only diet where yogurt's bad. And then number 5, I know this is not a food group, but for some of you it is. No alcohol or chocolate, okay? So no alcohol, which rules out elixirs, tinctures, no caffeine, which rules out chocolate, licorice, soy sauce, all of that. So those are the things they're not allowed to have. And B, teach the patients not to take over-the-counter meds when they're on an MAO inhibitor. Have you ever read drug labels at a drugstore? What do they all say? Don't take if you're on an MAO inhibitor. Classic. Okay, lithium. We talked about it a little bit yesterday, didn't we? Notice it's an electrolyte like potassium, magnesium, calcium. Isn't lithium on the periodic table of chemistry? Second row, first column, Li, lithium. It's used for treating bipolar disorder because it decreases what? What did I say yesterday? Mania. It does not treat what? Depression. It decreases the mania. You're going to find out that of all psych drugs, lithium is the most unique because its side effects are not A, B, C, D, or any variation thereof. The reason is all other psych drugs, other than lithium, are what I call neurotransmitter messer-withers. Okay? They have their action by what? Altering neurotransmitters. This drug is the only psych drug which does not mess with neurotransmitters. It stabilizes nerve cell membranes. So because it has a unique action, it will have a unique set of side effects. And its side effects will act more like an electrolyte. So it will have the 3 P's: peeing, pooping, and paresthesia. Peeing, pooping, and paresthesia. Why paresthesia? Why will this drug have paresthesia as a side effect? What did I say yesterday about electrolytes? The earliest sign of all electrolyte imbalances is numbness and tingling, paresthesia. So if you give somebody large doses of lithium and make their lithium high, first thing is numb and tingling. Now, what do you do if someone on lithium is peeing, pooping, and paresthetic? Give the drug, hold the drug, call the doctor, don't call the doctor. Which ones? Give and don't call. You can tell him later on when he comes in. However, number 3, toxic effects. What are we going to do with these? Hold and call. Okay, tremors, a metallic taste, and severe diarrhea. Tremors, a metallic taste, and severe diarrhea. Those are the toxic effects. Now, letter A should actually be pulled out to the margin. It really doesn't belong under toxic. I need to switch that. Number 1 intervention when someone is on lithium is increase fluids. The number 1 nursing intervention when someone is on lithium is make sure these people get ample fluids. Why? What are they doing all the time? Peeing and pooping, which makes them lose fluid, which makes them high risk for fluid volume deficit dehydration. So what are you watching? What other blood value are you watching? Dehydration. What other lead value are you watching? Sodium. Okay, letter B, if they are sweating, like they're outside work, and if they say you got a lithium patient, he's manicky, and he's out re-roofing everybody in the neighborhood's house, because they get that way when they get manicky and it's 90 degrees and they're sweating like crazy, don't give them free water. Give them like Gatorade or some electrolyte solution, because you'll be in real trouble, because you have to have a normal sodium for lithium to work. Number 4, note, lithium is closely linked to sodium. So when you're on lithium, you must monitor the sodium levels. Low sodium makes lithium more toxic. High sodium will make lithium ineffective. So if sodium's low, lithium's toxic. If sodium's high, lithium won't work. So the only way lithium will work is if sodium's what? Normal. That's why, in addition to monitoring the lithium level, you got to monitor the sodium level. Otherwise, you don't know what you're doing. So watch that sodium level when somebody's is on lithium. They're called competitive binders. Have you ever heard of that term? Okay. Prozac, everybody's favorite drug. Prozac is a selective serotonin reuptake inhibitor. It is similar to Elavil, the non-selective serotonin reuptake inhibitor. So the same set of side effects belong. So what are the side effects for Prozac? A, B, C, D, and euphoria. However, number 3 is more what they're going to test. Prozac causes insomnia. So give it before noon. Do not give Prozac at bedtime. Not a good idea. Number 4, when changing the dose of Prozac for an adolescent or young adult, watch for increased suicidal risk. What age group? Adolescents and young adults only. Now, if I were on Prozac and the doctor changed my dose of Prozac, would you have to watch me for increased suicidal ideation? Yes or no? No, because I'm not an adolescent or a young adult. I may look it, but I'm not. If you think that's true, you need glasses. The other thing is, what if an adolescent is on Prozac? Does that make them increased risk for suicide? No. It's only when you change the dose. So you have to have both. In order to say there's increased suicidal risk, you have to have recently changed the dose and they have to be an adolescent or a young adult. If you changed my dose, it wouldn't be increased risk. And if you kept their dose the same, it wouldn't be a risk. It's only when you change the dose for an adolescent. Which brings up the last three drugs, then we'll take a break. Haldol, my favorite drug. I love Haldol. Give me a Haldol and a dart gun and I'll be happy and psych all year long. It has a decanate form, which means what? Long-acting IM that you can zap somebody with. It's basically the same as Thorazine. So what are the side effects? A, B, C, D, E, F, G. This is also called a typical first-generation antipsychotic, just like the zines are. It's the old drugs, the old antipsychotics. The big thing they'll test with Haldol is NMS, and you must know NMS. Do not go to boards not knowing what NMS is. Elderly patients and young white schizophrenics also may develop NMS from an overdose of Haldol. NMS is neuroleptic malignant syndrome. It is a potentially fatal hyperpyrexia. That word hyperpyrexia means fever, with temps of potentially 106 to 108. Certainly over 105, but it could start at 102, but it's going to go up, way up. Therefore, the dose for elderly patients should be half the adult dose. But the big thing they're going to do, how they'll test this is this. NMS also has some tremors with it, and anxiety and tremors. EPS has anxiety and tremors with it. And you get EPS and NMS with the same drugs. So boards is going to want to know, do you know the difference between EPS and NMS? EPS is a side effect, no big deal. NMS is a medical emergency, huge big deal. Patient could die. So they're going to want to know, do you know the difference between EPS and NMS? Because one's a big deal and one is not. How do you tell the difference between EPS and NMS? Take a temperature, which any LPN and any nurse, RN, could do without a doctor's order. So there's no excuse for any nurse missing EPS versus NMS. So if they tell you that you've got a patient on one of these major tranquilizers and he's having tremors and anxiety and confusion, what would be the first action you would take? Take their temperature. And if it's 102, 103, 104, what do? Immediately call squad if you're in a nursing home or a psych facility. If you're in a hospital, call an emergency response team. You know what I mean? It's going to be a bad situation, yes.
So temperature above 102?
I would say, yeah. Even though classically it's the 106 to 108 range, if it's over 102, you call that. Lean, half the time, when you call 102, they're going to be okay. So you have to call them, even though you know that not everybody with a 102 is going to be actually in NMS. You can't. It's so life-threatening. You have to do it. That actually happened to us last spring when I was a nursing instructor at a certain hospital with some Cedarville students. We had a guy that was just a nervous wreck, and the patients were saying he's not himself. The nurses were, and they were trying to figure out what was wrong. And so I told my student, I said, "Go measure his temperature." So the student went and measured his temperature. It was 102.8. So we called the doctor, came in, got everything set, and I'm thinking, why didn't these nurses do this? But sometimes you forget those basic kinds of things when you're a nurse. You're thinking about a million things. So you do see it, and it's common. All right, Haldol, number 3, there are safety concerns related to the side effects. I love Haldol because if somebody comes in the ER and they're acutely psychotic and they're tearing the place up and they're wild and crazy, hit them with some Haldol. And then what we like to do, although I never have done this officially, although unofficially I've done it all the time, it's fun to take bets on when they're going to hit the floor. 5 minutes, 10 minutes, 20 minutes, because it's almost. Have you ever seen those wildlife shows where they shoot the rhinoceros in the rear end with a dart gun, and it runs around, and then all of a sudden, what's it do? Bam, like that. Well, that's what happens to these guys. They run around, and all of a sudden they go, bam, and they hit. It's kind of fun to watch. No, it isn't. I don't make a good psych nurse because I find things way too entertaining. And I've got lots of advice, and you're not supposed to give advice or think things are funny. Sorry, they are funny sometimes. Okay, Clozaril. Clozapine. What's the big danger with this drug? Name-wise. Look at the name. What's the big danger with the name? ZAP. Z-A-P. Which, if you're not careful, you think says what? ZEP. Z-E-P, and you'll miss what this drug is. Question?
With Haldol, if they're in this medical emergency then, with the NMS, would you hit them with fluids? Is there
No, you just stay with your patient. There's not much you can do. Just make sure the vital signs are stable. You're with them, the squad comes, and then they'll manage them medically at the hospital. Many people die because there's not a whole lot we can do for it. It's not a good thing. Clozaril, clozapine, this is the prototype. Do you know what I mean by prototype? What do I mean by prototype? The original first. This is the original first, second generation, atypical antipsychotic. This is the new class for the zany. Number 1, it is used to treat severe schizophrenia, which the zany. It was meant to replace the Zines and Haldol. It was originally developed to replace the Zines and the Haldol. And it looked real promising at first because it had an advantage. Number 2, it had an advantage. It does not have the side effects A, B, C, D, E, or F. Now, it can have slight effects like that, but very, very minor compared to the Zines and Haldol. Patient doesn't even notice usually. So originally we thought this was going to put the Zines and Haldol out of business. But then after it was on the market for about 6 months, we started to see a problem. And what was that problem? Number 2, the disadvantage. It does have the side effect A, granulocytosis. In fact, this drug is horrendous in trashing your bone marrow. Your white count can fall horribly low, and you can get unbelievable infections from being on this drug. So they then they altered the formula, came up with different drugs like Geodon, Abilify, Zyprexa, Olanzapine, and all of those. And those are variations of this Clozaril. And some of them are less likely to mess up your white count, some are just as bad. The thing is that not everybody gets the low white count when they're on these drugs. So the upshot is some people can take this drug and some people can't. But the big thing you got to know is with any of your atypical antipsychotics, white count is a big deal. Measuring the white count is a very important nursing monitoring function. The only thing I do want to say is I want to say something about Geodon. Geodon has a black box warning, which means a fatal drug situation. And that is Geodon prolongs the QT interval and can cause sudden cardiac arrest. Geodon prolongs the QT interval and can cause sudden cardiac arrest. Therefore, you shouldn't really use Geodon with people with heart problems. In general, your second generation atypicals end in the ending Z-A-P-I-N-E, zapine. So, once again, a tranquilizer class ends in a Z. So you have your zines. What are your zines? What are your zines? Typical old-time antipsychotics. What are the zapines? Second generation atypical new antipsychotics. And what are the zeps? The minor tranquilizers. Okay? So zine, zapine, and zep are all your tranquilizers. One's an old major, new major, minor. You got that? Can you match them? Minor, old major, new major. Zep, zapine, and zine. Okay, the last drug, Zoloft. They are Lovin Zoloft, and they will call it sertraline, not Zoloft. It's another SSRI like Prozac. It also causes insomnia, but you can give it at bedtime. But the big thing they are now testing more and more with sertraline is the interactions. Has anyone ever heard of the cytochrome P450 system in the liver? What is it responsible for? Cytochrome P450 system in the liver. It's the major enzyme pathway by which drugs are broken down and deactivated in the liver. You remember how drugs are detoxified, deactivated in the liver? Well, the cytochrome P450 enzyme system does that. You don't have to write this down. Zoloft, sertraline, is notorious for interfering with that system, the cytochrome P450 system. So what does it do when you take other drugs? Increases toxicities because they aren't broken down. So the reason why boards and other ones are testing sertraline is because when you're on sertraline, other drugs don't get metabolized and you have problems with too high levels of the other drugs. So when you add sertraline to the drug regimen of a patient, what do you probably have to do with all the other drugs they're on? Lower the dose. Okay, so let's talk about this. Number 3, watch for interaction with St. John's wort, this herbal preparation that people are taking right now. If you take St. John's wort and sertraline together, you're going to get serotonin syndrome, which is a potentially life-threatening problem. It looks a lot like those MAO guys that eat the tyramine. Looks a lot like that. So what are the symptoms? I remember the symptoms from SAD head. S for sweating. A for apprehension. D for dizziness and headache. So they sweat, they're apprehensive, they're dizzy, and they have a headache. Now, apprehension is often called an impending sense of doom. Have you heard of that? That's what we mean by apprehension. But the big one is its interaction with warfarin Coumadin. And that is when you're on sertraline and Coumadin, you're going to bleed out. You've got to reduce that Coumadin. So watch for increased bleeding. When they're on Coumadin and sertraline, watch for increased bleeding because the Coumadin is going to go toxic. All right, take a break. Come back at 5 after. We're getting there. Before lunch.
I've been trying, but it didn't work.
Yeah, page 41. The mother of all lectures. Maternal newborn overview. Oh, by the way, try to come back after lunch, because after lunch I actually do the most important review in the whole lecture, and the whole review is this afternoon. So don't, you know what I mean? It really, I mean, it's critical that you be there for that. Okay, maternal newborn overview. Pregnancy. You must be able to calculate a due date. If you can't calculate a due date, you're in trouble, because everybody else knows how to do it. So here's how you do it. Take the first day of the last menstrual period. The first day of the last menstrual period. Add 7 days, subtract 3 months. Now you can do it another way, but that's, if you don't have a way, that's a good way. So I'm going to give you a date, and I want you to figure the due date, and then talk to your buddy. Her last menstrual period was June 10 through June 15. Her last menstrual period was June 10 through June 15. I want you to figure her due date, and then see what your buddy said. June 10 through June 15. Okay, what do you say? March 17, exactly. Because you got to start with June 10, because that's the first day of the last menstrual period. Add 7, that's 17. Subtract 3 from 6 is 3, that's March. All right, so that's how you do that. Letter B, the weight gain. You need to know how much weight a woman should or should not have gained. Do not worry about multiples. Don't worry about women that are underweight or overweight to begin with. They don't go there. They're just talking about an average, typical pregnancy, which no one has, but the book describes. Okay? The total weight gain for pregnancy is 28 pounds plus or minus 3. 28 pounds plus or minus 3. That's the total weight gain. And here again, we're not talking about multiples, and we're not talking about women who are under or overweight to begin with. Number 2, in the first trimester, she gains 1 pound each month. 1 pound each month. How long is the first trimester? 3 months, so she gains a total of 3 pounds in the whole first trimester. So there's not much weight gain in the first trimester. So if they give you a woman who's had a fairly significant weight gain in the first trimester, that's bad. Because you really should not be gaining much weight in that first trimester. Maybe 3 pounds. In the second and third trimester, she's gaining much faster. She's gaining 1 pound per week. So how do you calculate? Because here's what you have to be able to do. On your licensing exam, if they give you a woman in a particular week of gestation, you have to be able to predict what her weight gain should be. For example, what if they ask you this question? A woman's in her 28th week. She has gained 22 pounds. What is your impression? And then the A says she's just fine, B says she's underweight, C says she's overweight, and D says, well, she could be either way, so do an assessment. She gained 22, she's at 28 weeks. How many of you know the answer? Know it. How many don't know the answer? How many aren't sure? How many aren't voting? Okay, the answer is, I'm going to show you an easy way to get that answer. Easy way. Here's how you do it. How do you calculate a woman's ideal weight gain? Do you see the chart there? We're going to fill in the chart. At week 12, that's the end of the first trimester. How many pounds should she have gained? 3. So put 3. At 13 weeks, she gained another week, so she gained another pound for a total of 4. Total of 4 to that point. 14, another week, another pound for a total of 5. 15, another week, another pound for a total of 6. 16, another week, another pound for a total of 7. 17, another week, another pound for a total of 8. 18, another week, another pound for a total of 9. 19, another week, another pound for a total of 10. 20, another week, another pound for a total of 11. Do you notice how every time she gains a week, she gains a pound? Now, what is the constant mathematical relationship between the top row, the weeks, and the bottom row, the weight gain? A difference of 9. A difference of 9. Take every top number and subtract 9 from it. What do you get? The bottom number. 12 minus 9 is 3. 13 minus 9 is 4. 14 minus 9 is 5. 15 minus 5 is 6. 16 minus 5 is 7. 17 minus 5 is 8. 18 minus 5, 9. I'm saying 5. You know what I mean? So, if you want to know the ideal weight gain for a pregnant woman, what do? Take the week of gestation and subtract 9. And that's what she should have gained, plus or minus a couple pounds. So let's go back to our example. What week did I say the woman was at in the example? 28 weeks. I said she gained how many pounds? 22. Okay, well, what should she have gained? 28 minus 9. 28 minus 9 is 19 pounds. She gained 3 more than she was supposed to. That is in the area of something could be wrong, let's assess. If she's within a pound or 2, she's okay. If she's 3 pounds off, you need to assess her. If she's 4 pounds off, there's trouble. So if a woman is in her 31st week and she's gained 15 pounds, 31st week, 15 pounds, what answer will you pick? Well, 31 minus 9 is... You don't have your calculators, do you? 22. She was supposed to have gained 22. The question said she gained 15. What do you think? We better, what's that called, a biophysical profile on the baby? Because the baby may have died last month. Do you see what I'm saying? And we don't know. So that's bad. So can you predict the ideal weight gain for every week of gestation? Yes. Sure. Just subtract 9 from it. Which is a good OB number to begin with, isn't it? So ideal weight gain equals week minus 9. That's your formula. Letter C, let's talk about the fundus, fundal height. What's the fundus? Not a river in India. What is it? The fundus is what?
Upper part of the uterus.
It's the top part of the uterus. Well, it's not palpable until week 12. So can you palpate the fundus anytime during the first trimester? No. So if they give you a woman for a first trimester checkup and they say, you can't palpate her fundus, should you panic? No, you're not supposed to feel a fundus. What if she's gained 10 pounds in the first trimester and that fundus is way up here? What do you think? She's either not first trimester or she's got that hydatidiform mole, that molar pregnancy, that cancer thing that's bad. Okay, that's in the blue book. All right. Second and third trimesters, they want to know when's it at the belly button. When is the fundus at the umbilicus, the belly button? And that is 20 to 22 weeks of gestation. 20 to 22 weeks of gestation. Now, why in the world would they want to know if you know those two things? What two things? Well, the fact that when do you palpate the fundus? At the end of the first trimester. When is it at the belly button? About 22 weeks. Why is that important for a nurse to know? Think about those 12 weeks and 22 weeks. What are those weeks?
Miscarriage and fetal demise.
Close, because you're dealing with what idea? Date of viability, which is 22 to 24 weeks, which is in the end of the second trimester. So isn't 12 at the end of the first trimester? And isn't 24 the end of the second? So can you use fundal height to determine in what trimester a woman is in? Yes. That's why they want to know it. Because if some woman comes in an auto accident or an accident of some situation, she's brought into the ER, she could not tell you what trimester she is in. Because either she's had no prenatal care, she didn't know she was pregnant, or she's unconscious and able to tell you she's pregnant. You have no history. She's positively pregnant. You need to know what trimester she's in to know what that going on with that baby, right? Well, how can you real quickly put her in the correct trimester? Palpate her fundus. Because if she's pregnant and you cannot feel the fundus at all, what trimester is she in? And who's the priority, the baby or her? Her. If you can palpate the fundus, but it's at or below the belly button, you know she's in the what? Second. And who's the priority? Her or the baby? Her. But if that fundus is above the umbilicus, you know she's in the third. Who's the priority? The baby or the mom? The baby. Are you seeing how they'll work that and who will get the attention and what they'll decide? So those are gross estimations of gestational age. Okay, signs of pregnancy. Do you remember learning probable, presumptive, and positive signs of pregnancy? How many remember those three categories? Good news. There aren't three categories on boards, there's only two. Positive and everything else. So they lump the probables and presumptives together. You are not going to be asked to tell the difference between a probable and a presumptive. You will be asked to tell the difference between a positive and one of the other two. So you've got to know your four positive signs. They are fetal skeleton on x-ray. If you x-ray the abdomen and there's a skeleton there, you're pregnant. You can protest all you want, but you're pregnant. Number two, a fetal presence on ultrasound. If they do an ultrasound and there's a baby there, you're pregnant. C, auscultation of a fetal heart rate. Auscultation of a fetal heart. If they put a Doppler down there and there's a rate of 140, it's a baby. Your bladder doesn't have its own pacemaker. You've got a baby down there. Now, when does that occur? Somewhere between 8 and 12 weeks. You can hear it somewhere between 8 and 12. Now, it starts beating at 5, but you can't hear it until 8. Which brings up a really important point about OB questions. Most OB information, because it's OB, has a range where it occurs, because every woman is different, right? And they give you a range for everything. There's a range for quickening, there's a range for lightening, there's a range for viability, there's a range for fetal heart, there's a range for fundal heights. There's always a range for everything. Because of that, be real careful in OB questions. This is critically important to remember. Really carefully read your OB questions, because there could be 3 different questions for every fact in OB. The first question would be, when would you first? Got that? When would you first? That's one form of the question. The second question would be, when would you most likely? And the third question would be, when should you buy? When would you first? When is it most likely? And when should you buy? Those are three totally different questions for the same fact. In other words, when would you first auscultate a fetal heart? The answer is 8 weeks. When would you most likely auscultate a fetal heart? 10 weeks. When should you auscultate a fetal heart by? 12 weeks. Do you see that? So whenever they say first, pick the earliest part of the range. When they say most likely, pick the midpoint of the range. And when they say should by, pick the end of the range. And a lot of times you're missing OB questions, not because you don't know the correct range, but you're not paying attention to which one of those they want. So when is quickening? When the baby kicks. Remember, quick, kick, quickening, kicking. When does it happen? 16 to 20. So when would you first feel quickening? 16. When would it be most likely? 18. When should you? By 20. Do you see the difference? Three totally different questions for every single fact. If you don't know that, you're going to miss questions thinking you, even though you know the information. Okay, letter D, the fourth positive sign of pregnancy is when the examiner palpates fetal movement or outline. So what does not count as a positive sign? When mom does. It's when the examiner does. Okay, let's turn the page and talk about the other signs, the maybe signs. We lump the probables and presumptives together and we call them maybes. Letter A, all urine and blood tests. All urine and blood pregnancy tests are maybes. They are not positive signs of pregnancy. I'm going to make a statement. You don't have to write it down, but this is the reason why everybody gets confused about this. Here's the true statement. A positive pregnancy test is not a positive sign of pregnancy. That's true. And that's why everybody gets confused about positive signs of pregnancy, because they think a positive pregnancy test is a positive sign. No, it is not. It's only probable or presumptive. So a positive pregnancy test is not a positive sign of pregnancy. Did everybody know that?
Why not?
Because it only means you have the hormones that go with pregnancy. And many, many times you may have the hormone increases that go with pregnancy, but you don't have a fetus. And so a lot of positive pregnancy tests are false positives. But when you hear a heartbeat down there, there's no false positives on that one. Okay? It's a good question. I could phrase it the other way in what relation to what you asked, is positive signs of pregnancies have no false positives, are things that never have a false positive. Okay, let's talk about some other probable presumptive sign. Have you heard of Chadwick's, Goodell's, and Hegar's signs? Hopefully you've heard of this. Two things you need to know. In what order do they occur? It's easy. They occur in alphabetical order. So who comes first? Chadwick followed by Goodell followed by Hegar. See, boards is more interested in if you know the order than if you know the exact weeks. Why? Weeks vary from woman to woman, but the order never varies. So boards is going to test what does not vary because it just is statistically more valid to test that. Or reliable, I should say. Well, what is Chadwick's sign? Chadwick's sign is a cervical color change to cyanosis. A cervical color change to cyanosis. What do you notice about all those words? They start with the letter C, and what does Chadwick's begin with? C. So Chadwick's is everything that starts with C. A cervical color change to cyanosis. It turns blue. And if the cervix is doing it, the vagina is too. Okay, Goodell's sign is cervical softening. And Hegar's is uterine softening. Doesn't that order make sense? what would happen first? The cervix would turn blue, then the cervix would soften, then that softness would move up into the uterus. So it kind of makes sense, the order does. Okay, let's talk about some patient teaching in pregnancy. You need to teach the woman the pattern of office visits. Good prenatal care is a major factor in reducing infant mortality. So you need to know how to teach a woman how often she should come in for good prenatal care. So you teach her to come in once a month until week 28. So through the whole first trimester and the whole second trimester and even into the third trimester, she's coming in once a month. Then at week 28, she should come in once every 2 weeks until week 36. Then she should come in every week until delivery or week 42. What happens at week 42? Do you schedule her for another office visit? C-section or an induction? So let me ask you this. If a woman comes in for her 12th week checkup, when does she come in next?
1 month.
16. If she comes in for 16, when does she come in? 20. If she comes in at 20, when does she come in? 24. If she comes in at 24, she comes back at 28. At 28, she comes back at 30. At 30, she comes back at 32, 34, 36, 37, 38, 39, 40, 41, 42, take the baby. So that's basically the way it goes. All right, another thing you have to teach her is that her hemoglobin will fall, and that's normal. We don't worry about low hemoglobins with pregnant women until it gets really low. The normal female hemoglobin level is 12 to 16. In the first trimester, it can fall to 11 and be perfectly normal. 11 is not low, tolerable. 11 is normal for a first trimester pregnant woman. It's not low, but tolerable. It's actually normal. It's not low. It's normal. In the second trimester, it can drop to 10.5 and be normal. Not low, but normal. In the third trimester, it can drop all the way to 10 and be normal. So what would you call a 10.1 hemoglobin in a woman's 37th week? Acceptably low or normal? Normal. So acceptably low might be as low as 9, you see. So I guess my point is this. Tolerate lower hemoglobins in pregnant women the further along they are than you would with other non-pregnant people.
What was the number for the first trimester?
11. It can fall to 11 and be normal. Which brings up the discomforts of pregnancy that you need to teach her. How do you treat morning sickness? What trimester problem is it? First, and what do you treat it with?
Crackers.
Dry carbohydrates. Yeah. Dry carbohydrate for breakfast, yes or no? No. It's dry carbohydrates before you get out of bed. Because once you're out of bed, it's too late. Number 2, how do you deal with urinary incontinence? This is a first and third trimester problem. Why do they not have a problem with urinary incontinence in the second trimester? Why do you not get urinary incontinence in the second trimester? Because the baby is in an abdominal pregnancy. It's up high off the bladder. But in the first, it's right down on the bladder, and the third, it's right down on the bladder again. How do you treat it? Void every 2 hours. A pregnant woman should void at least every 2 hours all the way from the day she gets pregnant until 6 weeks after delivery. Every day, all through labor, delivery, postpartum, pregnancy, void at least every 2 hours. Number 3, difficulty breathing. This is a second and third trimester problem. And you teach them tripod position. Can anybody explain to me what tripod position is? Feet flat.
Arms on the table with your.
Arms on the table, leaning forward. So that's tripod. Or you can even put your arms on your hands on your knees, leaning forward. It's what you see COPD clients doing. Okay, how to back pain. People with pregnancy get back pain. It's usually second and third trimester. It just keeps getting worse and worse and worse. How do you treat it? Pelvic tilt exercises. Pelvic tilt exercises. So what that means is the woman should tilt the pelvis forward. You don't want them going like that because that hurts. So you're going to see women do this. That's what they do. You know, they put this and they tilt that pelvis forward. That's classic pelvic tilt. Another way to do it is have them put their foot on a stool and that tilts the pelvis forward. Boards usually says this one. Okay, that's pregnancy. And you say, that's all? Well, there's some in the blue book, but pregnancy is a great place to use your common sense because pregnancy is not a disease. It's a healthy state. And so using good health patterns and ideas. So when you get a pregnancy question you don't know the answer to, what should you say?
Dehydration.
Well, what would be good for anybody? What would be a really good, healthy response here for anyone? Pick it and you will be surprised at how well you do. Okay, let's get this baby out of here now. Okay, let's go into labor and birth now. Letter A, what is the truest, most valid sign that a woman is in labor? How do you know a woman's in labor? What's the most valid sign she's in labor? What's that?
Bloody show.
Not bloody show. Not water breaking, because you can have both those and never be in labor. Okay, but the woman doesn't call you and say, I'm dilating and I'm effacing. So what will they call it? What will they report? They call that the onset of regular progressive contractions. The onset of regular progressive contractions. That's the most valid sign that a woman is in labor. Isn't it possible to have your membranes rupture and 2 days later you still aren't in labor and they have to C-section you? Yeah. So that's not a good indicator. But it's associated with it, but it's not the best. Okay, terms. Here again, you have to know a vocabulary. You have to know what the words mean in OB or you can't answer the questions. So I just want to be sure you guys know these words. Dilation is the opening of the cervix, the opening of it. And it goes from 0 to 10 centimeters. So what a cervix that is 0 is described as what? Closed. A cervix that is 10 is described as fully dilated. Or, because open's not the best, fully dilated is the best. In America, in the United States, do we use centimeters or inches, generally speaking, in our lives? We talk about inches. We don't use centimeters. Most Americans don't know what a centimeter is. They know what an inch is, but they don't know what a centimeter is. Then why do we use 10 centimeters and 0 centimeters in OB? Why don't we use inches? Because most of our obstetric history comes from England. And we use very much an English system. But I also think in America, just think about marketing and 10 centimeters is 4 inches. I don't know how many women would sign up where they have to push a baby out a 4-inch hole. Do you know what I'm saying? So 10 centimeters sounds a lot more what? Generous, doesn't it? Oh, you're 10 centimeters. Oh, I can do this. So I know that's interesting. Okay, effacement. Effacement is thinning. 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 Thinning of the cervix. It gets thinner. And it goes from thick to 100%. So a cervix that is not effaced is described as what? Thick. A cervix that is completely effaced is called 100%. So how does a woman begin labor? Thick and 0, or thick and closed, or thick and 0 centimeters. How does she end labor? Fully dilated and fully effaced, which what numbers? 10 and 100%. Okay. All right. Station. Station is the relationship between the spine. The fetal I'm sorry. I was getting in line. Station is the relationship of the fetal presenting part to mom's ischial spines, and you must know the ischial spines. This word is very important to know in OB. Ischial. The ischial spines are the smallest diameter through which the baby has to fit to be born vaginally. It's the tight squeeze, so to speak. It's the narrowest part of the pelvis. And if the baby can't fit through there, it cannot be born vaginally. If it can fit through there, it can be born vaginally. Station will tell you that. Now, negative stations means that the presenting part is above this tight squeeze. Positive numbers means the baby's presenting part is below, has already made it through the tight squeeze. So if a kid stays at -1, -2, -1, -2, -1, -2, -1, -2 for 17 hours after they're fully dilated and effaced, what do you know? Head's too big, C-section that lady. But what if a kid stays at +4, +3, +4, +3, +4, +3, +4, +3 for 17 hours? What's that tell you? Can the baby be born vaginally? Yes, because it's already made it through. It needs a vacuum extractor. It needs an extra little, maybe an episiotomy or just a forceps. So how many of you have a hard time remembering positive numbers and negative numbers? Which one's high, which one's low? Nobody does? Okay, I used to screw that up all the time. So I guess you don't. Okay. I had a way to remember it, but since you don't have that problem, we'll go on. Engagement is station 0. So what's that mean? If it's station 0, what's that mean?
Equal to?
The presenting part is where? At the ischial spines. Station 0. Yes?
Will you give me your clue in case I get nervous?
I always remember that positive numbers are positive news, negative numbers are negative news. Now what do I mean by that? Well, if you go into a woman's room and she says, what station am I at? And I tell her a negative number like -1, -6, that's negative news to her, which means where's the baby? Way up, and it's not coming down. But if I walk into a woman's room and she says, what station am I at? And I give her a positive number like +4, +2, what kind of news is that? Positive news. Good news. What's good news to a woman in labor? Baby's coming out, it won't be long now. So negative numbers are negative news to a woman, positive numbers are positive news. Negative, negative, net positive, positive. That's the way I remember it. Otherwise, I always got screwed up. Lie. Lie is the relationship between the spine of the mother and the spine of the baby. In other words, between the spine of the mom and the spine of the baby. If mom's spine is like this and baby's spine is like that, that's good. That's called a vertical lie. That's compatible with a vaginal birth, uncomplicated. Another lie is if mom's spine is like this and the baby's spine is perpendicular. That is bad. That is called a transverse lie. And you see how I use the perpendicular as the T. And that is also trouble. It's bad. So whenever they give you these questions about lie, they will tell you where mom's spine is in relationship to baby's. Alrighty? If they tell you that mom's spine and baby's spine are parallel, touchdown, we got a baby. Score. Good. Baby's coming out. If they tell you the mom's spine is this way and the baby's spine is that way, make that. And what's that make? A letter what? Which means it's trouble and transverse. So you either got a baby or you got trouble. Presentation. Presentation is the part of the baby that enters the birth canal first. This is where you get all those wonderful little alphabet soups. R-O-A, L-O-A, R-O-P, L-O-P, R-M-P, R-S-A, R-S-P. Punt all of that. You do not need to know all of that. Let me just show you a little poll. How many of you know all of that? How many of you don't know that? My point is proven. Okay, how many know that before you give digitalis you take an apical heart rate? How many know that? How many do not know that? What do you need to know? The presentations or the dig? Because everybody else knows the dig. You better know it. Nobody else knows this other stuff. So why would you spend 2 weeks memorizing it? You're going to forget it anyhow, right? If they want to ask a hard OB question, they pull this out. What's the damage to you to missing a hard question? There is none. There is no danger to you in missing a hard question. Where's the danger to you? Missing an easy question. Everybody's going to get hard questions. Everybody will. You can miss every single one of those and still pass with flying colors. You cannot miss the easy ones. So the goal is not to memorize or know everything. The goal is to know what everybody else knows so that your knowledge doesn't look any different than everybody else's. Do you understand what I'm saying? It's sort of like a National Geographic special, Boards is. And you're all a pack of zebras. Who gets picked off by the lion? The one that's what? Lagging by itself, all staying with the herd is good. So in nursing, stay with the herd, okay? So hopefully now, the most common presentation is ROA or LOA. Right occiput anterior, left occiput anterior. Okay, now, so if they ever give you a question where they say, you palpate a bulge here and an irregular there and a lump here and a round there, and then they say, what presentation is it? Hey, I'm picking ROA or LOA because I've got much better chances picking those two than anything else, and you'll probably be right. So that's just a good guess. ROA, LOA. And I'd pick R before L. 4 stages of labor and delivery. There are 4 stages of labor and delivery, and you must know them. Stage 1 is labor. All of labor is stage 1. And labor has 3 phases. Do you remember that? There are 4 stages that are big, and then 3 phases that are small in the first stage. So the phases are latent, active, and transition. And those phases are all in the first stage, which is called labor. Question?
Yeah. Going back to what you said about, doing the easy questions. Why do they tell us if we get a bunch of hard questions, that's good, because we're above that.
Yeah, if you get a whole bunch of hard questions, you have passed. Because you can only get to the hard questions by having mastered the easy ones. And the only way you can fail is to, for some reason, mess up easy ones. Whether due to your anxiety, just not understanding what they were asking, or not having certain basic knowledge that you should have, or not knowing how to answer certain kinds of questions. But I was sitting at a table in Cleveland at a national conference of the National Councils of State Boards of Nursing that write the test. And there were 8 of us at the table, and Ann Wendt was sitting right there, 2 people away from me. And Ann Wendt is the president of the National Council of State Boards of Nursing. She's the top NCLEX writer kind of person in the nation. And we were asking her questions. And one question I asked her, I said, Ann, people are always asking me, what do they need to do to pass? In a nutshell, what do they need to pass? And she looked at me, she says, I'll answer that in one question, one short answer. She said, they have to get to the hard questions. So if you want to pass, you have to what? Get to the hard questions, where you're going to miss a whole lot. But you've got to get to the hard questions, because if you never get to the hard questions, you will never pass. Do you see what I'm saying? Because you're always bouncing around down on the easy ones. And I didn't think that was that helpful, but at least it tells me that is because it came from the source authority on that. So she says you got to get to those hard questions. So the upshot of that is, don't panic when they're asking you about stuff you don't think anyone's ever heard of, because you're probably getting hard stuff, and that's okay. It's okay to get hard stuff. You want to get hard stuff. All right, stage number 2. Oh, by the way, what are the 3 phases? Latent, active, transition, in that order. What's the first phase? Latent. What are the first 3 letters of the first phase? L-A-T. What are those? The initials of this phase is in order. L for latent, A for active, T for transition. So the first phase, the first 3 letters of the first phase tell you the order of the phases. Stage 2 is called delivery of the baby. Stage 3 is delivery of the placenta. And stage 4 is recovery. Stage 1 is what? Labor. Stage 2 is delivery of baby. Stage 3 is delivery of placenta, and recovery is the 4th stage. Now, I would ask you, how long does recovery last? Does anybody know? Just 2 hours. It lasts for just 2 hours. So let me ask you this. What is the purpose of uterine, and this is what Hesse loves to ask, what's the purpose of uterine contractions in the first stage? In the first stage, what's the purpose of uterine contractions? No, that's stage 2. Dilate and efface the cervix. What is the purpose of uterine contractions in the second stage? Push the baby out. What's the purpose of uterine contractions in the third stage? Push the placenta out. What is the purpose of uterine contractions in the fourth stage? Stop bleeding. Yeah, to contract the uterus, to stop bleeding. So can anybody tell me when postpartum technically begins? When does postpartum technically begin?
After recovery.
And give me some more data on that.
2 hours after.
2 hours
2
after?
hours after recovery.
Not after recovery. 2 hours after delivery of the placenta. There you go. So 2 hours after that placenta comes out, they're in recovery, and then when that ends, they are now in postpartum. Postpartum does not begin when the baby comes out. Does everybody see that? Okay. So do you see where people get messed up? They get messed up between second phase and second stage. Because if I ask you, what is the number one priority in the second phase of labor? Number one priority in the second phase of labor, what would it be? Pain management. Right? But if they changed the word phase to stage, and they said, what's the number one priority in the second stage? Now what's the number one priority in the second stage? Clearing the baby's airway. You see what I'm saying? So you have to be careful if you know what would be an extremely important nursing action to undertake in the third phase. What do nurses do? What kind of actions are nurses engaging in the third phase? We're checking dilation, we're helping her with pain, we're helping her with breathing, because she's in the last intense part of labor to dilate, right? But if I said, what's a major nursing action for the third stage, what would you say? Yeah, watching for blood loss. What's the third stage? Okay, so what do you do with that? Yeah, make sure it's all there. Make sure there's 3 vessels in the cord. But you would never do that in the third phase because you don't. Do you see what I'm saying? So you understand how if you aren't paying attention to whether they're talking about stages or phases, you're gonna get messed up. Can you do that? Please keep phases separate from stages, because you have a first phase and a first stage. You have a second phase and a second stage. And you have a third phase and a third stage, but you only have a fourth stage. All right. Now let's go through those, and we'll go to lunch here in a little bit. Let's try to do the next 2 pages, and then we'll be done, but maybe we won't. The rest of this moves fairly quickly, because there's really not a whole lot. I mean, it's just a lot of fill in. D says the first stage of labor and delivery. What's it all about? The first stage. What's it called? Labor. So what you see here is what we call the labor chart. Bad news. You have to know it all. You have to know the whole labor chart. Good news, though, I'll show you a way to remember it that's really easy, so you don't have to memorize it all. So let's talk about this labor chart. How many phases do you see in the labor chart? 3, because how many phases are there to labor? 3, and there's latent, active, and transition. Let's talk about latent. In the latent phase, you dilate from 0 to 4 centimeters. Your contractions are 5 to 30 minutes apart. That's the first column. We're going down the first column. So the contraction frequency is 5 to 30 minutes apart. The contraction duration, meaning how long they last, is 15 to 30 seconds. And the intensity of the contractions is described as mild. Now that's our word, not hers. Now let's talk about active, because things pick up here. Dilation goes from 5 to 7 centimeters. The frequency is every 3 to 5 minutes. They last 30 to 60 seconds, and their intensity is moderate. Again, our word. However, in transition, things pick up even more. The cervical dilation goes from 8 to 10 centimeters. The frequency is every 2 to 3 minutes. And the duration is 60 to 90 seconds. And the intensity is strong. Now, the way they will test your knowledge of this is they will say, a woman comes into the labor and delivery suite. She is 5 centimeters. Her contractions are every 5 minutes apart, and they last for 45 seconds. What phase is she in? Active. That's how you do it. But you have to know the numbers to put her in the right one. Good news. This chart is what we call a 3-column sequential table. Meaning there's 3 columns, and where one leaves off, the other picks up. And where that leaves off, the next one picks up. The easiest way to master a 3-column sequential table is to ignore the sides and only memorize the middle column. So I only want you to memorize active labor. Just active, which is what? 5 to 7, 3 to 5, 30 to 60. And you got the whole chart, don't you? Because anything less intense would be what?
Late.
And anything more intense would be transition. So 5-7, 3-5, 30-60. It can't be simpler than that. Note. Do you see where it says note? Contractions should not be longer than 90 seconds or closer than every 2 minutes. You must know this. They love to test this one. How do you know a woman's in trouble in labor? Well, when her contractions are longer than 90 seconds and closer than every 2 minutes. You do not want to see that. They would give you 4 women in labor and say, who's in trouble? Her contractions are going to be longer than 90 and closer than 2 minutes. That's bad. They'll also ask it, what are the signs of uterine tetany? Well, contractions longer than 90 seconds, closer than every 2 minutes. What's uterine hyperstimulation? Contractions longer than 90 seconds, closer than every 2 minutes. What parameters would make you stop Pitocin? 90 seconds, 2 minutes. 90 seconds, 2 minutes. Remember that. You're very likely to see that. Okay, let's talk about assessment of contractions. You have to tell the woman how to do this, how to time her contractions. Well, frequency is beginning, that goes in the blank, beginning of one contraction to the beginning of the next. So if you're teaching a woman to time frequency and these are 2 contractions, what letter interval would you tell her to time for frequency? A beginning to C beginning. That actually includes the contraction, doesn't it? So frequency is beginning to beginning. Duration, on the other hand, is beginning to end of one contraction. Beginning to end of one contraction. So what number sequence would you tell her to time for duration? A to B or C to D. So frequency would be A to C. Duration would be A to B, C to D. Intensity is the strength of contraction, and it's purely subjective. However, that next sentence is really important. You see where it says palpate with? This is very important. Teach her to palpate with one hand, always one hand, because the other hand is timing. One hand over the fundus with the pads of the fingers. So make sure you teach her to use one hand. Make sure you teach her to go over the fundus, and make sure you tell her to use the pads of the fingers, which are the fingertips. Okay, let's talk about complications of labor and then go to lunch. Bad news. There are 18 complications that can occur in labor and delivery, and you have to know them all. Good news. There are only 3 protocols you need to know for all 18. So really, what do you have to memorize? 18 different things or 3 different things? 3. So let's talk about these 3 things you need to know. The first one is painful back labor. Have you heard of painful back labor? It's usually when she's OP, occiput posterior. You know, LOP, ROP, occiput posterior. I always tell people, when you see OP at the end of it, think O pain, because they're going to have it. OP is O pain. So what do you do for it? 2 things. Position, then push. You position her, and then you push. In what position would you place her? Does anybody know which position you put a painful back labor in?
Side.
Not side. Knee, chest. She goes on her hands and knees with her rear end up and her head down. Because that brings the baby down off the sacrum and coccyx. So knee, chest. Get her on her hands and knees. Then push. What do you push? Anybody know what you push? Take your fist and push into her sacrum. Because that applies counter pressure and actually relieves some pain. Yes?
Wait, I'm confused. You said knee to chest, but do you,
Knee, chest.
but then you said, how are you gonna, if they're laying back in bed, are they on all fours? Or-
No, knee. See, knee, chest.
I mean,
Yeah, people get knee, chest confused with lithotomy. Because in knee, chest, and lithotomy, your knees are to your chest in both. This is lithotomy. This is not what we're talking about. This is lithotomy. Okay? Okay? That's lithotomy. This is knee, chest. That's knee, chest. See? So your knees are to your chest here, and your knees are to your chest here. But this is lithotomy. This is, and here's the nose, that way. And this is knee, chest here. Because see, the baby then will come down off the coccyx. So knee, chest is that. Okay? That's knee, chest. Right? And that's what we mean. We don't mean this. Next one, prolapse cord. This is bad. This is a OB emergency. Prolapse cord is bad because the baby can kill itself. Prolapse cord is when the cord is the presenting part, which means comes out first, so that when the head comes down, what's the head do? Press on the cord and the baby dies. Baby literally commits suicide and kills itself. So this is not cool. Painful back labor, high priority, low priority.
Low.
Low. Prolapse cord, high priority, low priority. High. Okay, what do you do here? Push, position. Now what was painful back? Position, push. This one is push, position. So they're just the flip-flop. Well, what do you push? You don't touch the cord. Push the head back up. Push the head off the cord. Then what do you position her in? Knee, chest. The one we just talked about. So she's in knee, chest. You've got your hand pushing the head. And you stay that way till they pull it out C-section. So it's kind of, you have to ride on the cart with her. You know, so you just throw a blanket over everything. You just go like this, you look like a float, you know, in a parade. It's kind of weird. So what do you do for painful back? Position, push. What do you do for prolapse cord? Push, position. Do you remember I said usually I will always position before I do something else? That has an exception too, because in prolapse you push, then you position. Why do you push first in prolapse and position second in prolapse? Why? Because delaying pushing in order to position would increase the risk to the baby. See, but it's the same principle. So when you're sitting there not knowing what to do, it's probably good to you to think about, if I delay doing this to do that, would it... That's probably a good way to think. All right, number 3, interventions for all other complications and labor and birth. And there's like 16 of them. Uterine tetany, uterine atony, uterine hypertension, uterine hypotension, maternal subclavian syndrome, vena cava syndrome, just you name it. There's beaucoup complications. They're all treated the same. And they are treated with Lion, Lion. L means first you turn them on their left side. There's the L, left side. I is increase IV. O is oxygenate them. N is notify physician. So first you turn them on the left side, you increase the IV, you give them oxygen, and you notify the physician. Now LPNs, you will be able to do all of those except increase the IV. So what do you do for maternal hypotension? Line. What do you do for eclampsia? Line. What do you do for toxemia? What do you do for uterine rupture? Line. What do you do for, you see what I'm saying? As long as it's not painful back or prolapse cord, you're picking what? Line. Question? Question?
We were just talking about first and best for the situations where first again would be positioning and oxygen would be best.
Probably the first would be, the position, and the best would be tough. The left side there might be the best too, because that gets the pressure off, gets the placenta perfused better. So even if you give oxygen and the placenta is not being perfused, it's not going to get to baby. So I would say that's one place where first and best are the same one, left side. Would everybody agree with that sort of? Okay. And sometimes it's the same. It's just on occasion it's different. And most of the time it's different. On occasion it's the same. Okay. PIT. PIT means in a crisis, if Pitocin is running, stop it. In an OB crisis, if PIT is running, stop it. So could that be the first thing you would do? So that would catapult all the way to where? Hold the PIT would catapult to what order? Number 1, and that would be L. So you'd stop the PIT, then LION. But most of the time they will not tell you PIT is running, so PIT won't even be there. So 9 times out of 10 you'll be doing LION. But if they tell you PIT's there, stop PIT, LION. Okay. Pain medications in labor. Get this down word for word and then we'll go to lunch. Do not administer a pain medication to a woman in labor if the baby is likely to be born when the med peaks. Do not give a pain medication to a woman in labor if the baby is likely to be born when the med peaks. Let me illustrate how you're going to do this, because it's not going to be anything magical, it's just going to be good common sense. What about this question? You have a prima gravida. Prima gravida means what? First timer. Prima gravida at 5 centimeters who wants her IV push pain med. Will you give it to her or not? Well, the question is it likely that a prima gravida at 5 centimeters is going to deliver in the next what? Well, IV push meds. We learned the other day that IV push meds peak when? IV meds peak when? 15 to 30 minutes after you give them. So is it likely that a prima gravida at 5 centimeters will deliver the baby in the next 15 to 30 minutes? No. So would you give her the med? Yes. What about this question? You have a multigravida at 8 who wants her IM pain med. Well, the question then is it likely that a multigravida at 8 centimeters could deliver in the next, well, when do we know IMs peak? 3260. Is it likely that a multigravida at 8 could deliver in the next hour? So what would you say to her? No. Are you getting it? It's going to be obvious. It's not going to be, they're not going to play around with being real close like your teachers in school and ATI and stuff like that does. You know what I mean? They're going to make it clear. If you can pass HESI, you can pass ATI, you can do boards. You can. They are much harder. I would rather take state boards any day of the week than take an ATI or a HESI. That'd be a no-brainer. Be a no-brainer. Okay, after lunch, we'll come back and do fetal heart tracing. Be back at about, try to be back at 5 to 1.
I'm going to run. I'm going to fill my car up. Gas.
Part of this discretion, or is that too specific?
That's too specific. Part of dyskinesia generally is funny tongue movements, funny eye movements, and stiffness. There's odd eye movements, odd tongue movements, and stiffness. That's part of dyskinesia. The dystonia usually is muscles anywhere. Part of dyskinesia.
Yeah, I know why you wanted to do it.
Okay. That's more dystonia.
You want to do it. All right.
All right, we're going to talk about fetal monitoring patterns. There are 7 of them that you should know. Don't panic because they're actually easy to remember. I'm going to go through here and tell you which ones are okay and which ones are bad and what to do for them. All right, so that's the way we're going to go. The first one is a low fetal heart rate. That means under 110. This is bad. When you see it, you do LION, L-I-O-N. Left side, IV, O2, notify. And if PIT were running, what would you have done? Stop the PIT. High fetal heart rate. That's a fetal heart rate over 160. This is no big deal. You would document it and take mom's temperature because it's probably mom has a fever. That's based, but there's nothing wrong with who? The baby. Baby's just fine. You don't have to do anything specific. If you did anything, you'd take mom's temperature. That's basically all you do. It's no big deal. It's not a high priority. Low baseline variability. This is bad. This is when the fetal heart rate stays the same and does not change. Whether high or low or in the middle, it just stays the same. It doesn't change. That's bad. That's bad. And what you do is LION, L-I-O-N, left side, IV, O2, notify. High baseline variability. What that means is baby's heart rate is always changing. That's good. Document it. Now it's kind of interesting. Once a person is born, if their vital signs stay the same over time, what do we call them? Stable, and they are in good shape or bad shape? Good. But before you're born, if your vital signs stay the same over time, it's low baseline variability and it's bad. You want to see, so what we want to see before you're born, we don't want to see after you're born, and what we want to see after you're born, we don't want to see before you're born. So we want to see vital signs all over the map when the baby's in utero. That's called high baseline variability. That's good. We don't like to see stable vital signs, which is low baseline variability. Late decelerations. Decelerate means to slow down, and late means near the end of a contraction. So the heart rate slows down near the end or after a contraction. This is bad. So what you do is LION, L-I-O-N, left side, IV, O2, notify. Early decelerations. What would this mean? Early decelerations. Baby's heart what?
Slows.
Slows. Why did you say slows? Decelerate. When? Before a contraction or at the beginning of a contraction. And this is fine. This is normal. It's no big deal. So you just document it. Which brings up the last tracing. Variable decelerations. This is very bad. Think of variable, very, 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 variable, very bad, variable, very bad. So when you see variable, think, oop, very bad. How very bad? Well, this is prolapse chord. This is what happens when you prolapse a chord. So what do you do for this? Push, position. So of the 7 abnormal fetal heart tracings, which one is the most unique? Variable. And it's very bad. So it's the only one which is treated by push position because it's prolapse. Now, if we look at the remaining 6, how many are good and how many are bad? 3 are good, 3 are bad. What do you notice about all the ones which are bad? They begin with the letter L, which is the first letter in lion. So if you get a fetal heart tracing that begins with the letter L, what do you do for it? Lion. And so is it good or bad? Bad. So if it doesn't start with an L, it's okay, unless it's variable, in which case it's very bad. So if you want to know your fetal heart tracings, just look at the first letter. Starts with L, it's bad, it needs lion. If it doesn't start with L, it's okay, but if it's variable, it's very bad. It needs the prolapse routine, the push position. So do you feel a little bit better about those? There's one other thing I wanted to show you that tells you what they are. You know, what are they? What do they mean? And I'll see, you probably have heard of it, but for some of you that haven't heard of it, this might work. I've told you what the implications of them are, but what are they? Write the word veal, you know, like young beef veal. So write veal vertically down, and then write chop, like lamb chops, pork chops, veal chop. Do you see what I'm saying? So veal chop. Now what this is this is the first letter of the tracing, and this is the first letter of what it means. So variable would be what? V would be variable. That is chord compression. Do you see that? Variable is chord compression. What would this stand for, the E? Early decel, and that's what it is. What it's caused by starts with an H. So what would that be? Head compression. What would A be? Well, we didn't talk about it, but it's high fetal heart rate acceleration, which is high fetal heart rate, correct? And that's okay. Okay, meaning it's fine. Remember we said that high fetal heart rate was okay? What would L stand for? Late decel. And what would that stand for? Starts with a P. Placental insufficiency. Placental insufficiency. So veal chop. Variable chord, early head, accelerate, okay, late, placental. Veal chop. Yes?
So when we get into the test and we have, all these mnemonics and stuff, when would you recommend the best time to be to write it down, write the stuff down?
When you need it.
Oh, okay.
Not at the beginning.
Okay.
They'll give you a little whiteboard kind of thing, and you'll use that for your scratch pad. When you fill it up, you raise your hand, they bring you another one.
Okay.
You don't erase. They don't like you erasing. They'll freak out if you're erasing. So I would erase just for that purpose. In fact, what I would do is I go like this. But I would be doing absolutely nothing. You know, I wouldn't really be erasing. I'd just be going like this just to freak them out. Okay? They can make me take this test. They can make me sit there, but they can't make me behave. So I always think a little civil disobedience goes a long way. You know, are you in control in this test? No, you have to go take this test. You have to sit where they tell you to sit. They have to take the questions you have to take. You have to do it. So do something, you know, civilly disobedient. You know, wear a pair of clown ears. I don't know. Don't wear underwear. I don't know. Do something that's, you know, where you can sit there and you can say, I'm in control. You know, to give you a little edge. Okay. Ace of Spades. An ace of spades means what answer always wins in a tie. There are certain answers which they're always winners. They just win all the time. And in OB, there is one answer that always wins. And if you've ever worked OB, you'll know what it is. And that is check what? Fetal heart rate. You cannot work OB if you don't know that. No matter what happens in OB, no matter what happens in OB, what is the one question that surfaces all the time? What's the fetal heart rate? She's doing this and doing that. Well, what's the fetal heart rate? Well, this is doing that. Well, what's the fetal heart rate? So you'll always check a fetal heart rate. All right, that's the first stage of labor and delivery, labor. Let's talk about the second stage of labor and delivery, delivery of the baby. This is all about order. What do you do in what order? Well, first you deliver the head. And you say, well, what if it's breech? Come on, don't go breech unless they say it's breech. Okay, go with the common. So it's a cephalic, so deliver the head. Number 2, suction the mouth, then the nose. It always goes alphabetical. You suction the mouth first, then you suction the nose. Then number 3, check for a nuchal, N-U-C-H-A-L, cord. What does nuchal mean? Around the neck. Nuchal means neck. So check for a nuchal cord. Then number 4, deliver the shoulders and the body. In that order. So first out comes the head, then you suction the mouth, then you suction the nose, then you check for a cord around the neck, and then you deliver the rest of the baby. Right? That's the ideal. Number 5, the baby must have an ID band on before it leaves the delivery area. A baby must have an ID band on before it leaves the delivery area. Okay, third stage of labor and delivery. What's this about? Placenta. 2 things you need to know here. Number 1, make sure it's all there. Number 2, check for a 3-vessel cord. Make sure the cord has 3 vessels, 3 blood vessels. How many of each? 2 arteries, 1 vein. Think of the woman's name, Ava. Ava. How do you spell Ava? A-V-A. How many A's are there? 2. That's 2 arteries. How many V's? 1. That's 1 vein. So the woman's name, Ava. 2 arteries, 1 vein. Okay, that's all you really need to know about the placenta. 4th stage of labor and delivery, called recovery, correct? Recovery. That's what goes in that blank, recovery. It's the first 2 hours after delivery of the placenta, right? Now, there are 4 things you do 4 times an hour in the 4th stage. So you're going to write 4 3 times there. There are 4 things you do 4 times an hour in the 4th stage. So what are the 4 things you do every 15 minutes, which means 4 times an hour, in the 4th stage? Well, the first thing you do is vital signs. Vital signs. And you're assessing for signs and symptoms of shock, which is pressures go down, rates go up, you get pale, cold, and clammy. Pressures go down, rates go up, and you look pale, cold, and clammy. Those are the signs of shock. Anything that's called a pressure goes down, anything that's called a rate goes up, and that. Number 2, fundus. Check the fundus. If it's boggy, you massage it. If it's displaced, you catheterize. Number 3, the pads. The perineal pads. Check the perineal pads. Look to see how much she's bleeding. If she is bleeding excessively, she will saturate a pad in 15 minutes or less. So how often are you checking her? Every 15. And when you check her, you put on a new pad. You go back, it's 98% saturated. Is she in trouble or not? 98% saturated. Is she in trouble or not? How many say she's in trouble? How many say she's not? She's not in trouble. Because it has to be saturated, 100%, and 98 is not 100%. And when you learn these rules, you have to live and die by them. You can't start fudging. Do you know what I mean? You can't say, well, that's close to that. Then pretty soon you start, losing your anchors. So 100% means 100%. If it's not 100%, it's okay. But if you put a new pad on her, check her in 15 minutes, and it's fully saturated. If they say saturated, what does that mean? 100%, she's in trouble. But if they say 98% saturated, I'd say she's okay. Close, but she's okay. Number 4, roll her over. Roll her over. In other words, check for bleeding underneath of her. A lot of people will check the pads but won't roll her over, and that's not safe. Because could you saturate half a pad and bleed out underneath? So you gotta do both. So what do you do 4 times an hour in the 4th stage? Vitals, fundus, pads, and roll. Vitals, fundus, pads, and roll. You do those every 15 minutes in that stage, that phase, stage. Okay, turn the page and let's do postpartum. This is talking about postpartum assessment. What do you assess? And usually you're assessing this every 4 to 8 hours. It's either 4 hours or 8 hours. It just depends on whether she's stable or not. And what you're assessing is bubble head. Now there's a whole bunch of stuff here, but I only want you to highlight and know 3 of them. And I'll tell you which 3. The first B stands for breasts. This is not a real important one. The U stands for uterine fundus, and this is the first one you must highlight. This is an important one. Here again, you want it to be firm. If it's boggy, you massage. You want it to be midline. If it's not, you cath them. Just like in the recovery. But there's something new that they will ask here in postpartum, and that is the height of the fundus related to the belly button. Where do you find it? Because what they'll do is they'll tell you how many postpartum days it is, and you got to locate where the fundus should be. It's really simple. All you do is fundal height equals day postpartum. Fundal height equals day postpartum. Now what do I mean by that? Is this. If a woman, here's her abdomen, here's her navel, This is -1, -2, -3, -4, -5, -6. And it's the 4th postpartum day. And they want you to point and click. Okay, here's a hot spot here, hot spot here, hot spot here, one here, one here, one here, one here, one here, and one here. You know, A, B, C, D, E, F, G, H, I. All right? And she's 4th postpartum day. Which hotspot would you click on? G. Because that's how many below? 4. 4 below on the 4th day. Now be careful, because F will be there too. Why would you not click on F? It's displaced. You want it midline. So they will have hot spots so that you'll get the right level, but if you're not precise, you'll be off to the side, and you don't want to be off to the side. You want to be in the middle. Okay, the next 2 B's are bladder and bowel. They're not a big deal. Bladder and bowel. The L is lochia. L-O-C-H-I-A. This one is the second one you highlight. This is the second important one. They are rubra, serosa, and alba. Rubra, serosa, and alba. Rubra is R-U-B-R-A. Serosa is S-E-R-O-S-A. And alba is A-L-B-A. Now it occurs in that order. First, by the way, the lochia is the vaginal drainage. Rubra is first, then serosa is second, and alba comes last. Now they want to know what color they are. Okay, if you rub, do you see rubra has the word rub in it? If you rub and rub and rub something, what color will it turn? Red. So rubra is red. Serosa has the root rosa for rosy. If your cheeks are rosy, what color are they? Pink. So rosa is pink. And alba, if you are an albino, what color are you? White. So alba, albino, white. So rub red, rosy pink, albino white. Rubra, serosa, alba. Now the amount. 4 to 6 inches on a pad an hour is okay. Excessive is saturated pad in 15 minutes or less. It's the same idea. The E stands for episiotomy. Episiotomy. No big deal. It's an incision. The H stands for hemoglobin and hematocrit. No big deal there. They're not going to focus on that. The E stands for extremity check, checking the extremities. This is the third important one you must highlight. And right now, on this one, they're looking for thrombophlebitis. So they want to know what's the best way for you to determine if a person has thrombophlebitis or not. What's the best way? Exactly. Bilateral calf circumference measurement. Measuring their calves. How many have heard of Hohmann's sign? That's not going to be the best answer. Now, it's not a horrible answer, but it's not the best one. Because you can have a positive Hohmann's sign and have equal calves and not have thrombophlebitis. And you can have thrombophlebitis and not have a positive Hohmann's sign. So it's not as reliable or valid. Some places don't even want you to do it. A stands for affect. Means you're emotional. Don't worry about Bowlby's stages. You know, latching on, letting go, taking in, throwing up. I don't really know what they are. You know, but you've ever heard of those?
Yeah.
Don't worry about all that. That's nuts. And then D, discomforts. And there's really no big deal there either. So the three big things you're going to be tested on in postpartum are what? The fundus, the lochia, and about thrombophlebitis. Anybody ever work postpartum? That's the three big things you talk about in report. You know, where's the fundus? How's the lochia? And how are her legs? She got thrombophlebitis. Okay, turn the page. Let's talk about variations in the newborn. Yes?
No, the durations and intervals are different lochia.
No. The number of days when things go all varies. Boris likes to test what does not vary. The lengths vary, but the order never varies, and what they are never varies. So it's just like with Chadwicks, Goodells, and Hegars. They're not going to say what week or what month. They're just going to say what order and what is it. Okay, variations in the newborn. All of these things are normal. So I just wanted you to know that. I'm not going to read it to you. You don't have to have it read to you. But all of these things are normal, even though some of them sound bad. Look at number 4. Erythema toxicum neonatorum. Sounds horrible, doesn't it? But it's just a rash. It's no big deal. The only thing specifically I would want you to know from this page, other than the fact that all these are normal, is the difference between number 6 and number 7. Because they always test about the differences between 6 and 7. Caput succedanum and cephalohematoma. What do they always want to know?
One bleeds and one doesn't.
What's that?
One's bleeding.
One's bleeding, and that would be hema. And then also what else? Which one crosses sutures? Which one does not? Which one's symmetrical? Which one's not? The easiest way I know to memorize that is look at their initials. What are the initials of caput succedanum? CS. What could CS stand for? Crosses sutures. So the one whose initials are CS is the one that indeed crosses the sutures. So what about cephalohematoma? What are its initials? C or CH. Certainly not CS, so it does not cross sutures. And of course, the one that crosses the sutures is also the one that is symmetrical. So I always say CS stands for crosses sutures and caput symmetrical. And Leonid, on number 8, it's talked about the hyperbilirubinemia. Normal physiologic jaundice appears after 24 hours. So there's a reminder of the difference between physiologic jaundice and pathologic. Okay, the last page, OB meds. Top 10 group, you've got to know your OB meds. Now, good news. You don't have to know much about your OB meds, because you're not expected to be an expert in OB meds, but you've got to know generally what they are and just a couple of things about them. So rather than fill you full of all kinds of stuff you don't need to know, let's focus on what you do need to know with these 6 different meds. The first 2 meds are tocolytics, which stop labor. They are terbutaline and mag sulfate. These are drugs you give to women who are threatening prematurity and you want to stop their labor. Terbutaline, the only thing you need to know about it is that it causes maternal tachycardia. It speeds mom's heart rate up. That's really all they'll test on that one. That it stops labor and speeds up the heart. Mag sulfate will also stop labor. If you give a person a lot of magnesium, what electrolyte imbalance will you create? Hypermagnesemia. And you know that magnesemias do the opposite. So a high magnesium makes everything go down, so the uterine contractions will go down. Well, the only problem is, so will everything else. So what will your heart rate do? Go down, write that down. What will your blood pressure do? Go down, write that down. What will your reflexes do? Go down, write that down. What will your respiratory rate do? Go down, write that down. And what will your LOC do? go down. Write that down. So, mag sulfate, yes, the good news is it stops the uterine contractions. The bad news is it brings everything else down too. Which of those two do you think are the top two that boards will check your knowledge on? Respiratory and reflexes. They'll want to know, what does mag sulfate do to the respirations and what does mag sulfate do to the breathing? And it lowers both of them. So, when you're giving mag sulfate to a patient, you must monitor what two things?
Reflexes.
Reflexes and respiration. What are your parameters for titrating the mag sulfate? And LPNs, what parameters would you use when you notify the RN about it? 12? Okay, so what do you mean 12?
12 respirations.
Yes, so as long as the respirations are above 12, what do we know about the mag? Is it okay or not? It's okay, but if it goes below 12, what do we need to do with the mag? Slow it down. LPNs, you notify the RN of that. What about the reflexes? What do we want for reflexes? 2. We want +2. So if it's +1, what do we do to the mag? Slow it down. If it's +3, what do we do to the mag? Speed it up. So what do we want? 12 and 2. We want at least 12 respirations and we want 2 reflexes. What we don't want to see is 11 and 1. We don't want to see 11 respirations and lower, and we don't want to see 1 reflex and lower, +1 and lower. So 12 and 2 is good, 11 and 1 is bad. Okay, the next class of OB drugs are the opposite of the tocolytics. They are the oxytoxics. Now the oxytoxics stimulate and strengthen labor. Remember, the tocolytics stopped it. These ones start it. The most famous is Pitocin. We've talked about it before. The big thing you need to know about Pitocin is it can cause uterine hyperstimulation, which would be defined as what? Uterine contractions what? Longer than 90 seconds, closer than every 2 minutes. If you see that, back off your pit. Remember that before from the last couple of pages? Longer than 90 seconds, closer than 2 minutes. The next drug that will cause your uterus to contract is methergine. And the only thing you need to know about methergine is it causes high blood pressure. Now, if it's going to contract blood vessels and contract the uterus, if it contracts blood vessels, what's it going to do to the blood pressure? Increase. Does it make sense that vasoconstriction increases blood pressure? So do you see the 2 M's, methergine and mag? They're both used in OB, methergine and mag, right? What does one do to the blood pressure? Lowers it. Well, the other one does what to the blood pressure? Raises it. So one of the M's lowers the BP, the other M increases the BPO. Okay, the next 2 meds are the fetal lung maturing meds. The meds to make a fetus's lungs mature faster. The first one is beta-methasone. What is it? Steroid. And the other is Survanta, which is surfactant. So just let me talk about 3 things you need to know about each. With beta-methasone, number 1, it is given to the mother. Mom gets the beta-methasone. Number 2, it is given IM. And number 3, it is given before the baby is born. Before the baby is born. And you can repeat it as long as the baby is in utero. However, Survanta, on the other hand, 3 things about it. Number 1, it is given to the neonate, to the baby, not to the mother. It's given to the baby. Number 2, it is given transtracheal, which means blown in through the trachea. And number 3, it is given after the baby is born, not before. Cervanta is given to the baby transtracheally after the baby is born. Whereas betamethasone is given to the mother IM before the baby is born. They both are given to make the baby's lungs mature faster.
They blow it.
Cervanta is blown in.
What do they use?
They use a nebulizer kind of thing. They can even put it in a connection to a ventilator. Puff it in. Okay. That's it on OB. We're done with OB. That's the longest lecture of the whole review. That's why I like to split it up with lunch. Okay, we're going to go to page 51, medication helps and hints. This is a very short lecture just designed to help you get some basic facts down. Because if you don't know these facts and you miss these questions, you're in a major hurt. The first one is, what is Humulin 70/30? What is it? It's a mix of insulins, of R and N. Now you can have Lispro 70/30, but that's a variation. When they say 70/30, they're talking about N and R, basically. Now, 70 and 30 are percentages. So it means it's 70% one and 30% the other. Which one is which? 70% is N, and 30% is R. So if you give 100 units, which you would never do, it's way too much, but if you gave 100 units of 70/30, how many units of N would there be? And how many units of R would there be? If you gave 50 units of 70/30, how many units of N would there be? 35. How many of R would there be? 15. You see, it's just you just multiply the percentages. You know how to get a percentage? Just take that number and multiply by 0.7 for 70, 0.3 for 30. The way I remember that N is the 70 is 70/30 is like a fraction. What do you call the top term in a fraction? What letter does that begin with? N. So N is in the numerator. Number 2, can you mix insulins in the same syringe? Yes or no? Yes. When you draw it up, is there a certain way to do it? Which one comes first? Everybody says clear to cloudy. Boards doesn't use the words clear or cloudy. They talk about N and they talk about R. Now those of you that are taking the NCLEX RN, this will work better for you. But is that what you want to be? Then do it that way. RNs will do it this way, meaning draw up the what first? R followed by the N. That way you don't get into this clear cloudy garbage. Okay, RNs do it that way. Now if you're talking about pressurizing the vial, which vial would you inject the air into first? The N, then inject the air into the R, then draw up the R, then draw up the N. So it's N, R, R, N, but it always ends in RN. Injections. They will tell you what injection you're giving, and they will ask you what needle you're going to use. What needle will you use for giving a particular injection? Here's how you do that. If they say you're giving an IM injection, and they want to know which needle you'll use, 21 gauge, 5/8 inch, 22 gauge, 1 inch. 21 gauge, 1 inch. 25 gauge, 5/8 inch. They want to know which one of those needles will you use for IM? The clue is in the abbreviation. Look at the first letter of the abbreviation. What number does that look like? A 1. Go pick the answer in which both parts have a 1 in it. Which one would that be? C would be your answer. Did you see that? Why is C the answer? Because both the gauge and the length both have a number 1, because an I looks like a 1. Okay, but what about this? What if they changed it to sub Q? Here again, look at the first letter in the abbreviation. What is the first letter in the abbreviation? S. What number does an S look like? A 5. Go pick the answer that has a 5 in both of the parts. And the answer would be D. Because you've got 25 and 5/8. So when you're asked to pick a needle, just look at the abbreviation, look at the first letter, and go find the numbers. Okay, turn the page. We're going to talk about heparin and Coumadin because they're in the top 3 most commonly tested drugs on boards. If you don't know these, you're in trouble. Heparin versus Coumadin. Very, very important. Heparin. It is given IV or sub-Q. Coumadin is given only PO. See, I'm comparing and contrasting is what I'm doing, everybody. Go back to heparin. Heparin is working immediately. Works immediately. Go to Coumadin. Coumadin takes a few days to a week to work. Anywhere between a few days to a week. Go back to heparin. Heparin cannot be given for longer than 3 weeks. And in parenthesis put, except for Lovenox. Remember, the Lovenox can be given for a long time. Regular heparin cannot be. Yes?
4 weeks, you said?
3. Because in 21 days you start making heparin antibodies, which could be really life-threatening. Coumadin can be given for the rest of your life. Can you not? You can take Coumadin forever. Go back to heparin. The antidote to heparin overdose is protamine sulfate. They love that kind of stuff. Coumadin. What's the antidote to Coumadin?
Vitamin K.
Vitamin K. How do you remember that? Yeah, k, and p. Heparin, protamine, Coumadin, K. Go back to heparin. The lab test that monitors heparin is the PTT. PTT, which is the partial thromboplastin time. They'll give you both names. The one that monitors the Coumadin is the PT, which is the INR, from which the INR is derived. Now the way I remember that is several ways. If you have your hands, you can go what? H-E-P-A-R-I-N. How many fingers are left? 3. P-T-T. Okay, let's spell Coumadin. C-O-U-M-A-D-I-N. How many fingers are left? 2. P-T. Or you can cross. You can write P-T-T, cross them together. What letter does that make? H. which stands for heparin. Any of you guys computer people? Have you ever seen this? HTTP? Read it backwards. PTT is H, which is heparin. Okay? So you can do it either way, any way you want to do on that one. Heparin can be given to pregnant women. Coumadin cannot be given to pregnant women. Heparin can be given to pregnant women. Coumadin cannot be given to pregnant women. By the way, speaking of pregnant women, what's the only major antipsychotic tranquilizer that can be given to pregnant women? Remember all those Zines and Zapines? The only one that can be given is Haldol. Haldol is the only one you can give, antipsychotic you can give to pregnant women. Has nothing to do with what we're talking about, but I just thought we'd throw it in. The next thing is the K-wasting and K-sparing diuretics. K-wasting and K-sparing diuretics. Probably the only question you'll ever get about a diuretic is, does it waste K or does it spare K? The easiest way I know to do this is this. Any drug ending in X, any diuretic ending in the letter X, X's out K. So if it ends in X, it X's out K. So what is it? A waster or a sparer? If it ends in X, it X's out K. It wastes it, yes. Plus diuryl. So the K-wasters are all the diuretics that end in the letter X plus diuryl. If it does not end in an X, and it's not diuryl, it's a sparer. So I'm going to give you a bunch of drugs and you tell me whether they're wasters or sparers. Spironolactone. Aldactazide. Moderatic. Sparing. Lasix. Bumex. Clotrix. Esadrex. Demodex. Diuryl. Wasting. And yeah, so you got it? Okay. And baclofen. Baclofen is the last drug I want to talk about. Boards test muscle relaxants as a class. And you need to know your muscle relaxants. Now, the only thing they test about muscle relaxants is the 2 side effects and the 3 teachings. 2 side effects and 3 things to teach. The 2 side effects of a muscle relaxant are fatigue and muscle weakness. Does that make sense? That a muscle relaxant would make you tired and relax your muscles. Fatigue and muscle weakness. The 3 things you teach are don't drink, don't drive, and don't operate heavy machinery. So what do you have to know about baclofen? What are the side effects? Fatigue or drowsiness, right? Drowsiness, fatigue, same thing, right? And muscle weakness. What do you teach them? Don't drink, don't drive, don't operate heavy machinery. Now the other drug that they test is Flexeril. F-L-E-X-E-R-I-L. That's the other muscle relaxant they test. Flexeril and baclofen are the 2 muscle relaxants they test. I am not going to teach you how to remember that Flexeril is a muscle relaxant, because if you can't figure that one out, I can't help you. Right? So Flexeril you should remember is a what? Because you flex your muscles. Well, how in the world are you going to remember that baclofen is a muscle relaxant? Well, I always say this. When you are on your baclofen, you are on your baclofen. Which means you're doing what? If you're loafing, what are you doing? Aren't you relaxing? So there's your clue. It's a muscle relaxant. Because baclofen puts you on your back loafing. It's a muscle relaxant.
Mark,
Yes.
back to the wasting diuretic.
Yeah.
Remember how you said it might change things to more generic? What about
Yeah.
like furosemide and things
The
like
the
that?
semides, SEMIDE, SEMIDE are the X's. Semides are typically X's. Semides, SEMIDES. Not all of them, but most of them. Okay, let's talk about pediatric teaching on the next page. We've only got 3 left, guys. Actually, 3.5 left, so we're cool. This takes about 5-10 minutes, this one, because it's very short. It's just a review of Piaget's theory of cognitive development. Have you heard of that? You do need to know Piaget's theory, but they will never mention Piaget's name. They will test your knowledge of Piaget's theory of cognitive development by asking you how you would teach children. And you're supposed to, if you get a pediatric teaching question, that's a chance for you to show your knowledge of Piaget. So let's talk about it. Piaget has 4 stages for kids thinking. The first one is the 0 to 2-year-olds who are in the stage of sensory motor thinking. In the middle column, Piaget says these kids are totally present oriented. They don't think about the past. They don't understand the future. They only think about what they are sensing or doing right now. So, when do you teach these kids? Can you teach them ahead of time? Why? Why no? They don't understand the future. Can you teach them after you do it? No, they can't understand the past. So when do you teach them? While you do it. So when? While you do it. You teach them as you do it. What do you teach them? What you are doing. Do you notice the present tense there? What you are doing? And how? Verbally. Just tell them. Don't use play. They don't understand play. So if you get a kid from 0 to 2 years of age and he's going to have a spinal lumbar puncture and they want to know how you're going to teach him, what are you going to say? While we do it, we're going to tell him what we are doing. Bingo. That's all you do. There really is no such thing as pre-op or pre-test teaching for this age group. For this age group, who do you pre-teach? The parents, not the kid. Okay, the second stage of Piaget is the 3 to 6-year-olds. He calls them the pre-operational, which I like because 3 to 6 is a preschooler, correct? And he calls it pre-operational. So the 2 pre's go together. Preschooler, pre-operational. They are fantasy-oriented. They are imaginative. They are illogical. Their thinking obeys no rules. You cannot reason with a preschooler. If they can think it, it can happen. I mean, you can't, they're just, whatever. Well, do they understand the future? Yes. Do they understand the past? Yes. So when would you teach these kids? Would you teach them before? Yes. How long before? Or doesn't it matter how long? Shortly before. So here's the deal. Pick an answer that says the morning of or the day of. Or something like 2 hours before. That is fantastic preschool. Because you don't want to give these kids a whole lot of time to what? Get their imagination going on it. You see what I'm saying? My kids never, at this age, my kids never knew they were gone to the doctor's office until they pulled into the parking lot of the doctor's office. Otherwise, we'd have had disaster. That's why they never rode with me after that. No, what do you teach them? What you are going to do. What you are going to do. What tense are we talking in now? Future. What tense did we talk in with the younger ones? Present. So how old does a kid have to be before you can start using future tense verbs? 3, at least 3. Good. How? Play. These are the kids that learn through play. So in a nutshell, if you've got a 4-year-old who's going for a lumbar puncture, how do you teach him? When? The day of, you tell him what you're going to do using play. Some kind of a play thing. Alrighty? A story, a book, equipment, whatever. Dolls. Okay, the next stage are the 7 to 11-year-old concrete operations kids. The way I remember that 7-11 age is concrete is, have you ever seen a 7-Eleven grocery store? What's it surrounded by? Any flowers, grass, trees? No, just a bunch of concrete 7-Elevens. So just think of concrete 7-Elevens. You got 7-11 age concrete operations. These kids are rule-oriented. They live and die by the rules. They cannot abstract. With these kids, they are so rigid. If you tell them this is the way it's going to be, that's the way it has to be. How many, at 7 to 11, that age group, how many ways are there to do things? One and only one, and every other way is wrong. This is the age where the parent hears, the teacher said, and the teacher hears, my parents said. Now, have you ever taken care of these kids? This age group? Did you ever change the dressing for them or something like that? What do they always tell you when you change their dressing? You're doing it wrong. Which means what? You're not doing it like the other person did it. Now, are you doing it wrong? No, but they don't know that. They're so rigid. So, when do you teach them? Days ahead. Because they're not going to blow it out of proportion. If you tell them this is what's going to happen, 3 days later, that's what they think is going to happen. So you can teach them a day or two ahead of time. So how old does a child need to be before you could teach them the day before? 7. Now you can give a little one, a 3 or a 4-year-old, a tour of the facility. You just don't tell them what's going to happen there. Do you understand what I'm saying? Tours are okay. You can give anybody a tour. What are you going to teach them? What you're going to do plus skills. What you're going to do, plus you can teach a 7 to 11-year-old how to do skills. You cannot teach a 3 to 6-year-old how to do skills. Why? If you teach a 7 to 11-year-old how to do a skill, how will they do it every time? Exactly the way you taught them, because they're rigid, concrete. If you teach a 3 to 6-year-old how to do a skill, how will they do it? Any way they can imagine. You teach a 3 or 4, 5-year-old how to give themselves insulin, they'll do it just fine for you. Then the next day, what will they do? Well, I think I'll not put anything in there and I'll just jab it out. And then the next day they go, oh, why don't I give it to the dog? That'll work. They just don't, ugh. So what age does a child have to be before you could teach them a skill? 7. How? Use age-appropriate reading and demonstration. Use age-appropriate reading and demonstration. Okay, the next age group are the 12 to 15-year-olds, and they are formal operations. These kids can abstract. That's the big, huge thing that they can do that the younger ones can't. They can abstract, and they can think cause and effect. So here's the good news. As soon as a kid hits 12 and they ask you about teaching, it's not a pediatric question anymore. It's an adult med-surg question. Because when do you teach a 12-year-old and above? Like an adult. What do you teach them? Like an adult. How do you teach them? Like an adult. So, at what age is a child first taught like an adult? 12. Trick question. When's the first age that a child would be able to manage their own care? 12. Why can a 7-year-old do the skills related to their care? Could they manage it? No. What does manage mean? Make what? Decisions which require abstraction. Because if you got a board question like this, which of the following 4 children could manage their own care? A 7-year-old with cystic fibrosis? No. An 8-year-old with diabetes mellitus? No. A 10-year-old with a scraped knee? No. A 13-year-old with chronic renal failure? Yes. Why did they put the 10-year-old with a scraped knee in there? To fool you, because it's not the severity of the illness that determines who can manage, but the age of the kid. Why could a 10-year-old not manage a scraped knee? What will you teach a 10-year-old to do about a scraped knee? You'll tell them to do what? Wash it, dry it, put on Neosporin and a Band-Aid. Okay, what will he do the next day? Wash, dry, Neosporin, Band-Aid, because they do it exactly the way you said. So what do they do the third day? Wash, dry, Neosporin, Band-Aid. The fourth day, it's swollen. What will they do? Wash, dry, Neosporin, Band-Aid. The next day, there's pus coming out of it. What will they do? Wash, dry, Neosporin, Band-Aids. The next day, it's swollen twice the size of the other leg. What will they do? Wash, dry, Neosporin, Band-Aid. The next day, they're semi-comatose, and they've got red streaks coming up and down the leg. They can barely get out of bed. What will they do? Wash, dry. Are they managing? No. That's why they can't do it. But a 13-year-old with a chronic renal failure, if they are taught auscultate your shunt every day to hear a bruit, if they don't hear a bruit, what will they do? Get help. That's managing. Managing doesn't mean doing everything. Managing means knowing when you can and when you can't and what's necessary. So just be careful. If they say manage, it's a 13-year-old. If they say skills, it's a 7-year-old. All right. Let's go to page 58. I want you to read this. This is for you to read about and learn about. It's about how to take psych tests. All it is a bunch of 7 principles you have to obey. The first principle says, make sure you know what phase of the relationship you're in. Remember the nurse-patient relationship? Pre-interaction, introduction or orientation, working, and termination phase. Remember that? This tells you how to answer in each of those phases. The second principle is gift giving, which means don't give gifts in psych. Don't accept gifts in psych. If your schizophrenic gives you flowers, don't accept them. Why? Because to you it's just flowers. To them it may be a marriage proposal. And when you accept it, you're in trouble, okay? Number 3, don't give advice. If the patient says, what do you think I should do? What should you say? What do you think you should do? I know it sounds corny, but that's what they want you to say. Don't give them advice. Now, can you give advice in med-surg and peds? Sure, but not in psych. Because if a mother says to you, how should I care for my child's PICC line when she goes into the shower? You should not say, how do you think you should care for the PICC line when she goes? Do you know what I'm saying? It's stupid in med-surg. It makes sense in psych. Number 4, don't give guarantees in psych. Don't say, if you cry, you'll feel better. If you talk to me, we can help you. Remember, all those are guarantees. Don't do that. On that next page, immediacy, and you can read all about this. I'm just showing you what it's about. Immediacy says, if a patient says something, what's the best answer? The one that keeps them talking. If you're between 2 psych answers and you don't know which one to pick the one that keeps the patient talking. The one that says, let's talk about her right here and right now. Let's keep talking. Don't pick answers that say, refer them to the social worker. Why? If you're referring to the social worker, what are you doing to the communication right then and right there? Shutting it off. Don't do that. Even if it's appropriate for the social worker to deal with. Do you see what I'm saying? Keep them talking. It's never wrong to get your patient to talk. Did you hear what I said? It's never wrong to get your patient to talk. So if one of the answers gets that patient to talk, you better pick that. Because if you don't, you're saying it's wrong to get a patient to talk. It's never wrong to get a patient to talk. That rule alone can really help you on psych questions. If you're sitting there and you're between two answers, for example, like a woman has had a breast biopsy, and she says to you, when will the results come back? Do you think I have cancer? My sister had cancer. She died of breast cancer. What's your best response? And you're between A, which says, your results will come back in 2 to 3 days and the doctor will discuss them with you. Or B, which says, you're concerned about what the results may show. Both of those are okay. But one of them doesn't get her to talk. The other one gets her to talk. Which one gets her to talk? B. Now, is there anything wrong with A? It's absolutely 100% correct. But it says, the results will come back in 2 to 3 days. The doctor will talk to you. Talk to the hand that cares. You know what I mean? Talk to someone who cares, because I don't care. Whereas, you're concerned about what the results may show gets her to talk. But you see, that's a real dilemma that a lot of people get into. So when you're between two psych answers, remember, it's never wrong to get the patient to, so it's probably always right. Okay, concreteness, number 6, means don't use slang. You know, if the patient says, I feel rotten about what I did, don't say, you feel rotten? Because then they go, oh, maybe I have, maybe I'm, rotting away. And don't tell an upset patient to chill out. You'll probably find him in the refrigerator. Because psych patients take you what? Literal and concrete. So don't say to a client, oh, what goes around comes around. Now they're going like this all day long, because they're worried about something going around and coming around. That's figurative speech. That stinks in psych. If a patient says to you, you're a real Brinslevik, what should you say?
What's a Brinslevik?
Ah, I tricked you. Brinslevik is not what? Concrete. So you wouldn't say, what's a Brinslevik? You'd say, you're confused about what my role is here. I know it sounds really stupid, but that's what they're going to say. Or you're a real Brinslevik. I see you're angry. You see what I'm saying? That's perfect. You don't use the dumb word they used. You know what I mean? You're a Shabazniak. What's a Shabazniak? No, you don't go there. Don't go. You don't, believe me, you don't want to go there. Now, you may want to go there because sometimes it's really fun to hear about it. It can be very entertaining, but that's what makes me a bad psych nurse. Okay. The one I want to camp out on is empathy here. You got to know empathy, because they won't license a nurse who's not empathetic. Believe me, they won't. Empathy says the best psych answers are those answers that communicate to the patient that the nurse accepts the patient's feelings as being valid, real, and worthy of action. Empathy is all about feeling. Do you remember we talked about this the other day? Acknowledge feeling. You're empathetic. Always be empathetic. Here are some really bad answers. If you ever see an answer written this way, don't even finish reading it. It isn't worth your time. Here's a really horrible one. Don't worry. Don't feel. You shouldn't feel. I would feel. Anybody would feel. Nobody would feel. Most people feel. All of those are as stupid gets. I saw a question in a review book that shall remain nameless called Saunders that said that a woman had a miscarriage and was crying. And they wanted to know what the nurse should say. And they said that you should say, I know how you feel. I had a miscarriage too. Now, it's true, you did have a miscarriage. You know what I'm saying? It's not that you're lying. But they said you should say that. I'm telling you, you never say that. That is the stupidest answer I've ever heard. You say something like what?
Tell me how you feel.
Well, remember, I don't like tell me how you feel. That's very upsetting. Yeah, that is so sad. Everything that has happened is so devastating. You see, we don't like to say, how are you feeling? We want you to look at the scenario and assume. Remember, you're always told, don't read into questions. But on these ones, you have to read the feeling into what's going on. This is the one place where you have to read into the question. If you don't read in, you're going to miss it. Because see, if she's crying and you say, how do you feel? That's kind of, well, how do you think I feel? You know what I mean? But I see you're so sad. This is just devastating. You know, that's good. You don't say, I know how you feel. I did it too. You know, who cares? Who cares? Okay, turn the page. I want to teach you a 4-step process for answering empathy questions. And if you use this, you will do really well with them. Number 1, recognize that it's an empathy question. Empathy questions always have a quote in the question, and each of the answers is a quote. Have you seen that format? Patient says, quote, da 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 da. What would you say? A quote, B quote, C quote, D quote. When you see that format, what should you say to yourself every single time? Chance for me to show my empathy. Okay, now here's how you do it. Because you're going to have to read. Aren't you going to have to read the feeling into it? Number 2, put yourself in the client's place, their shoes, and say their words as though you really, 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 really meant them. Be an actor. Get into it. Role play it. Number 3, then ask yourself, if I said those words and really meant them, how would I be feeling right now? Okay, now you got your answer. Now you got your answer. All you have to do now is, number 4, go and choose the answer that reflects that feeling or anything close. Do not choose the answer that reflects their words. Because these empathy questions always have what I call the sucker answer there. It's an answer that's wrong, but it's there to sucker you into answering it. And what it will reflect is what the patient said. But it will ignore what the patient felt. You're supposed to pick the answer that reflects what they felt and ignore what they said. Did you hear that? Empathy ignores what is said and goes with what is felt. Don't get it switched around. When people have a hard time answering empathy questions, it's usually because they respond directly to what the patient said rather than how the patient feels. Do you remember when, I don't know your name, but I said, you're a real Brinslevik? If you respond to what they said, you'll say, a Brinslevik? But if you respond to how they feel, you'll say, I see you're angry. Do you see the difference? Now, I want you to do the next 3 questions, practice questions, and I want you to use these rules. Put yourself in the client's place. Say the words as though you really meant them. Ask yourself, how would I be feeling if I said these words? Pick the answer that reflects that feeling. I also want you to identify at least one sucker answer that overemphasizes what the patient said but missed how the patient was feeling. So do that and then talk to your buddy. Stay on task. I'll be right back. The third one is really hard. That third one, the problem with it is when you put yourself in the patient's shoes and say those words, no feeling really pops out. So what you have to do is go to the answers and see what feeling the answers are reflecting and see which one has the most likely feeling. So go to your answers and see if you can get it that way. Well, let me ask you about the first one. She said, "You're killers, you all killed my mother, whatever, she died before I was born." How does she feel? If you said those words and believed them, how would you feel? Scared? Okay, now, go to the answers and find the answer that reflects being scared. Which one is it? B. What is the sucker answer? C. Because that focused on what she said. She isn't concerned about her mother. She's scared. She's frightened. So the answer is B. The sucker answer is C. The next one, what's the right answer? D. And a sucker answer is any of the others. Because the others focused on what he said. D focused on how he feels. Did anybody get an answer on the third one? What did you say? The answer is C. What's the sucker answer? B. Because B says religious. He's not feeling religious. He's using a bunch of religious what? Words. That's the hint that it's the wrong answer. He's feeling out of control. So that's why C is the answer. Because with those words, I can prove to you that he has a control issue. I can't prove to you that he feels religious. So C is the right answer. How many got C on that one? Wow, that's great. How many got all three? Terrific. If you missed any, do you see why you missed it? What were some of the problems you had with that? Anybody? Or you've learned from it? Any questions you have for me about those? Did you use the process? Did the process help? Okay, so that's what I want you to start doing. I don't want you guessing on psych answers. I want you to know the answer. You understand what I'm saying? So many times you guys just guess on psych answers. I want you to know why you're picking what you're picking. Okay. Take a quick break. Come back at 25 after, and we'll just do the last lecture and a wrap-up and be done. Okay? And the sooner you're back, the sooner we'll get done. Page 54. This is the most important lecture in the whole review. Everyone will get at least 15 questions on this. You'll think this is all your test was sometimes. Most people just dead guess on these ones. I don't want you dead guessing. And if they don't get dead guess, they use ABCs. I don't want you using ABCs on this. So let's talk about how you prioritize. Prioritization, delegation, and staff management. The first skill is prioritization. They will be testing to see how you prioritize 4 different patients. Number 1, you are deciding which patient is sickest or healthiest. Now be sure you know which one you're looking for, because sometimes they have you looking for the sickest, highest priority, and sometimes they have you looking for the lowest, healthiest priority. For example, if they said, there's been a disaster in your town and you have to discharge one of the following people to make room for incoming wounded, who would you discharge? Would you be looking for the highest priority client or the lowest priority client? Lowest. But if they said to you, you receive report on all of the following 4 patients, which patient will you check first when you get out a report? What would you pick? Highest. So the point is, sometimes you're picking the highest, sometimes you're picking the lowest. Make sure you keep that in your mind, because sometimes you can start out looking for the lowest and halfway through the question start looking for the highest. You see, so don't get turned around in the middle of the question. Okay, now 4 rules for okay, that's that. Is Linda's not there? Sorry to have to write this way. I just don't have any more open transparencies. What they will do in the answers will always have 4 parts. They'll have an age, a gender, a diagnosis, and a modifying phrase. So the answers will always be a 10-year-old male with hypospadias who's throwing up bile-stained emesis. Well, the age is the age, the gender is the gender, the diagnosis is hypospadias, and the modifying phrase was who's throwing up bile-stained emesis. You got that? They always have an age, a gender, a diagnosis, and a modifying phrase. 2 of those are totally irrelevant, and you do not use them in your answer. Which 2 are irrelevant? Age and gender. When you prioritize, completely get rid of the age, completely get rid of the gender. Do you understand, though, in pediatrics, in a pediatric question, you got to pay attention to the age. But in a prioritization question, you don't pay attention to the age. Because a 2-year-old is not more valuable than a 90-year-old. They're both humans. Do you understand what I'm saying? So age is not a criteria whereby you prioritize. Gender is not a criterion by which you prioritize. Women are not more valuable than men. And men are not more valuable than women. It's irrelevant. Okay, the diagnosis is important, and the modifying phrase is important. Which one is more important? The modifying phrase. The modifying phrase is always more important. So, if the patient had sorry, I'll get rid of this. Okay, if the patient had angina pectoris versus myocardial infarction. Angina pectoris versus myocardial infarction. Who's the higher priority person? The heart attack, the MI. However, look at this. With unstable BP, with stable vital signs. I added a modifying phrase. Do you see that? Now, who's a higher priority? The angina, because he has what? Unstable blood pressure. The myocardial infarction, they told me, was stable because he has stable vital signs. So here we have low priority, high priority, high priority, low priority. We always pay more attention to which one? Modifying phrase. So he's the higher priority, he's the lower priority, regardless of this. Do you see that? That's why you can't use ABC. That's one of the many reasons why you can't. So this person is more stable, this is more unstable. Here's your higher priority, here's your lower. So always break the tie in favor of the modifying phrase. All right? Now let's go to the 4 rules for prioritization, the 4 rules. Rule number 1, acute beats chronic. Acute beats chronic. What do I mean by beats is a higher priority than. In other words, an acutely ill person is a higher priority than a chronically ill person. Now let's look at this, how this works out. If you had the following patients, a COPD, a CHF, and an appendicitis, who would be the higher priority? Exactly. Why? Because what are the other 2? Chronic illnesses. The appendicitis is acute. If you used ABCs, who would be your highest priority client? COPD, and you'd be dead wrong. Are you seeing what I'm talking about? So acutely ill people, would you agree with me that an acute gut is a higher priority than a chronic lung? Absolutely. So acute beats chronic, it's not ABC. Okay, next one, rule number 2 on the next page. Rule number 2. Fresh post-op. Fresh post-op. Now, how fresh would fresh be? How many hours?
24?
12. 12. Not 24. 12. So any post-op in the first 12 hours is a fresh post-op. Fresh post-op beats medical or other surgical. Fresh post-op beats medical or other surgical. Okay, so what about this? Of those people, who is your highest priority? A COPDer, a CHFer, an acute appendicitis, a 2-hour post-cholecystectomy, and a second post-op day coronary artery bypass graft? Who's your highest priority? The 2-hour post-chole. Why? They're fresh post-op, and that beats what? Medical and other surgical. What about this? And a radical neck dissection. Who would win? 2-hour post-chole. And a bilateral above-the-knee amputation. Who would win? 2-hour post-chole. And a right frontal craniotomy. Who would win? The 2-hour post-chole. What's my point? Doesn't matter how bad the surgery is or how involved the surgery is, if you aren't 12 hours in, you aren't high risk. You're recovering. That fresh post-op is much more unstable than this guy, no matter what was done. So don't go on all of this stuff. Go on these time frames. Are you seeing that? Okay. Rule number 3. This is my favorite rule. I use it. I use it. This is the one I use. And that is unstable beats stable. Unstable beats stable. So that means unstable people are a higher priority than stable people. Duh. Who knew that before you went to nursing school? Who knew that in 7th grade? So then why don't you get these questions right all the time if you knew that? Why? Because you don't get them right. Why don't you get them right? You know this, then why don't you get it right?
Telling you the word stable
in the question. Yeah, in the question, there's all these words, and you were never taught what words count for stability and what words count for instability. No school teaches that. I'm going to teach you that right now. It's Cedarville. I always tell the faculty when faculty meets, we got to teach the students what stable and unstable means. Oh, we do. No, they don't. I go in their classes and I listen and they talk in platitudes. You know, if it's life-threatening, it's high. Well, then tell me what's life-threatening, guys. I mean, you can't just be... I need concrete, specific things to look at. So we're going to generate some concrete, specific lists here. Words to look for in an answer. Do you see the two lists? One list says things that make a patient stable, and the other says things that make a patient unstable. What do I mean by things?
Words.
Words in an answer or modifying phrase that makes the patient either what? Stable or unstable. So that you can actually take this to a question and use it, and you'll know what you're talking about. Okay, let's go through the list of things that makes a patient stable. Let's start there. What makes an answer stable? Number one, let's start real easy. Use of the word stable. No, I'm serious. People, I don't know how many people will say, well, it says they're stable, but they could just a second later they could just decompensate and they could herniate and then they could die and that could happen in seconds. So while it's saying it's stable now, they're really like a ticking time bomb, so I'm going to put them high priority. No! They said they were stable. They're stable. Don't argue with the fact that they said they were stable. You have to answer it at this moment in time for this patient. If they said this patient was stable right now, what are they? And if they destabilize in 1 second, we're not talking about that. Do you understand what I'm saying? We're talking about right now when they're talking about this patient. So let's go across to the other list. Things that make a patient unstable. What do you think number one is there? Unstable. Use of the word unstable. And don't argue whether you think they would be unstable or not. They said they were. Okay, next, go back to stable. Go back to the stable column. We're going to bounce back and forth between stable and... You see what we're going to do here? Okay, stable. One thing that makes a patient stable. Number two, chronic illness. Chronic illness makes you stable. So go to the unstable side. Number two, what makes a patient unstable? Acute illness. What rule is that? That was rule number one, wasn't it? The reason why I like this rule is because it grandfathers rule number one into it. Okay, go back to the stable side. A phrase that makes you stable. Post-op greater than 12 hours. If the patient is post-op greater than 12 hours, they are stable. So what makes a patient unstable? Post-op less than 12 hours. Now what rule is that? That was rule number two. So I use rule number three because it includes rule number one and rule number two. Okay, go back to something that makes you stable. Go back to the stable. Local or regional anesthesia. If you had a procedure with local or regional anesthesia, you are stable. So what makes you unstable? General anesthesia. But only in the first 12 hours. Go back to stable, things that make you stable. Lab abnormalities of an A or B level. Lab abnormalities of an A or B level. What am I talking about? Remember this morning?
Yeah.
If you got a lab abnormality, yes, it's abnormal, but it's an A or a B, guess what the patient is? Stable. Okay, then what makes you unstable? Lab abnormalities of a C or a D. So who's unstable? A client with a creatinine of 17.8 or a client with a potassium of 6.1? Potassium 6.1, because that's a D versus an A right there. Go back to things that make you stable. The phrases ready for discharge. And don't argue, oh, I don't really think they'd be ready for discharge that soon. I really don't think they would be. They said they were, they are. So don't argue it. Okay, ready for discharge, to be discharged, or admitted longer than 24 hours ago. Admitted longer than 24 hours ago. So if the patient has been here longer than 24 hours, we assume they are what? Stable. And don't say, well, I don't think it would take that long to stabilize them. They said it. You go with it. So what makes a patient unstable? What phrases? Not ready for discharge. Newly admitted. Newly diagnosed. Or what? Admitted less than 24 hours ago. Exactly. Admitted less than 24 hours ago. Another one. Stable. Unchanged assessments. Unchanged assessments, meaning the assessment is unchanged. It's the same as it's been. There's nothing new. Okay, what makes a patient unstable? Changing or changed assessments. There's something new. There's something different. Okay, we're almost done. Go back to stable. This is a long one, so get it down word for word. The patient is stable. Don't write it down. The patient is stable if they are, here we go, experiencing the typical, expected signs and symptoms of the disease with which they were diagnosed. Experiencing the typical expected signs and symptoms of the disease with which they were diagnosed. A patient is stable if they are experiencing the typical expected signs and symptoms of the disease with which they were diagnosed. Go to unstable. The patient is unstable if they are, and get this down now, experiencing unexpected signs and symptoms. Unexpected signs and symptoms. The mistake that most students make when they prioritize patients is they prioritize based on symptom severity rather than symptom expectedness. In other words, if somebody has severe pain and somebody has mild pain, they will always prioritize the severe pain higher than the mild pain. And that's wrong. If somebody has kidney stones and they're having severe colic pain, are they stable or unstable? Stable. Why? Do you expect severe colicky pain with kidney stones? Right, yes. But somebody's having mild pain with a chest x-ray. Should you have mild pain with a chest x-ray? You should have no pain with a chest x-ray. So who's unstable? The mild pain with the chest x-ray is unstable. The guy with the severe pain with the kidney stone is stable. Did you see what I'm saying? Okay. All right, let's look at how we apply this. How do we apply this? I want you to tell me who the highest priority patient is here. And I want you to use the rules I taught you, okay? You have a 16-year-old female with meningococcal meningitis, right? Who has had a temp of 103.8 since admission 3 days ago. That's your first patient. 16-year-old girl, meningococcal meningitis. She's had a temperature of 103.8 since she was admitted 3 days ago. The next patient is a 67-year-old male with irritable bowel syndrome who spiked a temp of 100.3 this afternoon. I want you to talk to your buddy and decide who, on the basis of the rules I gave you, not guessing, but on the basis of the rules I gave you, I want you to cite who is higher priority and why.
From what he said, then the 67-year-old one was. But I would have picked the other one if I would have been in the
The
tent.
temperature respiration is spiking. Is that
Because now there's a change.
Is that 100.3?
yeah, 103.
Or 100?
130.
100.3.
I would say it's B.
Yeah, this woman's been admitted 3 days ago. So is that expected? 3 days before?
All we gotta do is what they, all we gotta do is what they say.
How many would say, what are you guys saying, A or B? B. B is the answer. Now, what do we rule out right away here? Okay, so we can rule this out. And we can rule that out. Okay, now. Meningococcal meningitis, high or low priority? High because it's what? Acute. Irritable bowel syndrome, high or low? Because it's... Okay, now that's our diagnosis. Let's go to our modifying phrase, which are going to be more or less important. More important, okay. Who has had? What kind of language is that? Who has had? But what criteria are we talking about in your list there? Who said it? Unchanged. Unchanged. Who has had? So automatically that puts her what? Up or down? Down. A temp of 103.8. Now when you get a symptom on these questions, do not look at how bad it is. Look at whether it is what? Expected or not. Remember that? Typical expected. Do you expect anybody with meningococcal meningitis to have a fairly high fever? Yes. Yes. So is this expected? Yes. So does that make her high or low priority? Low. And to put the nail in the coffin, what phrase comes next?
3 days
Mission
ago.
when?
3 days ago.
And that puts her what? Remember, admitted more than 24 hours ago? So she's low. So how many highs does she have? How many lows does she have? 2 or 3. And all the lows are in what area? Modifying phrase. So we're thinking she's what? Low priority. Okay. Who spiked? Changed. High. Okay. Temp of 103. How do you deal with that? What do you say to yourself? Is it expected for an IBS? No, not low. Don't say low. Remember, I told you it's not severity, so don't be talking high and low. Ask, is it expected for an IBSer, irritable bowel, to have a temp of 100.3? No. Actually, for them, it's high. It's not low. 100.3. So that's unexpected. So does that make him high or low priority? High, unexpected. And then to put the nail in the coffin, what did it end with? This afternoon, which means it was new, changed, not been happening. So how many highs does he have? 2 or 3. How many lows? 1. The highs are all in the modifying phrase. Who's your higher priority? B. Now let me ask you that. Does that make sense to you? Now in real life, I said this was low and this was high. Low priority, high priority, right? So who could go home? If it's true that this one's low, she can go home. This one's high, he cannot go home. Is that true? Yes. It is absolutely true. Why? If she goes home, do we know what's happening with her?
Yeah.
Everything? Yes, we know the symptom. We know why she's got a 103.8. We know what it is. It's been that way. We're going to send her home with a home health referral for what? IV antibiotics. And she's good to go. She can go home because she's stable. Can I send this guy home? Why can I not send him home? You don't know what's going on. Do you know what this is? It's not that. So what is it? You don't know. Do you know what this is?
Yes.
Do you know what this is? Yes, it's a symptom of that. Well, I knew she had that. Tell me something I didn't know. I can't send this guy home. This guy could probably ruptured an ulceration, probably is developing septic peritonitis, and we're just catching his temperature on the way up. If I send him home, he's going to come in dead because he's going to go into septic shock and fade out during the night and no one knows it. Do you see why this guy, you can't send him home. He may die. This one, you can send home. How many of you would have picked the meningitis an hour ago? How many would have picked the irritable bowel an hour ago? Nobody? Nobody would have picked it? Do you see what I'm saying? But does it make sense? And do you see why it's true? Okay? Do you see where it says always unstable? I want to give you 4 things that are always unstable, regardless of whether it's expected or not. Remember I told you, when you get a symptom, don't qualify how bad it is, but ask, is it expected or not? Well, there are 4 things that, just because they're there, makes you unstable. Number 1, hemorrhage. If you are hemorrhaging, even if I expect it, you're unstable, right?
Yes.
For example, if I said a client had DIC and hemophilia, which would be rare, but let's say they did, and I said he's hemorrhaging, I don't want you to say, well, you know, hemorrhaging, I would expect a client with DIC and hemophilia to hemorrhage. So since it's expected, it's low priority. Do you see the absurdity in that? There are certain things that even if they are expected are what? Serious and bad. So hemorrhaging is always bad even if you expect it. Does that make sense? Now, do not confuse hemorrhaging with bleeding. Those are two different things. Boards thinks bleeding, hemorrhaging. You know, to them there's a huge difference between bleeding and hemorrhaging. So if you see bleeding, high or low? No, it depends on whether it's expected or not. Gotcha. Hemorrhaging, high or low? High, because it's one of those things. Okay, second one. High fevers, over 105. 105 and over. Why? Even if it's expected, what will a person with a fever of 105 and over do? Seize. So that's high priority. Even like now, what could I have done to this meningitis girl to make her a high priority? Made her temp 105, and then she's there. Okay. Hypoglycemia is the third one, a low blood glucose. A patient has hypoglycemia. Their blood glucose is 8. Don't do this. Don't say, well, you know, I would expect a low glucose with hypoglycemia. So an 8 is stable. Do you see how stupid that is? If you got a low sugar, it doesn't matter if it's expected or not, you are in trouble. Okay? So hemorrhaging, high fever, hypoglycemia. So far they're all H's, right? And the last ones are pulselessness or breathlessness. If you are pulseless or breathless, even if it's expected, you are high priority. Now, how would that ever happen? Well, could you imagine a question like this? The patient has VFib, ventricular fibrillation, or asystole, and you don't get a pulse. High or low priority? Well, you know, if they had asystole, I would expect them not to have a pulse, so they're okay. Do you see how stupid that is? You can't take this to the absurd. Do you see what I'm saying? And I'm trying to show you where the line is drawn. So, with pulselessness, breathlessness, hypoglycemia, hemorrhaging, and high fevers, what are they? Unstable, regardless of expected or not. But everything else obeys the rule of expectedness or not. Do you understand that? That's the way to go with it. Hey, just a real quick question. When is pulselessness and breathlessness actually the lowest priority?
Under death.
At the scene of an unwitnessed accident. At the scene of an unwitnessed accident, if you find anyone who is pulseless or breathless, guess what? They are what? What'd you say? They're dead. They're the lowest priority. But if you witness the problem, who's the highest priority? Pulseless, breathless. So knowing whether to prioritize pulselessness and breathlessness highest or lowest depends on witness or not. Was it witnessed? Was it not witnessed? By the way, what are the 3 things that result in a black tag in an accident, at an unwitnessed accident? What are the 3 things that result in a black tag? You know what I mean by a black tag?
Yeah.
Tag them black and ship them last at an unwitnessed accident. Pulselessness, breathlessness, fixed and dilated pupils, even if they're breathing and have a pulse. Those are the 3 things. If you have any one of those, they're black tag at an unwitnessed. And the hardest one is someone who has fixed and dilated pupils who's still breathing. You know, that's the hard one to leave alone. You know what I'm saying? But you've got to go to somebody else. Somebody else needs your help more. All right, rule number 3. No, rule number 4 on the next page. Rule number 4. This is a tiebreaker. This is a tiebreaker. Caution, only use this as a tiebreaker. I'm totally trying to be totally honest with you. A lot of times when you use those previous rules, you end up with one or about 2 or 3 that could be it. So you need a tiebreaker. The tiebreaker says the more vital the organ, the higher the priority. The more vital the organ, the higher the priority. Now, just a caution here. The organ we're talking about, is it the organ of the diagnosis or the organ of the modifying phrase? The organ of the modifying phrase is what we're talking to. When you do your tiebreaker, do the tie-breaking with the organ in which the modifying phrase is happening, not the diagnosis itself. You got that? Okay, now, what I need to give you is the order of organ vitality. So here it is. The most vital organ in your body is your brain. The second most vital organ is your lung. The third most vital is your heart. The fourth is the liver. The next is the kidney. And the next is the pancreas. After that, no one agrees. But that's good enough. That'll get you what you need. Brain, lung, heart, liver, kidney, pancreas. In that order. So, you have a 23-year-old, does that matter? No. Male. No. With CHF. High or low priority? Low, because it's what? Chronic. With a potassium of 6.6. High, why? It's a CD. It's one of those CD levels. Okay? And no EKG changes. What would that do? Increase his priority or lower his priority? Lower, because they're saying at least he's not affecting the what yet? The heart. Okay? A chronic renal failure with a creatinine of 24.7. High or low? Low. High or low?
It's high.
No, I mean high priority, low priority.
Oh, low.
Why? For two reasons. It's an A level plus it's expected. And this is really not expected with that. And pink, frothy sputum. Why high priority?
Lungs are filling up.
Is a classic symptom of chronic renal failure pink frothy sputum. No. So this person is unstable. This guy's unstable, but asymptomatic. This guy is unstable and having symptoms. So this guy could be beating this guy. It will see. All right? A patient with acute hepatitis, high or low priority, acute hepatitis, high, with jaundice, high or low? Low. Why? You expect jaundice with hepatitis. An increased ammonia level, expected, who you cannot arouse. Expected or unexpected with hepatitis? Unexpected. Okay, so that's an unexpected. So that's what? High. So we got an unstable here, an unstable here, and an unstable there. We got 3 unstable people, right? Okay, who's our highest priority? Okay, potassium. What organ system are we worried about? So we got a heart. Number 1 is a heart. Number 2, we got a what? No, we don't have a kidney. We got a lung. Remember, you go with the modifying phrase, you don't go with the disease. So we got a lung. Right? And then, number 3, we got a what? Don't say liver, right? We got a brain. Okay? So, I go to my tiebreaker. Correct? And who wins? He wins. Are you seeing this? Does that help you? Can you replicate that? Can you actually do that when you go to take your boards? Okay. Does this change some of the ways you might do things? Does it make sense to you why you do it that way? Do you see why it's valid? Okay. Just say, tell me if they're stable or unstable. Angina pectoris. Why?
Just chest pain.
Chronic. Okay. With crushing substernal chest pain. Stable, because that is expected with angina. Not relieved by rest or 3-nitroglycerin. Unstable, because the definition of angina is chest pain relieved by rest and nitro. So if it's unrelieved, it's not angina anymore, it's MI. Now they're unstable. Does everybody see what I'm saying on that? Okay. Delegation. Do not delegate the following responsibilities to an LPN. And LPNs, you're not allowed to assume the following responsibilities if an RN delegates it to you. Now, don't yell at me, I didn't write the list. Okay? I'm just reporting. So don't shoot the messenger. I know that 99% of the hospitals in Ohio don't do this, but this is what the book saith. Okay? Do not delegate the following to an LPN. Starting an IV. And you say, but what if they have IV certification? It didn't say they did, so you're not allowed to assume that they did. Hanging or mixing IV meds. They're not allowed to hang or mix IV meds. Number 3, pushing IV push meds. So what can they do in regard to an IV? Maintain and document the flow. That's what they can do. D, they cannot administer blood or mess with central lines. They cannot administer blood or mess with central lines. So no central line flushing. If I had to go down to the wire on it, I would say they're not allowed to change a central line dressing. But if that was the only thing that they possibly could do, then I might let them do it. But it's going to be, I'm going to really seriously not let them do that unless that's the only option. The next one, they're not allowed to plan care. The RN makes the care plan. The LPN can implement it, but the RN does the care plan. The next one, they're not allowed to perform or develop teaching. What they can do is reinforce teaching. What's the difference between performing and reinforcing? Yeah. So if somebody needs taught about their diabetes, who should do the patient teaching regarding the diabetes? The RN. But can an LPN reinforce the necessity of doing an AccuCheck before you give insulin to a patient? Yes. They're not allowed to take care of unstable patients. So LPNs, that's why you need to know this stable, unstable thing, because you're supposed to know what you're allowed to accept and what you're not allowed to accept. You'd have taken the meningococcal meningitis kid, but you wouldn't take the IBS person. If you remember that illustration. They're not allowed to do the first of anything. If they're doing the first, if there's something that's being done for the very first time, who should do the very first? The RNs, because what are they going to do? Assess and care plan. So can an LPN perform tube feedings? Yes or no? Sure. Can they do the first tube feed after a G-tube was inserted? No. Can they change post-operative dressings? Sure. Should they change the first post-op dressing the day of surgery? No. Can they feed stroke patients? Sure. But they shouldn't do the first feeding of the stroke patient after the feed. Can they ambulate post-op clients? Of course. Should they get the patient out of bed the very first time after surgery? No. Can they take vital signs? Should they take the first set of vital signs after a patient came back from surgery? No. And that's one that nobody ever does. But I do it as an RN. I even see hospitals that are so stupid that they let aides take the first set of vital signs after surgery. That's ridiculous. Somebody's waiting for a lawsuit to happen on that one. You won't stand up 5 minutes in court if that happens. Yes?
For dressing changes, is it true that you're really supposed to let the surgeon?
That is, RNs, boards would allow an RN to do the first dressing change. It is tradition to allow the surgeon to do the first one. Do you see my point? But boards is more, we as nurses, we are the world. You know, that kind of thing. You know, more assertive kind of thing. And are you with the last one now? Mm-hmm. They're not allowed to do the following assessments. They're not allowed to do the following assessments. Admission. Discharge. Transfer. Or the first one after a change. The first assessment after there has been a change. Who has to do the first assessment after there has been a change? The RN. Because they have to assess, plan, the whole bit. So what about this? In report, a nurse says, I think I heard crackles on that guy in 52. He's never had them before. I think that he has had them. I mean, no, I think I heard them. Who would be the person that should go assess that person in the morning? The RN. Something may have changed. Okay, so who should the LPN check? Who would you send the LPN to check? And LPNs, who would you go check?
Stable people.
A patient with angina pectoris with crushing substernal chest pain who was admitted 3 days ago and is on nitroglycerin. A patient with a subtotal thyroidectomy 2 days ago who says, why are they washing elephants in the parking lot? Who should the LPN check? Who should the RN check? A for the LPN, B for the RN. Why B for the RN? What's going on, man? Subtotals get storm. And what's a symptom of storm? Delirium. It could be that person's going into storm. We don't know it. But the angina with the substernal crushing chest pain and the night, that's all totally. But why are they doing that? Why do they always give you the crushing substernal chest pain versus somebody that says, why are elephants in the parking lot? They know that people, including nurses, when they hear crushing substernal chest pain, they go what? Whoa! You know, but don't go whoa because it's no big deal. It's expected and you're going to treat it and it's nothing. Does everybody understand that? Mm-hmm. Make sense? Okay. Now, do not delegate the following responsibilities to an aide. They won't call it an aide, they'll call them a UAP, unlicensed assistive personnel. When they talk about a UAP, it's an aide, a tech. Here's what they're not allowed to do, charting. Now, they can chart what they did, but they can't chart about the patient. They can chart what they did, but they can't chart about the patient. So could they chart side rails up, bed in low, call light in reach, bed bath given? Could they chart patient less anxious today, tolerated ambulation well? No. Secondly, they're not allowed to give meds. Except for what? What meds can they give? Topical, over-the-counter barrier creams. Aides can independently apply topical, over-the-counter barrier creams. So can they give nitroglycerin ointment? It's topical, but it's not over-the-counter. Okay, good job. Can they apply Neosporin ointment? Technically what? Because it's what? Not a barrier. Do you see what I'm saying? What about hydrocortisone cream? Probably not. What about A&D ointment? Alpha Cari lotion. Yeah, see what I'm saying? So those barrier creams they can do. What about Elase ointment for the skin? ACE. Sounds like a what? Enzyme. It's probably not over the counter. Okay, but don't get bogged down on that because that's the one they'll least test because different states are somewhat different on that. Okay, the next one is they're not allowed to do assessments except for vitals and Accu-Checks, which I think is stupid. Why do I think that's stupid? Why do we delegate the measurement of something called vital signs and Accu-Check, which can go to brain damage? Why do we delegate those two most critical, most important assessments to the least prepared person? I don't understand. I'd rather have them do my bowel sounds and pulses, frankly. My peripheral pulses and my bowel sounds. I'd rather have them listen to those than do the Accu-Checks and the vital signs. But why can we do them? Why do they do them? What's the reason? Money. It's all money. So we're jeopardizing patients to save money. I do all my own vital signs. I do all my own Accu-Checks when I'm an RN working, and I work. And I never get out late. I could count on one hand the number of times I've been out after my quitting time. I am not one of those nurses, an hour after quitting shift, I'm still there doing my charting. I never do that. Ask anybody that's worked with me. I'm out of there. I don't stay late. But yet I do all my own Accu-Checks and all my own vitals. So you can't tell me that that you don't have time to do them. You do. I think the reason why I'm out on time is because I do my own stuff. What do I mean by that? I know what's going on. I'm on top of it. Nothing surprises me. Nothing hits me at 6 o'clock when I look at the sheet and I go, oh my goodness, his blood pressure is 90/10. You see what I'm saying? Nobody told me his blood glucose was 15. You see what I'm saying? I know it. I can tell. I boom, boom, boom. So watch pots never boil. So I'm just telling you, you know, I don't buy it. So anyhow, but here's the deal. If somebody comes back from surgery and I do a set of vitals, and I do all my own set of vitals when they come back for surgery, and the vital signs are unchanged from the PACU, the recovery room discharge vitals, they're unchanged relatively, I know my patient is what? Stable. So then I will tell an aide, check them. Do you see what I'm saying? But I do it sparing when I know what's going on, and I'm checking on it. Okay, enough said on that one. Next thing, they're not allowed to do treatments except for enemas. Figure that out. Doesn't take a rocket scientist. They can do enemas, but they can't do other things. Here's the deal. Be real cautious of allowing them to catheterize. But I'm not willing to say never let them catheterize. I'm just telling you, if you can pick any other answer other than catheterize, pick the other answer. But if it would say catheterize a patient, give an IV push medication, intubate the client, and irrigate the T-tube, what would you have them do? Cath. Do you see what I'm saying? But if there's anything else that they could do, don't pick cath, because boards doesn't like a cath. One aide, I know there's one big question on ATI that was talking about what would you let an aide do, and you were between having them empty the bag on an ileal conduit continent cock pouch and versus somebody, or versus evaluating the effects of range of motion, I think it said. Everybody was freaking out between this emptying this bag they never heard of, let alone, an aide doing it, versus range of motion. But that question was not about that. The question was about doing versus evaluating. Do you see? And people missed it. So look at your verbs, not just your nouns, on your aid things. Maybe it's something like evaluating the effectiveness of a bed bath. Can they do a bed bath? Can they evaluate if no? So sometimes that verb can get you off a hook on that one. All right, did we cover all that? What an aide is not allowed to do? Well then, what is an aide allowed to do? You may delegate ADLs, beds, baths, and activities of daily living. However, they should never do the first of any of that. Why? Who does the first? All right. Now, why in a extended care facility, why are LPNs allowed to do a lot of these things I said that they cannot do? Why could they do them in an extended care facility? What is assumed about the patient clientele in a extended care facility? They are stable. And therefore, an LPN can do many of the things that I said you can't do in those settings. So keep that in mind. All right, staff management. Oh, turn the page. Do not delegate to the family safety responsibilities. Do not delegate to the family, that's on the next page, safety responsibilities. Now, what do I mean by that?
Lefty?
Who's responsible for the safety of the patient? You are. So if a family member says, would you leave the restraints off my dad while I'm here? I'll watch and make sure nothing happens, and I'll call you when I leave and you can put the restraints back on him. Yes or no? No. No. Saunders says yes. I'm telling you, no, the book is wrong. You cannot delegate safety to a non-hospital caregiver. What about a sitter? Yes, why can you delegate to a sitter? What does a sitter have to, what has to happen for them to be designated a sitter? You have to teach them, and you have to put in the chart documentation that you what? Taught them. So the second sentence is, they can only do what you teach them to do. So if you decide, and the doctor says, that the mother can give this 3-year-old kid the insulin shot, okay? Can you do it? Yes, as long as you what? Document in the chart that you taught them, you put them through the same checklist that you would do with any new grad, new hire, on competency for insulin injection. And then you put that in the record and you're good to go. But you can't just let them do it without documenting, teaching, and their competency. What if a mother says this? Oh, would you, I'm not done finishing my baby yet. This is in the nursery. Would you just leave the side rail down and I'll finish bathing, then I'll put it up when I'm done. You can leave the room and go do what you need to do. What do you say to them? No, I'll stay with you to help you with this bath, and when you're finished, I'll put the side rails up and then we'll be done. Because what will happen Does she get an in-service on putting up the side rails on a crib? No. So if she doesn't click it right and the baby rolls and bam and slam, who's going to be in trouble? You. Well, she asked me. Yeah, right. Like they're going to say, oh, then I give up the lawsuit because I asked you. You know, like that'll never happen. So you can't do it. I can't understand why that book said. Has anyone seen that answer where you're allowed to do that? What book? I mean, not book. Was it a book or was it a teacher test?
It was actually online on the website.
I know. I couldn't believe that. I mean, are you kidding me? Just unbelievable. Yes.
With someone that's like going back to the insulin thing.
Yeah.
Somebody that's been, a type 1 administering their own insulin injections. Would you want to evaluate and document the evaluated before you allow them to do it?
Every single time they are hospitalized. If a person's been giving their own insulin injections for 90 years, every single time they're hospitalized, we have to go through the documentation for competency and have it in part of the chart. I know it'll drive them crazy, but they'll know the drill. Yeah. Okay, staff management. How do you intervene? How do you intervene with inappropriate behavior of staff? How do you intervene with inappropriate behavior of staff? This is not prioritizing. This is not delegating. This is handling your staff when they do stupid things. And boards will give you those questions too. Have you ever seen that? You're a nurse manager, you're the charge nurse, you're the LPN in charge, or you're an LPN and the nurse does this and how you deal with it. Okay. Number 1. Number 2. There are always 4 answers. The same answers show up all the time. The first answer usually is something like, tell supervisor. Okay, have you seen that as an answer to these kind of questions? A staff member's doing something stupid, what do? Tell the supervisor. That's always there. Number 2, another one that's always there is confront them and take over immediately. That's always there. And a third one that's always there is, at a later date, just talk to them about it. You don't have to do anything right now. You don't have to report it to anybody. Just talk to them. And the last one that is always there is ignore it. Just let it go. Ignore it. Now, one of those is never the answer. Which one is never the answer? Ignore. Because you never ignore inappropriate behavior of staff. You always take it as an opportunity to teach and change behavior. Now, the other 3 could be right or could be wrong, depending upon the situation. So what I want to teach you is how to choose between the remaining 3 options. When you get a staff question, the first question you should ask yourself is, number 1, is what they are doing illegal? You see where I'm at? Is what they're doing illegal? That's number 1. If the answer is yes, they are engaging in illegal activity, what is the answer that you always choose? Tell supervisor. That's always the answer. However, what if the answer is no? It is not illegal. Well, then go to the next question. The second question you ask yourself is anyone, the patient or the staff member, in immediate danger of physical or psychological harm? In other words, is anyone in harm's way? Is anyone in danger of physical or psychological harm? If the answer is yes, what do you pick? Confront immediately and take over, because you don't want anybody to get hurt. Why don't you want to tell the supervisor? Yes, because delaying, confronting, in order to go tell the supervisor would put the patient at risk. So you go, right? Now you may have to tell who later on, supervisor, but you gotta deal with it right then and right there. Yes?
So if it's illegal, I'm going to cut off harm.
Yeah, if it's illegal, and we're not there yet, but you're ahead of me. But sometimes in certain situations it is both illegal and harmful. In that case, you do both, but in what order? Confront, then tell. But look at this, if it's not harmful and illegal. What do you do? Not harmful, but illegal. Tell supervisor. But if it's illegal and harmful, you do both, but first you intervene and then you tell supervisor. Good point. That's a good question. Okay, next one. What if the answer is no? Nobody is in harm's way. Well, then go to the next question, the last one. The third question says, is this behavior legal, not harmful, but simply inappropriate? If the answer is yes, what do you do? What do you pick? Approach them later on and talk to them. Just counsel them later on. No hurry, no rush. Okay, now I'm going to give you some scenarios, and I want you to tell me which one you'll pick. And I want you to ask those questions of yourself. Okay? You suspect that a nurse, you're an LPN, you suspect that an RN with whom you work is diverting narcotics for private sale and use. Well, is that illegal? Yes. So what do? Tell the supervisor. Okay. You're an LPN, you walk by the room of an aide who is giving perineal care to a patient, and the aide is not wearing gloves. Is that illegal? No. Is anybody in harm's way? Yes. Who? The aide. So what do you do as the LPN? You go right in and say, let me take over. You wash your hands, you get gloves on, and I'll help you finish. Got it? You're an LPN. You notice an RN going home every day with bulging pockets. What do you do? Is that illegal? Yeah, it could be stealing, right? So you what? Tell the supervisor. Okay, you are an LPN in the OR. You're a circulating LPN in the OR. And you notice the surgeon during surgery contaminates the pinky of his left hand. What do you do? Is that illegal? No. Is anybody in harm's way? Yes. Who? Patient. So what do you say? Excuse me. You just contaminated the pinky of your left hand. I have a glove right here for you. You see what I'm saying? You're an LPN, and an RN always gives report at change of shift, and this RN always says exasperation instead of exacerbation when referring to COPD. So the RN is saying he's having exasperations of COPD. And they're saying it over and over again all the time. So what do you do about it? Well, is that illegal? No. It should be, but it's not. Is anybody being harmed? So what would you do as an LPN? You'd say, hey, come here. Sometime later, at a good time, you'd say, hey, I noticed you're always saying exasperation. Am I wrong? But I kind of thought it was exacerbation. Now, I could be wrong, but what do you think? That kind of thing. Because remember, when you have a problem with somebody else, what do you always talk in? I, not you. As an LPN, you would say, you're wrong, you're always saying they're wrong. Not a good idea. It's okay to do that, but that's the wrong phrasing. Okay, are you getting it? Kind of getting the idea of how you're going to do that? Yes?
Question. The first example that you said was that the RN is diverting drugs. So does that imply that the patients that she's diverting skin for are not getting that medication?
No, that does not imply that. Now, if it says this, you are an RN. One of your fellow RNs was passing narcotics to a bunch of patients. You notice that he is somewhat incoherent and not as attentive as usual. What would you do? Yeah, I would. you've got illegality, and the patients that he's caring for could be in jeopardy. So you've got what you were talking about, harm and illegality. So first you would say to him, you're over here, you stay over here, you're not touching any patients anymore, and then you call the supervisor and get it going. Okay? But if they want harm to be there, don't imagine it the second degree. Just kind of, it'll be pretty clear for you. Question?
What if he was an LPN and you seen a nurse taking the patient's pill
An
in her
RN?
mouth? An RN, yeah.
Or an LPN.
Either.
So you're an LPN and you observe an RN taking a pill.
Would you confront him right then, or would you go tell the supervisor?
Okay. Yeah, I would probably, at that point in time, there could be harm. Because what is that being taken, and could it affect their care? Do you see what I'm saying? Because I actually saw them take it. Now, if they're diverting narcotics with the counts, I don't know what they're doing there. They could be just, falsifying records. But I saw them take a pill. So I go up and say, what is that pill you just took? You see what I'm saying? And then I might tell the supervisor if it wasn't something that was logical explanation, or if I thought was a problem. You see what I'm saying?
Yeah, so you'd confront him first.
You confront them, yeah.
Okay.
Even if you see a doctor comes out of the medication rooms and swallows a pill, what do you say?
What are you doing?
And you're an LPN. What was that pill you just swallowed? And even though you may not feel, oh, it's a doctor. No, boards want you to go after him. Boards just gets goosebumps when you go after doctors. They love it. It makes them quiver.
What, on a HESI test, would it be the answer the same way?
Yeah, I think so. I think so. HESI's favorite question about inappropriate behavior is not staff. Their favorite one is, you've got two patients who are engaging in sexual intercourse in a room. What do? You shut the door. No, that's the HESI answer. You shut the door and let them do it.
That's the answer?
No, that's the answer on HESI. I'm telling you.
Wow.
Isn't it? Have you had the HESI and taken that one? Was that the answer? That was the answer? Yeah. So anyhow, they love that one. That one shows up all the time. I think it's one of their favorite questions. Okay. And also, they'll say masturbation, which is you just shut the door. That's another big one. Okay, let's go to the last lecture, and we'll be done. Last lecture. Before I started, I want to direct you to the last 2 pages. Sorry, this belt is not the right size. I always have pants on the ground, so I have to pull them up. Okay, the first one is, do you see the abdomen there? It's divided into 4 quadrants. What this is about is they will ask you to point and click where you would find the organs. Where's the liver? Where's the pancreas? Where's the right kidney? Where's the left kidney? Where's the spleen? Where's the ascending colon? Where's the descending colon? You see what I'm saying? And so what you got to be able to do is click on the correct quadrant. Now they give you a little bit of leeway with this one. As long as you're in the general vicinity, they're going to count it. Now the next page, is a point and click for auscultating the valves of the heart. The aortic, the aortic, the pulmonic, the tricuspid, and the mitral, APTM. Now this one you have to get exactly over the spot. There's no leeway on this one. So the aortic is in the second right intercostal space. Pulmonic is in the second left intercostal space. At the sternal border. These are all at the sternal border. The tricuspid is in the fourth intercostal space at the left sternal border. And the mitral valve is in the fifth intercostal space in the mid-clavicular line. So let me go over those again. The aortic is in the second intercostal space at the right sternal border. The pulmonic is in the second intercostal space at the left sternal border. The tricuspid is in the fourth intercostal space at the left sternal border. And the mitral valve is in the fifth intercostal space in the mid-clavicular line, meaning the line down from the midpoint of the clavicle. So those are the things those are the point and clicks. Now the other point and click they always have is the pulses. Where's the carotid? Where's the brachial? Where's the radial? Where's the femoral? I'm not even giving you that because I think you should know that. Question?
Are they going to ask about herbs?
Herbs point, they don't usually talk about herbs, but that's the third intercostal space at the left sternal border. It's right between the pulmonic and the tricuspid. So actually it goes A, PET, M. A, PET, and PET goes down that border line, P-E-T, and then M goes off to the side, A, PET, M. But they've never asked about herbs. Question?
Is apical pulse included in this one?
Excuse me?
Apical pulse, is that included in the pulses?
The apical pulse would be the mitral area.
But
Yeah, the apical pulse would be where then? Fifth, intercostal space, mid-clavicular line. Now, go back to page 70 and we'll finish up. I have given you a lot of information, and I've given you a lot of application of that information, and that's going to serve you well. But I can't teach you everything that they could possibly ask. Because if I taught you more, they would just ask harder stuff. And if I taught that, they would just ask harder stuff. And if I taught that, they would just ask harder stuff. So where do we stop? Well, we're not getting on that merry-go-round. I'm teaching you the basic stuff that you need to know to pass. Now, you all are going to have to guess. Everybody in this room is going to have to guess an awful lot on this test. Because it is a computer adaptive test. And that is the nature of computer adaptive testing. If I took the test, would I fail? No way. It's impossible for me to fail. I could never fail this test. But would I have to guess a lot on it? Yes. Why? Because it's computer adaptive. And it would try to camp out on stuff I didn't know, which would be pediatrics. That would be the area I would be weakest in. Okay, so let's talk about how you guess. Because I want to help you out there too. How do you guess? Now, what I am concerned about is a lot of reviews give you a lot of guessing skills and guessing strategies. And that's dangerous. Because when your anxiety goes up, what do you revert to? Using fancy little guessing skills and guessing strategies instead of using your knowledge and your common sense. So, what do I want you to use first when you answer a question? Knowledge. If your knowledge is failing you, what do you use? Common sense. When common sense fails you, what do you use? A guessing strategy. And some of these reviews just tell you all these guessing strategies, and then you go to take the boards and you're trying to figure out what guessing strategy to use instead of answering the question. And it actually makes you worse. Okay? So I'm just cautioning you about these. These are what you use when you don't know what's going on. Okay, psych questions. The best psych question, if you're totally clueless on it, the best psych answer is the nurse will examine their own feelings about. Why is that the best? Why is it best that the nurse examine their own feelings about something in psych nursing? Yeah, because that way you don't counter-transfer. Remember counter-transference? The patient reminds you of your dad, so you treat him dirty because you didn't like your dad. You know what I'm saying? So you have to examine your own feelings before you're a good therapist in psych. Secondly, in psych, another really, really good answer in psych is establish a trust relationship. Why would that be a good guess in psych? Establish a trust relationship. Because if you pick something else, what would you be saying? It's not that important to establish a trust. Oh, I don't think so. Now don't use your, you understand what I'm saying? Don't use, here's where common sense should be applied before this rule. You have a schizophrenic client who has a knife who is about to stab you. What is the most important thing to do? Establish a trust relationship. Run the other way. What's the answer? Run the other way. But Mark said establish a trust. Do you hear what I'm saying about using these cutesy little rules before you use your common sense? Okay. Nutrition. I tell you what, I have to guess all the time in nutrition, particularly in those answers where they say, what meal would be good? And then A would be like baked potato, boiled bacon, and fried cheese, and a guacamole peanut butter milkshake. And the other one is a chicken tenders, green leafy vegetable salad, tofu, custard, and a slice of bread. See, you know what I'm saying? And they've got all the... Oh man, I just crashed and burned on those. But I figured out a guessing strategy that gets me about 75% right, even when I don't know anything about it. My rule is, in a tie, pick chicken. I'm serious.
I know.
This works. It should never work. It has no right working. But I'm telling you, on these nutrition questions, if answer B has chicken in it, I'm heading for it. And I get it right like 3 out of 4 times, and I'm just totally dead guessing. Of course, I don't go with fried chicken because I know that, I'm bad, but I know that's bad. Fried's no good. But if it's baked chicken, oh man, that's the meal I'm picking. Now, if chicken's not there, I pick fish. But I don't pick shellfish, like lobsters, and why? Because they're high in cholesterol. So I pick just the regular fish. The scale fish, not the shellfish. Number 2, never pick casseroles for children. If they ask you what's a good meal for this child and it's a little kid, don't pick a casserole. Tuna, tofu, and alfalfa casserole. It may be wonderfully nutritious, but they won't eat it. So don't pick a casserole for them. Number 2, never mix medication in children's food. By the way, before you mix medication in anyone's food, what must you ask for? Permission. You never Mickey Finn patient's food. Okay? And I know that when I've worked in nursing homes, and I've Mickey Finned 90% of my patients' food. But on the boards, I won't do it. Okay? Toddlers, it's finger food. It's finger food. In other words, what's a better meal for a toddler? Hot dogs and French fries, or a tofu, bean curd, and alfalfa sprout salad? The hot dog and the French fries, even though the other one is much more nutritious. See, when they give you a toddler question, it's not about nutrition content, it's about what can they eat on the run. So it may be not very healthy, but it's finger food, so go for it. I have to laugh. They always say, I love statistics and research projects, but this big research project came out of Ann Arbor. Well, I should have known already. That hot dogs and popcorn are the top 2 things that toddlers choke on. Duh! What are the top 2 things that toddlers eat? Hot dogs and popcorn. Do you see what I'm saying? If tofu squares and bok choy were the top 2 things toddlers ate, what would be the top 2 things they choke on? Tofu squares and bok choy. So you got to watch that stuff, but it's kind of crazy. Anyhow, preschoolers, leave them alone. Leave them alone. What's that mean? 1 meal a day is okay. What do you know about preschool eating habits? They eat when they're hungry, and they may not eat but 1 meal a day, and they eat the same thing every day for 7 weeks. Then they change it and eat that for 7 weeks. So what do you do as healthcare workers and parents? Leave them alone. There's no such thing as anorexia nervosa of preschool. They don't say, ooh, I look fat. No, they don't. They eat when they are hungry. Why do they not need the food that the toddler needed? Exactly. What's the growth curve of an infant? Like that. What's the growth curve of a toddler? Like that. What's the growth curve of a preschooler? That. Who needs more? When a kid went from toddler to preschool, what happened to his nutritional needs? They bottomed out. What do parents always freak out? He isn't eating like he used to. He's a preschooler. He's not growing like he used to. And parents don't get that. That when you shift from toddler to preschool, they're going to stop eating, and that's okay. 1 meal a day is okay. We have a rule at our house. You take 1 bite of everything on your plate, but you don't have to eat anything else if you don't want to. But you have to take 1 bite of everything. And if that's when you're done, you're done. My brother, who was a pediatrician who should have known better, he had kids too, and his rule was you eat everything on your plate. And you are not getting off of this table till everything your plate is licked clean. It is really, really interesting that my daughters are all perfect weight for size. I mean, they're all they could walk through the hourglass figure for the, perfect 20-year-old female frame. No, not an ounce of fat here or there that shouldn't be there. His kids are you know what I'm talking about? And I'm just saying, I have my suspicions of where that started. Because in their lives, what made them good and obedient? Food. And food was what reinforced if you were good or bad, obedient or disobedient. And so, do you know what I'm saying? And my kids' food was just food. So I don't know. It's interesting. Okay, who cares? Let's move on. Pharmacology. But I'm just telling you that for your own thoughts, okay? Pharmacology. I have to guess all the time in pharm. The most commonly tested area in pharm is side effects. You do not have to memorize dosages. Please don't do that. Don't memorize routes. Don't memorize frequencies. If you're going to do any memorization of drugs, please memorize side effects. Why? Because you are a nurse. Your job is to assess for side effects and see if things are working. Your job is not to prescribe the dose, prescribe the frequency, prescribe the route. Now, there are some where they might give you a dose that makes sense or doesn't make sense. You know what I'm saying? Like DIG, 10,000 milligrams, that kind of thing. So number two, if you know what a drug does, but you don't know the side effects, how should you proceed? Have you ever been in that situation? You go, oh, I know that drug. It's Protonix. It's a proton pump inhibitor. It prevents ulceration in the gut. And then it says, what are the side effects? And you go, oh, I didn't know that. If you'd asked me what it was, I knew. Do you see what I'm saying? Have you ever been there? You know the drug, but you don't know the side effects? Great guessing rule that will get you the answer almost 80% of the time. 4 out of 5 times. Pick a side effect in the same body system where the drug is working. Let me illustrate this. If you got a question about a drug, let's say you knew the drug was a GI drug, but you didn't know the side effects, would you pick drowsiness, tachycardia, or diarrhea? If you knew it was a heart drug, but you didn't know what the side effects were, would you pick drowsiness, tachycardia, or diarrhea? Tachycardia. If you knew it was a central nervous system drug, but you didn't know what the side effects were, would you pick drowsiness, tachycardia, or diarrhea? Drowsiness. That works so much for me. It's really, really big. Doesn't it make sense, though? If a drug is having a therapeutic effect in certain areas, it's also going to have some side effects there, too. So why would a CNS drug have a problem with your gut? You know what I mean? That's kind of the question we'd ask. What about number 3? Do you think this might happen to you? If you have absolutely no clue what the drug even is, you swear you've never heard of it. Could that happen? Okay. You're not dead yet. You're close, but you're not dead yet. Look to see if it's PO. If they said it was PO, I think you might have dodged a bullet 2 out of 3 times. At least 50-50 you're going to dodge the bullet. Pick a GI side effect. If it's PO, pick a GI side effect. That works about 50-50. And you say, well, that's not very good. It's better than 1 in 4, isn't it? So that helps me with some questions, particularly the really hard ones. Number 4, never tell a child that medicine is candy. Because if you tell them, oh, this is candy, when they go home, what are they going to think medicine is? Candy. So when you run out of Halloween candy at Halloween time, they're going to pass out Grandma's Valium. Right? To all these little kids. No, that actually happened to my brother. He's a pediatrician. He was working in Chicago. He worked at the Hyde Park Clinic in Chicago. And Halloween, he was working in the ER area. And this one little kid came in with these symptoms that looked an awful lot like tofranil poisoning. An antidepressant poisoning. And they thought, that's interesting. So then about 10 minutes later, another kid came in with the exact symptoms. And then an hour later, another kid came in. And then about a half hour later, a fourth kid came in. What happened was all 4 of those kids had gone to the same house. And there was a little kid literally passing out his parents' tofranil to all the little kids for Halloween candy because he had been in the hospital the week before and was told it was candy. So he said, I thought that was a real interesting. He got an article in the American Journal of Medicine on that one. Okay, OB. What's the ace of spades answer in OB? Check fetal heart rate. Yeah, check fetal heart rate. Med-surg. What's the first thing you assess in a med-surg situation? What's the first thing you assess in med-surg? Level of consciousness. Bingo. Not airway. Airway is not the first thing you assess. Think about a code. You're in a code. You're doing basic life support, alrighty? Or advanced cardiac life support. What's the first thing you do?
What's your name?
Annie, or what's your name, or are you okay? What's that? Level of consciousness. Then you do your A, B, C's. So ABC doesn't even win there. Okay? But number 2, what is the first thing you do? Now, what's the first thing you do in a med-surg situation if you're guessing? Establish an airway. So that will work there. Okay, let's turn the page. Pediatric guessing skills for growth and development. How many of you in here aren't really good at growth and development? You're joining me. I wish I had these rules that I'm going to give you right now when I was in peds, because I'd have done a lot better. Because my experience in peds was, particularly growth and development, I could always narrow it down to 2. And after that, I was dead. Because it seemed like 2 ages were reasonable, 2 tasks were reasonable. Here's the deal. 3 rules of growth and development questions. They are all based on the principle, always give the child more time. Always give the child more time. More time to what? Grow and develop. In other words, don't rush children's growth and development. Don't rush it. Always give the child more time to grow and develop. So let's talk about these rules. Rule number 1, when in doubt, call it normal. Now this is radically different than med-surg. In med-surg, what's the rule? When in doubt, call it abnormal, so you don't make a safety mistake. But in growth and development, when in doubt, call it normal. So what would be the right answer to the question? C. Why is the question written the way it is? What age did they give you?
6.
What task did they say? What's the problem with that question? It varies. It's on the line. So some 6-year-olds can read and some 6-year-olds can't read. So it was purposefully written to confuse you so that you didn't know what to pick. And since you didn't know what to pick, they were waiting to see if you would give the child more time by calling it normal. And that's exactly what they do. They purposefully give you ages and tasks where it could go either way and ask you what's going on here. And so you always call it normal. Now what about this? You have a 13-year-old who isn't potty trained. Did I say call that normal? But you shouldn't be in doubt. I said when in doubt, call it normal. I didn't say to call everything normal. That's using your knowledge first. Are you starting to understand that? Okay, second rule. Rule number 2. When in doubt, pick the older age. I don't know about you guys, but whenever they ask at what age should a kid be able to do a certain thing, I could always narrow it down to how many? 2. And I never knew which one to pick. When I started using this rule, my scores went through the roof, went way up. I picked the older age, not the oldest, but the older age in the 2 that it could be. So in the question here, at what age should a child be able to walk? There are 2 ages where it could be. What could those be?
12 and 14.
B and C. 12 and 14 months was it?
Yeah.
So what would you pick? 14. Because you're giving the kid more time. Yeah, some kids could walk at 12, but give them a couple more months. Are you seeing the principle? And then rule number 3, when in doubt, pick the easier task. I always got questions where they said, a kid is a certain age, what task have they mastered? And they'll give me 4 tasks. I could always narrow it down to how many? 2. And I never knew which one to pick. Once I started using this rule, my scores went way up. Why do I pick the easier task?
It's probably easier.
Because I'm giving him more time to do the harder one. Now, look at a 6-month-old kid. There are 2 tasks there that a 6-month-old kid probably would be doing, working on, or trying to do. What would be those 2 that they would be working on or trying to do? B and C. Rolling over and sitting up. Okay, so what's the answer? Roll over, because that's easier than sit up. Do you understand that in growth and development they always give you 2 right answers? On purpose. See, I thought there was 1 right answer and 1 wrong one, and I just was stupid and didn't know the difference. No, they always give you these, in growth and development in particular, they give you 2 right answers. And they want to see, are you going to call it normal, pick the older age, and pick the easier task. When you get growth and development questions, what do I want you to be chanting in your head? Normal, older, easier. Normal, older, easier. Okay? Literally, my scores on a growth and development test went from an average between 38 and 48% to 70 to 78% in a day when I started using these rules. And I didn't learn any more information. I finally figured out what they were up to. Okay, general guessing skills. Rule out absolutes. Why are absolutes not good answers?
You have to be able to apply to every situation.
Yeah, and all you have to do is find one situation where it doesn't apply and it's wrong. Now, did I say never pick an absolute as your answer? Because aren't there some absolutes that you should know? Like never push potassium IV. Never give a med to a patient unless you can identify, right? Those are absolutes and they're correct. Why can you pick them? Because of your knowledge. But I'm saying if you're guessing, don't pick them. Number 2, if 2 answers say the same thing, neither one is right. Why can it be this? I had a HESI test last spring, and it asked me about a disease I never heard of before. And it asked me, what would you see? A said increased bowel sounds. B said something else. C said borborygmi. And D said something else. Well, I immediately ruled out increased bowel sounds and borborygmi because they were the same thing. Then I figured which one of the remaining ones would be logical. I picked it and got it right. And that was just a guess. Okay. Number 3, if 2 answers are opposite, one of them is probably right. If 2 answers are opposite, one of them is probably right. Number 4, the umbrella strategy. I like this one. This one helps me out a lot. It says which answer is more global? Have you ever had the experience, and I have it a lot, on tests where I want to say all of the above, but that's not there? Have you ever had that experience? I want to say all of the above, but that's not an option. If that's the experience you're having, look for an umbrella answer. What do I mean by an umbrella answer is an answer that covers, like an umbrella, covers all the others without saying it does. An answer that's so broad that when you do it, you do all the others. So look at our example. What is the umbrella answer? B. Because if you do that, you do all the others. I was doing a test with a student that had some trouble with tests, and we ran across one the other day. It said, when you transfer a patient from a bed to a wheelchair, it was a Meds Pub test question. When you transfer a patient from a bed to a wheelchair, what's important to do? A, bring the chair as close to the bed as possible. B, remove the foot pedal from the chair so you don't trip over it. C, use safety and good body mechanics when transferring. D, lead into the bed with the strong foot. Well, all of them are correct. And I'm going, well, they're all right, they're all right. Wait a minute, Mark. Look for an umbrella. The answer was C, use safety and good body mechanics when, because all those work. Do you see how that works? I'm surprised that it works as much as it really does. Number 5, if the question gives you 4 right answers, and asks you to pick the one with the highest priority. Now you realize that an hour ago we talked about prioritization, right? What were we prioritizing? 4 what? Different patients. When you get a question that's prioritization of 4 different patients, use the rules I taught you an hour ago. However, if they give you 1 patient and ask you which of the following needs is highest priority, don't use what I taught you before won't work. That's for prioritizing different patients. What do you do here? Well, you do what I call the worst consequences game. Take each option, A, B, C, and D, and ask yourself, if I did not do this, what is the worst thing that would happen? Then the best answer is the one that has the worst outcome if you don't do it. Now, I know that sounds crazy, but let me illustrate it in the question below. Which of the following is highest priority in caring for a suicidal patient? How many patients do you have? 1. So those rules I taught you about before, do those apply? No. So let's take each answer. If you do not give him a tranquilizer, what is the worst thing that would happen? He'd be agitated. Okay. If you don't orient him to the unit, what's the worst thing that would happen? He'd get lost and disoriented. If you don't put him on suicide precautions, what's the worst that would happen? He'd be dead. If you don't introduce him to the staff, what's the worst that would happen? Wouldn't know anybody. So, of being agitated, lost, dead, and not knowing anybody, what's the worst? Dead. So what's the highest priority? Suicide precautions. So let's do it with the next one. Ask yourself, what's the worst thing that would happen if I didn't have sips of water? What's the worst thing that would happen if I didn't have pain meds? What's the worst thing that would happen if the side rails weren't up? What's the worst thing that would happen if I didn't use the abductor pillow? Not just something bad, but the worst thing that would happen. What's your answer? Side rails. Yeah, because if you didn't, what's the worst thing that would happen if you didn't do the sips of water? Not thirsty is not bad enough. They get dehydrated. Okay? If they didn't have pain meds, they'd be in severe pain. If you didn't put the side rails up, what would happen? Fall, break, hips, head, multiple injuries. If you didn't use an abductor pillow, what's the worst thing that would happen? Mess up the hip. So of being dehydrated, severe pain, messing up the hip and everything else, and messing up the hip, what's the worst of the worst? Messing up the hip and other injuries, so the side rails is number 1. Are you seeing that? Okay. You could also juxtapose C and D, couldn't you? You could say, if I put the side rails up but didn't use the abductor pillow, Or I used the abductor pillow but left the side rails down. You hear that? Which would be better? Put the side rails up and don't use an abductor pillow, or use an abductor pillow and leave the side rails down. What would be better? You get the side rails, you're getting the more hot water for the side rails down. Okay, 8. When you're stuck between two answers, read the question. Where's the clue to the answers? In the question, not the answers. So quit reading and rereading answers. Go back and read the question. You probably missed something. Okay, the last page. Right? The Sesame Street rule. You have my permission to use this rule when and only when your only remaining option is to do this. Okay, if you're at that point, what should you use? Sesame Street rule. But if you use it before then, you will fail boards. Because this is a dangerous one to use, but it's the one you use when nothing else works. Do you remember Sesame Street? 3 of these things belong with the others. 1 of these things just isn't the same. Remember that? And they'd show you 3 sailboats and a kumquat, and you had to figure out which one was different. Right? Okay. Well, right answers tend to be different than the others. Why? The right answer tends to be different than the others. Why? Because it is the only one which is correct. Exactly. However, the wrong answers all are similar because they share something in common, and that is that they are all wrong. So by virtue of that, the right answer is the most unique or different answer. So in our question below, what would be the correct answer? C would be the correct answer. All right. Number 8. Don't be tempted to answer a question based on your ignorance instead of your knowledge. And you guys say, oh, I don't do that. Oh, yes, you do. You do it. I know you do it. I want to illustrate something really quickly. Do you see this question below about amikacin? I'm going to do something here. What I'm going to do is this. I'm going to role play a student who answers that question based on ignorance, meaning what they don't know. Then I'm going to role play another student who answers it based on what they do know. But the interesting thing you're going to notice about those 2 students is they know the exact same amount. One does not know any more than the other. So let me illustrate this. Who am I right now? The student that's answering based on what? Ignorance. Okay, here we go. Here's what ignorance answers do. Which of the following is important to do in the administration of amikacin IV piggyback? Oh my goodness. Amikacin. Oh man. I knew I was going to get these stupid drugs I don't know. Why does it always happen to me? Why? I knew. Amikacin. Maxin. Oh man, I don't know amikacin. Okay. Amikacin IV piggyback. Cover the bag with foil to protect from light. What? Okay, use an IV pump. Huh? Amikacin IV piggyback. Oh, stupid Mount Carmel pharmacology class never taught us anything. Why didn't Mark tell us about this? If it was going to be on here, why didn't he mention it? It wasn't in the blue book or the yellow book. Amikacin. Oh man. Cover the bag with foil to protect from light. Now you know. If I wanted to protect it from light, covering with foil would work. And I know some drugs are biodegraded by UV radiation. I've never heard of amikacin, and I've never heard of covering bags with foil. So they probably go together. Because had I heard of amikacin, I would immediately know if you did or did not do that. And if I had heard of doing that, I would have known which drug it was, like amikacin. So since I don't know either one, This is probably some obscure fact about some obscure drug. And I'm not going to let him trick me. So I'm going to pick cover the bag with foil to protect from the light. All right, now, second student. This is going to base his answer on what? What they know, not what they don't know. Okay, let's go. What is important to do in the administration of amikacin IV pig? Amikacin, oh man. Amikacin, why do I always get these drug ones I don't know? I knew this was going to happen when I took boards. I would get all these drugs I didn't know. Amikacin, Maxin, Kiss-Mac, Amicus. Oh man, nothing. Okay, cover the bag with foil to protect from light. What? Use an IV pump. Whoa. Amikacin. Stupid Mount Carmel pharmacology class never taught us about this. Mark should have told us. It wasn't in the yellow book. It wasn't in the blue book. If it was going to be on here, he should have let us know. Man, why is this always happening to me? Amikacin. Okay. All right. I don't know amikacin. I don't know it. I can't answer this question based on amikacin because I don't know it. So let me take amikacin out of the question. See what's left. See if there's anything I do know something about. Okay, what is important in the administration of IV piggyback? Oh, IV piggybacks. I know IV piggybacks. I've given them. I've seen them given, and every time I've seen them given, 99% of the time they're on a pump. So I'm picking pump. Now, who got the question right? First one or second one? And did they know anything more about amikacin than they did? No. What did they learn about the first person? What did the boards learn about the first person? When they don't know what to do, what do? They go around covering bags in foil. What did they learn about the second person? When they don't know what a drug is, they put it on a pump. Who would you license? No, I'm serious. Who would you license? Do you see what I'm saying? But don't. See, here's the deal. If you don't know what something is, what should you do? Pull it what?
Away.
Out of the question. Read the question without it there and see what happens. I had a student that was really bad at this. I knew she finally got it when we did a question like this, and she finally said, what is important to do to teach parents of a kid going home on Pen VK suspension? And she sweat Pen VK for like 20 minutes, not really, but for a minute or two, sweating what Pen VK was. What's Pen VK? What's Pen VK? I don't know Pen VK. I don't know Pen VK. And then she looked at me and she said, oh, I don't know what it is, do I? And I said, do you? And she said, no. And she says, I'm supposed to pull that out of the question, aren't I? And I said, do you think you are? She said, yeah, I think I am. And I says, she said, should I do it? And I said, do you think you should do it? And she said, yeah, I'll do it. So she reread the question. What did it do? What did it read when she pulled out Pen VK? What's important to teach the parents of a child going home on a suspension? And she said, oh my goodness, it's letter D, isn't it? And I said, yeah. You know what D said? Shake well before giving. And that was the right answer. Do you understand? Boards will give you things you've never heard of for the purpose of seeing if you use common sense. See, if I want to measure your common sense, if I want to measure this whole class's common sense, I have to ask something about which none of you know, none of you have knowledge. Because if you don't have knowledge, what do you have to use? Common sense. So I have to ask you about a drug nobody's ever what? Heard of. A disease that no one's ever heard of. Or a treatment that no one's ever heard of. And that way I can measure what? Common sense. So when you get something you don't know, use your common sense. It's probably a really, really easy question. So don't freak out that it's hard. And that happens a lot in the first 10. Use your common sense in the first 10. Do not overanalyze those first 10 questions. Take them as though you weren't even a nurse. Say to yourself, what I think Aunt Billy would answer for this one. It's just, they're ambiguous, but they are very clear. Not clear, but they're very, everybody gets them right even though they're vague. All right? Now, last things, if something really seems right, it probably is. My point there is, do I have any gut changers here? People who go against their gut answer, stop it. You have no right to go away from your gut answer unless you could prove why the other one is superior. Not just as good, but what? Superior. So if you have a gut draw to letter B, your gut answer is B, but you think, oh, well, maybe it's C. Should you pick C? Not unless what? Not unless you could articulate a reason why C is what? Superior. Not just as good. There is a mini mark on your shoulder when you take this test. I am there. I'm sitting right there. Little mini mark is right there. And when you go to change from your gut, what is mini mark going to say? Why is that superior? Why is that superior? And if you cannot tell me why, you get your hand off that button and you pick your gut. Alrighty? So don't go. Research has shown that you change from right to wrong twice as much as you change from wrong to right. So it's a losing battle. Don't do it. Number 10, if you don't know the answer, you do know the answer, use your common sense. All right, that's it for the review. I just wanted to give you 3 parting shots on that last page. Just 3 things and then we're done. Okay, Mark, move it. 3 expectations you're not allowed to have. Do you know what fails people a lot? They get taken the test, and during the test, it wasn't what they expected. It wasn't what they were hoping for. It wasn't what they wanted. And that breeds negativity. And then that negativity affects their what? Performance. And then what happens? They fail. So what failed them? Their negativity. Where did their negativity come from? It didn't live up to their expectations. It wasn't what I expected. Well, here are 3 expectations you are not allowed to have. If you have these expectations, get rid of them right now. They are dangerous. They will kill you on this test. First expectation, don't expect 75 for the RN or 85 for the LPN. Don't expect 75 or 85 questions. Don't expect it. Go there expecting 265 or 205, depending on whether you're an LPN or an RN. Go there and prepare yourself psychologically, mentally, physically, emotionally to go for the whole maximum. You know what happens? I know this happens. I've heard people say it all the time. They say, oh, I want 75 questions. I hope I get 75 questions. They've got the whole church praying, dear Lord, let Sally have 75 questions. You know, it's on the church website. You know, pray for Sally that she has 75 questions when she takes. That's so stupid. Because what happens? When you go take that test and you hit 75 and you answer it and you hit the button and it goes 76, what do? And then you hit 110 and then and then it's 198 and then 215. You start going, what? This is horrible. This is terrible. I'm doing so bad. This is horrible. I just can't stand this. So what's entering your mind? Negativity. What happens to your performance? It's going down. Why do you fail? You failed because you had this unrealistic goal of 75. Expect 265. In fact, the longer you go, you're doing fine. Everybody says, oh, I want 75. Well, that's dumb. Because somebody said, no, here's what they say. They say, I got to 200 and I knew I was failing. That's the stupidest thing ever uttered by a human being. Because this is a computer adaptive test. If you got to 200 and you were failing, what would it have done? And if you were failing, what would it have done? Shut off. So the only way you're getting to 200 is if you're not what? Failing. You aren't failing. Now, are you doing a bang-up job? No. But who do you think you are? Who do you think? Are you God's gift to nursing? No, you're average. So you're going to be average. So do you see what I'm saying? If you get 220, if you're on question 220, what should you say? Okay, I'm still in the game. 223, I'm still in the game. 224, I'm still in the game. 225, oh, it shut off. And everybody says to me, Mark, well, when you tell me that, when it shuts off, I'm going to freak out. My reply to them is, I don't care. I do not care what you do after it shuts off. All I care about is what you do before it shuts off. So freak out all you want afterward. Don't freak out before. The reality is the same number of people, same percentage of people pass at 265 as pass at 75. And every number in between. There's this rumor out there that says if you go to 265, the percentage of people failing is like 2 or 3 times at 75. That's a person that's never looked at the statistics, the scattergrams of the test, which I have done every year since its inception. So they're wrong. And the myth about every once in a while somebody randomly gets 265 is baloney. That's baloney. If you ever heard that from somebody, that's a myth. It's not true. Everybody gets a computer adaptive test. Everyone does. And the number you get is based on your performance. Okay? All right. So don't expect what? Expect how many? The whole bit. Okay, number 2, don't expect to know everything. Why? Because it's computer adaptive. You're not going to know everything. Even if you're acing it, they're going to bring out stuff you've never heard of. So don't worry about not knowing everything. Number 3, don't expect everything to go right. What I mean by is don't expect the birds to sing, sunshiny day, you get a parking spot right up front. Sometimes you got a person sitting next to you that goes every 5 minutes. You know what I mean? Don't let that fail you. Now, you do have an option to say, would you get this snotter out of here? But do you understand what I'm saying? No, listen, think about it. Just last thing I'm going to say. Isn't it true that everybody in this room, in your program, would have had at least 3 or 4 or 5 times in your program to legitimately quit? If you'd have just stopped, you'd have been totally legitimate because it was ridiculous. But you would have had a reason to quit. Isn't that true? But what did you do? You stuck it out. Was it pretty? No. Did it get ugly at times? Did it get messy? Was it hard? But what did you do? You stuck it out. So you know what that tells me about you? Everybody in this room, you have perseverance. You have a strength of character and a perseverance to slug it out when it gets tough. Or you wouldn't even be sitting here. When you take this test, it's going to be hard. It's going to be tough. It may not be pretty. It may be sloppy. It may be messy. But you have what? Perseverance and an intense strength of character to get through that. You can get through it. And get through it one question at a time. Just answer one, forget about it, move to the next. That's how you got through school. That's how you get through here. Correct? Because at the beginning, if you thought about the whole thing, you would have quit. So, just go there. Okay, thank you for this opportunity. I appreciate all you guys. And if you see me around, just say, who can sterilize my bowel? And I'll know you can. Also, I go by word of mouth, so if you want to tell other people about the review, that's fine with me. Sure.